Can I hear her? laboratory, physician referral, and pharmacological privileges. He's completed his Bachelor of Science in Physical Therapy from Demon College, his Master's of Doctorate of Health Science in Physical Therapy from University of Indianapolis, and Fellowship in Orthopedic Manual Therapy and Musculoskeletal Primary Care from Kaiser Permanente Medical Center in Vallejo, California. He has made numerous scientific presentations and had lectures extensively in the third level, graduate, postgraduate level on diagnostic imaging, medical screening, and differential diagnosis in physical therapy practice. Dr. Ross maintained an active community-based practice focusing on patients with chronic pain disorders and has published over 200 manuscripts and abstracts related to orthopedic physical therapist practice. He served as the editor of the musculoskeletal imaging feature of the Journal of Orthopedic and Sport Physical Therapy from 2008 to 2016, and he's a manuscript reviewer for several medical rehabilitation journals. Thank you, Mike.
Thank you.
Good to have you here.
Excellent.
Good to have you back here, I guess.
Very good. Very good. Thank you very much. Sorry to be late today, but let's go ahead and get rolling right into it. So my email address there, if any questions pop up, you guys have that. And if anybody wants the actual version of the slides, you can just email me and I can get those to you instead of the PDF versions here. The objectives of the course, and I'll be completely honest, the objectives of this particular course, when we show you the data that we've gathered with respect to PTs, is really knowing when to order imaging, what's the timeliness of the imaging, and then what modality would you suggest? My understanding is that Arizona has imaging privileges. I'm a delegate for New York State, and I also saw that you guys are trying to get lab privileges as well, which is really interesting. And I wish you the best in that. We'll talk about labs this afternoon. I think it'll work if you get it. I think you'll be the first state to have it, and you should have it. And you know, we're prepared to do these type of things. And so our goals today, again, are to really help you understand when imaging is needed based upon the evidence, and then what modality is needed and what's the timeliness of that. One of the handouts that I provided for you is a handout that lists out all the different plain films that you could potentially get for a body region. And so depending upon where you are, if you're in a hospital-based system, many of these are probably listed in your EMR as order sets. If you go ahead and you order diagnostic imaging, you may see a cervical spine, you may see a cervical spine 3 view, which is simply an AP view and a lateral view and an open mouth view, right? The open mouth view is an AP view, but it just supplements the lateral view. I mean, anytime we order imaging, we always want 2 views, right, at 90-degree angles to each other for the most part, right? 2 views at 90-degree angles, and we put those together and try and figure out what's going on in all dimensions. You could potentially also have a 5 view. A 5 view series would be the AP, lateral, open mouth, plus oblique angles, right? And so why would we want obliques associated with that? Well, the obliques image the neuroforamen, right? So make sure I got the right laser here. Yeah, so the obliques image the neuroforamen. So if you think about what patient would need oblique images, if you're ordering diagnostic imaging for a patient, first-line imaging, plain films, right? For a patient with cervical radiculopathy, you would want to include the neuroforamen, right? And we'll provide a case that shows that a little bit later. If it's just garden variety neck pain, you can get away with the 3 view series, right? The AP, lateral, open mouth. And then you can also see as well that there could potentially be a need for motion films as well. And so motion films, that could be a 7 view series, right? I want all the angles, and now I want flexion and extension as well. And flexion extension films are going to be helpful to identify if there's atlantoaxial instability, right? So knowing what film is needed, right, for each particular patient based upon their signs and symptoms can be a little bit complicated, but this, I think, provides something. We've been teaching this for the military for years, and so they've been doing probably imaging for 50 plus years, and so, you know, this is something that we've put together that helps them with that. The back side of that form talks about more advanced imaging and why you'd want it, right? So plain film, radiography, x-rays, first-line imaging for most everything, right? We'll give you examples where maybe it's not the best first image. It misses sometimes things in the neck and in the wrist and sometimes in the small bones of the foot. So sometimes you'll get a negative plain film, right? But there's still a fracture there, right? And so to avoid those pitfalls, sometimes what we do, not sure about this here, is we rely on advanced imaging, right? So MRI, CT, nuclear medicine, and ultrasound should probably be up here, right? But ultrasound, we don't have it on this, but that would be for soft tissue, right? Evaluating soft tissue. MRI is going to be for soft tissue as well, brain, spinal cord, soft tissue related to joints in terms of ligaments, labrum, those type of things, menisci. CT, at least for an outpatient orthopedic population, would be for bone, right? So if you were concerned about a fracture, you got a plain film, fracture's negative, or the plain film's negative, but you're still concerned, CT would be the next level imaging. And then bone scans just look at metabolic activity of bone. So one of the reasons that we've seen it done a lot in the military for suspected stress fractures, right, where you're going to see a stress reaction, that'll get picked up on a bone scan. The other one it's helpful for is determining what the distribution of possible metastatic disease would be. So an example would be a patient who has primary lung cancer, but now they have musculoskeletal complaints. And so you could do an MRI, right, of the lumbar spine, thoracic spine, and cervical spine, but that would probably take close to an hour and a half. You could get a bone scan, right? The bone scan would tell you where those lesions are, and then you could hone in a little bit more if you wanted to with MRI or CT. Couple just papers that I want to provide. I mean, diagnostic imaging doesn't change. The principles behind it do a little bit and the evidence for it, but the basics of diagnostic imaging don't change. Two great papers by Dr. Gail Dial. This first one here was published a ways back, but like I said, this information really doesn't change. Dr. Dial was a former military physical therapist and runs the fellowship at the Army Baylor program. This was a good paper, and then he hones in a little bit more on MRI in this one, which are both really, really good. And so, you know, coming out of delegate assembly, when I was in New York State delegate assembly probably about a month ago, June 1st. And what they were doing is they were reviewing all of the proposals that are going up at the national level. And one of them was your guys. It had your lab values on there. And you guys already have diagnostic imaging, but you'd be surprised at the opposition of even physical therapists, right, for you guys ordering diagnostic imaging. There's a lot of opposition from some physical therapists with that, right? And one of the reasons for it is that diagnostic imaging has got a little bit of a bad name, right? It's got a bad name because, you know, what we think is that it's probably overutilized in most cases, right? And there's good reasons for that. The first is that the evidence base for diagnostic imaging, at least 10 to 15 years ago, was a little more incomplete than it is now. Things have definitely gotten better. Physicians, for sure, especially if they've been sued in the past, you'll see their imaging tendencies change, right? So the risk of litigation, I missed something, I should have got a film. So we see unnecessary imaging for that. And then, you know, the bottom line is that, you know, for most meds, I'll say about a third, you know, musculoskeletal medicine isn't really a heavy component in these curricula, right? They're doing other things. And so these physicians come out with typically very little training until they come into their internships and their residencies and learn about it from there. And I mentioned already about the thought of over imaging, right? Well, this paper looked at both sides of the coin. So systematic reviews and meta-analyses. And so systematic reviews, these are people who come together and gather up all the data, right? All the papers that have been published. The meta-analysis actually looks at the data, right, associated with all those papers. And I circled two different numbers there, but the top one says in about a third of cases, this related to the spine, there was no indication for diagnostic imaging and imaging was still done. That's the overutilization piece. The bigger one is that 65.6%. That means that in 2/3 of cases where imaging was needed, it wasn't performed. So those are patients who had true clinical indications for diagnostic imaging and it was not done. And so it isn't only an overutilization problem, it's an underutilization problem, and it's challenging to figure out where imaging falls with some patients, right? How many of you were here when I came a couple years ago? How many of you were here? So a couple of you. Okay, so I did change up the slides a lot from what I did a couple years ago, and so some of these slides are in there. And I'm going to say, I mean, you're never going to come to a Con Ed course where the instructor is going to tell you that they really have no idea what the heck they're doing, but I'm going to tell you, we really have no idea what the heck we're doing. Okay, and I mean that in all sincerity. And so this is a paper that was published a few years back. It was published a few years back, and it's a group of individuals throughout the world that look at trends in terms of disease, right? They look at the prevalence of disease, and they look at what type of disability is imposed on a population by those disorders. So they looked at 310 disorders between 1990 and 2015. If I was going to ask you, what do you think would be the most prevalent disorder worldwide that causes the most disability? What would you think that would be?
Okay.
So of all the things that we got, you name the disease, they looked at it, right? This is the top 10 list, right? The top 10 list. It's a little challenging to kind of interpret, but on that far left vertical axis, those are ages, and then along the top, those are the top 10. So if we want to interpret this, we'd say, if we look at individuals 20 to 24 years old, depression is the #1 cause of disability in that group, followed by back and neck pain. If you look at 25 to 29, back and neck pain begins to become the most prevalent cause of disability worldwide. I mean, if you look at the colors, you'd say, well, what do the colors mean? The colors mean if it's green, that means over that 25-year period, the outcomes actually improved. Yellow to the various colors of red and orange means the outcomes have gotten worse. So if you look at back and neck pain, these outcomes have probably gotten worse over the 25 years. And if you look at this population right here from 45 to 64, the outcomes have really gotten worse. And so there's a lot of smart people in the room. I'm just curious if you have any idea as to why this is happening. Back pain as being the #1 cause of disability, with everything that we know and have studied. And even if you look out here too, I mean, other musculoskeletal disorders, right? OA is out here, osteoarthritis. So a lot of musculoskeletal stuff. Diabetes are in here. We'll talk about that this afternoon. Depression is all over this. And you know how challenging it is when there's a true depression comorbidity in terms of treating a patient for a musculoskeletal disorder. I don't know. Does anyone have any thoughts on this as to where this might have come from? Mm-hmm. Yeah.
Sedentary lifestyle.
Yeah. So it could be in terms of what we're doing.
Study we just did a publication about non-patient lower back pain. And one of the a couple of things that came out in that study. One is that chronic lower back pain. And one of the things that came out was that about 80% of them have central sensitization. So those are phenomic changes that occur over time. And the other three things that came out as comorbidity that make it worse was past surgical history, depression, anxiety,
Yep.
as well as use of statin medication.
Yeah. Yeah.
So that's
Yeah. So there's a lot there, right? It's probably related to, in part, lifestyle. I mean, I forget what I was looking at the other day, but they showed a picture of people at the beach, like in the 50s, and it was like a packed beach with people like standing, and there wasn't like one overweight person at that picture. And I don't know what's going on, but
So I have a bunch well, I'm monitoring the chat.
Okay. Sure.
So, obesity, inflammation, inflammatory diet, lack of early intervention, sedentary lifestyle. So but secondary gain.
yeah, secondary gains might be related to, you're in a motor vehicle collision, and there's other things associated with that, right? And so, maybe the patient isn't getting as better as they think that they would. And we'll talk more about this, but I think it kind of sets the stage for where we're going to kind of go for the rest of today. And you would say that, okay, back and neck pain, number one cause of disability. Like I said, you're never going to go to a course at combined sections meeting or any of these meetings, and the instructors are going to tell you they don't know what we're doing. But this is very, very challenging. Now, I'd say that PTs are probably in the best position to probably change that trend. But I don't know if you guys know, but I mean, if you look at, let's see, what describes you best? PT member. Minimize that. I forgot where I was going with this. Yes, yes. So if you look at even some of the bigger hospital systems, let's pick like Intermountain Healthcare, you know, out in Utah. You take like Kaiser in Northern California, Southern California. They only see about 10% of patients who have back pain. And, you know, if you start looking at why those patients even got to a PT, there really isn't any good understanding as to why that even is sometimes. And so we see a very small percent of patients, and a lot of these patients we're not seeing, but the PTs who do manage these patients typically do a pretty good job with them. Not sure what's going on here now. It's challenging. I don't know how much you guys know about Zoom, but this stuff can get sometimes a little bit wonky, so I'm not sure what's happening here. Slide's not advancing. Oh, there we go. Yes?
Part of the problem is, here we sit in a medical school. For the education, there's been probably less than 10% of the medical education has to do with muscular problems.
Absolutely. Absolutely. And I'll just give you a quick story. So when I got out of the military, I took a job at University of Scranton, PA. They started a medical school there, the Commonwealth Medical School, like a block away from us. Beautiful building that they built. And the first 2 classes they let in for free. And so they took 100 people, it took them for free, but they had to stay in the local area, you know, and treat patients for a while. And so the second cohort that started, they hired an internal medicine physician, and her primary job was to teach physical exam. Now, their president was a cardiologist, their provost was a nephrologist, you know, their dean was a gastroenterologist, and so, as they should be. But she contacted us, you know, reached out to us at the PT school. We had 2 orthopedic instructors. I was one of them. And she basically said, you know, we're dealing with these students who are going out on these internships and their residencies, and everything they see with low back pain, they see as drug-seeking behavior, you know, and they're not even sure how to analyze. You know, they're out there looking for drugs, and can you come in and help out? So the first year we did it, it was on a Friday afternoon from 5 to 7. They ordered pizza, and they had a cooler of beer for the students who showed up after it got done. We had about 10 students show up. 10 students show up for a 2-hour talk, and they were students who wanted to go into orthopedics or sports medicine, that type of thing. And so the next year after that, they turned it into a 4-hour mandatory course. And right now it's 8 hours. That's all they get. It's 8 hours, right? By 2 PTs who go in there. We do 4 hours on the extremities and 4 hours on the spine. And that's it. And really what it comes down to is, what do they need to know, right, to get patients to you guys? When do they have to order diagnostic imaging or other types of special tests? EMG, nerve conduction studies, what meds should they prescribe? And when should they send them to you guys, right? And so, but that's all they get, 8 hours, right? And when we talk about to our PT students who go for an entire year, right, of nothing but musculoskeletal, then they even have a course in their second year that deals with advanced clinical decision-making, and they're concerned that their knowledge doesn't match up. And we're not trying to compare, but there's other things that physicians need to know about. We're talking about labs this afternoon. They're going to know that better than any of you will ever know that. That's what they train on. But this stuff, that's a little bit different. And so, you know, you would say, even with all of those issues, right, if we were getting better, right, seeing improved outcomes, that would be a good thing, especially since, you know, when we look at the cost of dealing with these disorders, musculoskeletal disorders not only are the most prevalent and the greatest cause of disability, but they're the costliest. They exceed these non-communicable diseases down here, like cardiovascular disease, diabetes, et cetera, cancers, things like that. And you would say, can I even put that number in perspective? So 165 billion deals with low back pain. That's about 250,000. I'm just putting this in perspective here. $250,000 spent every minute of every hour of every day, 24/7. It's $250,000 spent on this stuff. And so extremely costly to manage. And you say, I don't know about you guys, but I'm not seeing that money. Are you guys seeing that? So and I think I took some of these slides out, but the bottom line is that, when you start to talk about what these costs are from, what do you guys think? What do you think those costs are related to? I mean, yep. And so when you start talking about failed interventions, and failed intervention, that's an interesting term that you use, because when you start imaging, this is the thing that, and you guys probably know this, when you start imaging, right, you're going to see things, especially as people start to age. And the bottom line is trying to figure out if that stuff matters or not, right? If it matters or not. And so when you start to send patients down that road, right, of surgery, right, of invasive procedures, of costly and potentially harmful medications and all the side effects associated with it, and we step back and say, we only got about 10% of these folks seeing you guys, right? Probably should be more, but you'd be overwhelmed at the numbers because that's what we hear, right? But I like these couple of these little infograms we're going to put up here. So this is, I think, from the American Academy of Orthopedic Manual Physical Therapy. And they're trying to get away from using these terms like degeneration, right? And essentially look at what we call like a normal age-related change, right? Shift from degeneration to normal age-related changes. It's like anything else, right? It's the anatomic gray hair, essentially, that we see, especially in older individuals. So if you start looking at these different areas, right, you can see that the spine is probably the worst. If you image asymptomatic folk, image asymptomatic individuals, you're going to see a high prevalence of what could appear to be rather significant concerns, right? And people don't know what to do about that, right? And you look at the shoulder with respect to labral tear, the knee, the hip, we see it all the time. And so trying to figure out, right, how those findings on imaging fit, right, is really key. And I will tell you this, when you start sending these patients imaging reports, because they get them, they can go in the portals, they can read these things. And these MRIs are so good now. I mean, they come up with so much detail. Patients look at, right, these imaging reports, and it does nothing but cause catastrophization, right, and fear, right, when they read these type of things. Because the physicians, I'm going to be completely honest, aren't sure how to interpret it, right? But it's up, I think, to us sometimes, even if you're not ordering diagnostic imaging, to look at imaging and figure out where all that fits. Because, in my mind, imaging is just a data point, right? It's one additional piece of data that you're going to use in this hypothetical deductive reasoning model that we use. What does that mean, right? We evaluate, from the moment we put eyes on a patient, we have hypotheses, right? And we gather data, right, to try and either support or refute those hypotheses, right? Diagnostic imaging is one part of that, right? One part. Some patients it's really, really important. Others, it's not really as important at all, but it's there, right? And we have to deal with it. And so I thought this was an interesting paper. So this is a paper that looked at purposeful, well thought out education that we just talked about, right? Well thought out education for patients with low back pain who had MRIs, and they had rather advanced changes in their disc, right? So we'll talk about this a little later, but when you start talking about imaging, there are certain imaging findings related to this that we don't see in asymptomatic people, right? Specifically like an extruded disc, which is a really, really large herniation that's compressing nerve roots in the cauda equina. We typically don't see those, right? So these are patients who had those large herniations, right? One group got a very well thought out educational intervention in addition to their normal rehabilitation. These were all patients who were managed conservatively. And they looked at 4 different components. They looked at pain, right? They looked at the perception of symptoms. They looked at physical and emotional well-being. and the orange line is the group that got the education. So everything else the same in terms of management, just changing the education, you can see that pain dropped significantly. This is all 6 weeks, right? Their symptom perception improved significantly, and their physical and emotional well-being also improved significantly, just with purposeful education, right? Just with purposeful education. And so if you do nothing more than just review these reports, now, you always have to be a little bit careful too, because you don't know what the physicians have already sometimes told these patients, right? And you have to be careful, because if you kind of come at this from, whatever they told you was wrong, but this is right, now you add doubt into the patient's mind, which probably doesn't help the situation either, right? So all you're going to say is that these imaging findings, while very, very important to you, important to me, we're going to take them into clinical context, right? And we're going to talk our way through this, right? And help you understand that even though you have this imaging finding, right, at L4-5, all the rest of your spine looks great, right? And that's what we're going to focus on, that one level. And so just keeping it really simple, right, and helping patients understand what's going on. So the other thing we've kind of been working on, and you guys have kind of nailed it already, getting imaging, and there's probably 13 states that have it. But this study looked at surveying 4,700 PTs and looking to see, are they doing what we would call the requisite skills for imaging? And so the requisite skills that we think for imaging relate to these findings on the left. So this is a paper published in the Journal of Manual Manipulative Therapy, and they like to put these infograms out, right? And so they're a little biased, right, toward PT, right? But on that little box there, that lists out the skills, right? So do PTs triage patients normally? Of course they do, right? Do they utilize evidence-based guidelines? Do they consider risk-benefit? Do they refer, suggest an imaging modality, review the imaging reports, educate patients? Do they integrate the finding? And then do they refer as necessary? So, if you look at this, it looks like it's a good news story, right? That everything here really, really worked out well because PTs are doing this. So it's a little bit challenging to look at, but I'll tell you what this is. This looks at whether or not they were routinely doing the skills. And there were two areas that PTs struggle with. One is going to be utilizing evidence-based guidelines, right? And the second one is going to be skill 5, which is suggesting an imaging modality. So that's where PTs are still struggling. What's the evidence for what I'm doing, right? And then once I figure out if I need to do imaging, what should I do and when should I do it? So that's really what we're going to focus on today, right? Helping folks understand when imaging is needed based upon the evidence, right? And then what imaging modalities should be done, right? And so, we'll talk about it right up front, when to consider imaging early, right? And so this is based upon a whole bunch of different studies and things like that. But if you're concerned about a fracture or concerned about bony alignment, right? If you have patients with a history or potential for any of these, sinister disorders like malignancy or infection, inflammatory disorders, if they have pain, right, in addition with constitutional symptoms, things like fatigue, fevers, weight loss, right? Things like that. Bowel and bladder concerns for sure. Neurologic examinations, I think we'll talk about these probably right before lunch, but neurologic examinations are extremely important. I think, in my personal opinion, they should be done on all patients day one. We're going to talk about medical labs and why I think they're important for you guys to have those privileges. Because when you see a patient on that day 1, day 0, whatever you call it, and a patient comes in and they have a concern for something and you order those labs, right? You refer the patient to the physician sees them, whatever, 3-4 days later. Physicians look at one thing when it comes to labs, trends, right? So here's my lab on day 1, and now on day 4, I'll repeat the lab again. What's happening, right? What's happening to those trends, right? Same thing with this. These neurologic deficits, if you don't do an exam on day 1, the patient comes back a week later and now they have weakness, or now they have hyporeflexia or hyperreflexia. You don't know if it was there in day 1. You don't know the trend on that. So I would say, and we'll give you good reason for that. And then lack of improvement. Lack of improvement is interesting, right? Because at what point do you look at lack of improvement as a reason to do diagnostic imaging? And that's based upon a lot, and we'll talk about that as well. So I'm just going to let you know, let the cat out of the bag early. These evidence-based guidelines, the gold standard, are the American College of Radiology's appropriateness criteria. This is the gold standard. So you can go to Google, just type in the ACR, and you'll get, they change it all the time, but you're going to get it. And you're going to be able to go into it and look up, right, these different areas. We'll give you some examples. I don't know if I can get online here, but I can give you some examples that I put in here. It's really easy to use. And it tells you exactly what you should do, tells you when you should do it. And the cool thing is that they wrote nice papers associated with these, right? So they get a bunch of these physicians together, right? And they write the paper that really supports their decision-making associated with it. So these are evidence-based guidelines, and they continue to grow. The problem is, if you survey physicians, not radiologists, but about half don't even know these exist. They don't even know it exists. And those are studies that we don't like to do, but I mean, you do them, and if I even did it with PTs, I don't know, but this is the gold standard, right? This is it. And so if you guys look at JOSPT, JOSPT started an imaging feature, and we'll give you some examples. These are one-page imaging cases that started back in 2008. And I edited that section for 8 years, 2016, I stepped away, and now there was such a huge push. There's now JOSPT cases. So JOSPT, that's the big orthopedic journal, their main goal is to really bump their impact factor up. So the impact factor really tells individuals if it's a journal that I want to publish in. High impact factor means lots of people read it. All the impact factor relates to is that papers that are published, how many times are they cited? That drives impact factor. Case reports don't get cited, right? No one cites those. So JOSPT doesn't want to publish those anymore. They want randomized controlled trials and systematic reviews and meta-analyses because those get cited. So there's a JOSPT cases, and I'll show you an example. JOSPT cases, now for each of these one-page imaging cases done by PTs, you have to cite where in the ACR, right, that imaging was needed. Because sometimes you're not sure what to do, and you get imaging and stuff shows up, and it looks really, really good that you got this, but you have no idea why you did what you did, right? You just got lucky, right? And we don't want that. We want you to have a reason for why you're doing what you're doing. Because remember that one slide I showed you? There's overutilization, but almost twice as much underutilization for patients who need imaging, right? So let's go through a couple cases here. So this is a case that we'll talk about. So this is a 58-year-old gentleman who's seen in an emergency department, and he has about 4 to 5 weeks of neck pain that is just continuing to get worse. There's no mechanism for injury, but he woke up this morning, his neck was really, really bad, couldn't even move it. So he's seen in an emergency department, right, examined, treated with Toradol, which is an intramuscular non-steroidal anti-inflammatory drug, very, very good for pain control. And Valium is something we give people. It's actually a muscle relaxant, but we give it to them. It kind of calms people down a little bit. And 1 hour later, right, the pain was improved. And, if you give that to anybody, right, Toradol is a really, really powerful anti-inflammatory. Even if you had like a fractured ankle and you gave them that, they're going to feel better. But he's better. He's diagnosed with a neck strain. And as most ER physicians are going to do, all ER physicians that were discharged, follow up with your primary care doctor if this doesn't get better. So 4 days later, he follows up with his primary care physician, right? And now, in addition to his neck pain, right, he has pain radiating down both arms, numbness in his thumb on the right side, and he also has some constitutional symptoms, fevers, chills, dysuria, painful urination, and now pain in his legs, okay? 4 days later, physical exam, so he has decreased range of motion of his neck in all directions, and again, diagnosed with a neck strain, and he has likely prostatitis. The prostatitis relates back to the fact that he has painful urination, right? So the treatment was an oral antibiotic, a non-emergent MRI, and I don't know what the time is for the centers that you guys work in. Center we're in right now, if you order a routine MRI, it's about 3 weeks, right, to get the patient in there, right? 3 weeks, and PT. So that's the treatment, right? That's the treatment, right? And so over the course of the next 2 weeks, he continues to get worse, okay? Continues to get worse. He had 4 PT visits during that period of time. So first PT visit, they're working on his neck pain, a little manual therapy, right? A little traction, some modalities to try and calm things down. The second visit, he's coming in and now he's having balance issues. Third visit turns into them teaching him how to walk with a walker, right? And fourth visit continued to the point where he couldn't even really get out of a chair. 4 PT visits. And that's what went on during that period of time. So 14 days after the last visit, his wife says, you have to go back. So he goes back. Now he's in a wheelchair, difficulty breathing, and he can't stand. Okay. So in the ER, he didn't have this is 14 days. Remember, his MRI was probably gonna be 3 weeks out. So emergent MRI. And the MRI showed cervical epidural abscess with spinal cord compression. So on the image on your right, that's a normal MRI, right? Normal MRI, right? This is a T2 weighted MRI. What does that mean? It means that fluid shows up bright, right? Fluid shows up bright. And so here's the cord, right? Here are the vertebral bodies. This would be C2, right? 3, 4, 5, etc., right? And what you're looking for is a nice, bright cord signal, right? Anterior and posterior to the cord. We talk about plain films, right? We're going to talk about shades of gray, right? Varying shades of gray. Same thing with CT, right? MRI, you talk about signal. Things are either high, medium, or low signal, and it deals with the color, right? So on this image, right, CSF should be white or bright or high signal, right? Bone, right, especially if we look at, the vertebral body, should typically be a little bit grayer in color, right? That's going to be normally a medium signal, right? And so if you saw all of a sudden high signal intensity in the middle of the bone, that might represent a fracture or some other pathologic process. If you look at his image, right, on your left, right, you see a bunch of different things. And this might be a challenging room for some of these images to see. I don't know if we turn the lights off, but we'll get into more imaging. Can you guys see it though on the left? Okay. Well, there's a couple things. First off, you see no cerebral spinal fluid anterior posterior to the cord. So he has cord compression at multiple levels. So that's the cord compression component, right? But he also has an abscess. So the epidural abscess is this stuff right here, right? That white right there, right? So that would be the infection in the abscess right there, right? That would be the infection in the abscess. And so the treatment would be emergency surgery, right? Emergency decompressive surgery. Now, this is not able to, let me say it this way, it's very difficult to predict outcome in these patients who have a worsening neurologic profile, right? Once you begin to see that neurologic status worsening as quickly as it did on this gentleman, it's very difficult to determine the prognosis. But in his particular case, even after several weeks in a hospital, there was no improvement, right? And so you got, a middle-aged guy, maybe a little beyond middle age, but the outcome, no use of his legs, very limited use of his hands and fingers, confined to a wheelchair and needs help with pretty much everything, right? And so this was a paper that was published in a physician journal, a brief case write-up, and they looked at it from a legal perspective, right? And so we have 2 groups here, right? The plaintiff, which is the patient, and then the defendant, which would be the physicians in this. So if you were on that jury, Well, let me give you the arguments first. These are the arguments. So the plaintiff or the patient's, right? The patient, right, visited his primary care physician. He had a classic presentation of an infection, right, that should have had an emergent MRI, which revealed the abscess, allowed treatment, antibiotics, and surgery before permanent damage occurred. The defense, right, which I guess you guys would be a part of because you were kind of sandwiched in there, right? They weren't typical of an infection, and there was no way the physician could have known what would happen. So how would you guys rule? Would you guys rule for the patient or the physicians? What do you guys think? How would you guys rule? Yeah, this was published a while back, so it was a $3 million award. The verdict was $3 million to the patient. And, you know, they talk about this stuff, zebras amongst the horses, right? Do you guys know what that means? Yeah, you hear hoofbeats, you think horses, right? And that's how physicians think, right? But occasionally there's a sinister cause of that neck pain that needs to be evaluated, right? So the neck pain, they call it patchy neurologic findings, signs of infection, and bladder symptoms should have raised red flags. There's a couple key points here. So the infection is one component. So that caused a lot of the fever, the chills. But what caused the change in urination and the weakness to the point where he couldn't get out of a chair? That's the cord compression, right? That's the cord compression. And we'll talk a little more about that later this morning, but the cord compression is going to cause a whole bunch of different neurologic findings. One would be motor, right? One would be motor findings. Why do you have difficulty breathing? I think someone said it. Yep. So C3, 4, 5, I remember that, keep you alive, right? And so if you have compression at 3, 4, 5, that's going to innervate the diaphragm, and that's going to cause that problem with breathing. The other thing that's important to note is that the infection is probably what caused the pain, right? So that was this acute onset of pain. And he was working fine up to this point, right? So it shows you that neurologic compression on the cord, which had been going on for a long time, he had no symptoms associated with it. He walked into the ER, no problem, right? And for whatever reason, all of a sudden, it triggered, right, this neurologic sequelae associated with it. So there are really two different things kind of going on here at one time. And it just tells you that if you got imaging on the guy a month earlier, you'd have seen all this cord compression, but for whatever reason, it wasn't influencing. So that's why those findings you see on MRI are really quite challenging. And so, again, I put this up here. What kind of went wrong in this particular case? Well, the first thing is that the MRI was appropriate to order, but it should have been urgent, right? They blamed a dysuria because, again, upper motor neuron disorders can cause changes in urination. They cause a spastic bladder, right? We'll talk about cauda equina later. Lower motor neuron, right in the lumbar spine, that causes a flaccid bladder. Either way, you're going to have difficulty voiding, right? And so the painful urination wasn't related to his prostate, but the physician's playing the odds, right? Hoofbeats tell me a painful urination, a 58-year-old guy is likely his prostate, right? It's prostatitis. Let's treat that. And so again, the evidence base for this should have been he needed an MRI much earlier, and it needed to be an MRI. Right, it needed to be an MRI because of the neurologic cascade that he had. Yes, sir. Yeah, and we'll talk about infections later this afternoon, but they're tricky as to know why that may have happened, right? And so there's some ideas that sometimes you have trauma in an area, right? And you have a recent history of an infection, sometimes all that blood flow going to that area. But I don't think in this case there's a good understanding as to why he had it. It's a good question.
The bigger problem here is that whether it's order or not, is the fact that either the PR, maybe us and primary care, people don't do differential diagnosis anymore. They just
No.
ask you one question and try to find an answer for one thing.
That's right.
Possible problem, and that's what you've done.
That's a good point. And you think about what the PT was doing. You know, in the course of 4 visits in 2 weeks, going from, you know, treating someone's neck pain to teaching gait training with a walker. I mean, that wouldn't trigger something. You know what I mean? That wouldn't trigger something? Yes.
Question
Sure. Okay, maybe I can use this. I can maybe use can they see the cursor? Yeah, I'll use the cursor then. That'll work. That's no problem. It's no problem. No.
The patient was fine up until then, but do you think that he wrote off some of his own, "Oh, I'm 58, I'm not as strong as I used to be"? Like, did he have any indication that anything was, "Oh, I'm getting clumsier, I'm dropping things, I'm not as strong, I can't make it upstairs"? I mean, even some like basic reflex stuff.
Yeah. Yeah. But I guess you make a good point. There may have been some loss of function that maybe he just thinks is related to his age, right? Maybe he was experiencing some weakness. We don't know because we don't have the data associated with the case, but absolutely. Oh, absolutely. Absolutely. And those are, and we'll talk about what questions you should ask. In my mind, of every patient with spine-related impairments, right? Any numbness, tingling in your hands or feet or the extremities, and any changes at all in balance. Anything at all, because you have to have some understanding of when to move down that road, right? And we teach it, especially for the neck, because we teach thrust, and you wouldn't want to do any of that or any manual intervention if there's any concern over cord compression, atlantoaxial instability, et cetera. And so,
My question is, looking at the MRI, would an X-ray would have picked up enough to put a flag to most physicians as far as that? It looks like the C3, C4.
Yep.
There's an anterior thesis there, and even something basic as that goes, maybe we should have, more research on that.
yep, the X-ray would have probably showed, and I think we do have, the X-rays may have been published in there. I didn't put them in here, but the X-rays just would have showed like advanced degenerative changes. That's what it would have showed. Whether you could infer whether or not the cord was being impinged upon, you wouldn't be able to see that. And unless there was actual destruction, like you mentioned, of the vertebrae from the infection, that might have triggered something. And we'll talk about today what terms you'd see in a radiology report that would be concerning for an infection, right? So if those terms were there, that would definitely spur you on. But we'll talk about cervical spine more and what the appropriate modality should be, because normally you want to start with X-rays, right? That's what you want to start with. Let's go ahead and cover another quick one, just to give you some context here. So 61-year-old male, referred to PT 3 weeks following an L3-4 discectomy. All right, so, normally patients, if they do pretty well with these, will not see PT afterwards. He's seeing his physician 3 weeks later, right? And he's seeing PT because he's not better, right? That's the bottom line. If the patient's better, they're not going to see you. So we send him to PT because he's not better. He's got a complicated body diagram, right? So he has this intermittent ache in his low back, throbbing on the outside of his hip. He has intermittent sharp pain if he moves his leg and his groin. And the knee, this constant low-grade ache was one of the worst areas, right? This constant low-grade ache, right? And if you look at what the surgical indications were, he had severe low back pain, he had this severe left or right lower extremity pain, and he had weakness of his right quadriceps, right? So whatever a 4 out of 5 would be, right, he had it, right? So 3 would be you can extend your knee against gravity, right? A 4 would be that they really can't tolerate any resistance. So he had a weak quadricep. And if you look at his MRI, he had a large disc herniation, extruded disc at the L3-4 level. So this is it. Now, again, these extruded discs, you don't see these in asymptomatics, right? So when you see this, this probably means something. So he has a large herniation at L3-4. Large herniation at L3-4, this is the sagittal view, compressing, right? The cauda equina, these are the nerve roots here. It's not the spinal cord anymore. This is cauda equina, right? And then here's the disc herniation on a axial view. The axial view would be, the feet would be out toward you, and they're cutting the body in half, and you're looking up, right? You're looking up, right? And so, yeah, you're looking up at it. So the right side would actually be here on the patient, right? So it has a little bit of a right-sided spin to this disc herniation, and the neural frame is completely compromised, right? So this is another image right here. Here's this white that you'd hope to see for the neural frame on the left, but the right side is completely compromised, which you'd think be compressing the L3 nerve, right? Which would cause symptoms, right, into the thigh, maybe into the knee, right? So they treat the disc, right? But he's not any better, right? So he's seeing the PT. How old is he again? 61. So he's coming in 3 weeks later with a rolling walker, right, due to all the symptoms that he's having. And the PT was concerned because he could barely sit on the plinth. He couldn't even get up on the plinth because anytime he flexed his hip, it caused pain. And so his right hip range of motion, when they evaluated it, was limited in terms of flexion, internal rotation, abduction. And when they evaluated it, there was also crepitus associated with it, right? A grinding sensation. And then strength of all of his hip musculature, as well as the right knee extensors, was decreased. The kicker there is, though, that the strength of all of the hip musculature was limited by pain, right? So it was pain inhibited. His quadriceps weren't, right? So you test his quadriceps and it wasn't painful. So he did have frank quadriceps weakness, but the pain at the hip was probably limiting some of the strength as well. So the question would be, you evaluate this, what would you do at this point, right? He's going to see the PT for this, right? This is the hip, right? You're implicating the hip. So that's a capsular pattern, right? At the hip, flexion, internal rotation, abduction being most limited, which means it's likely an intra-articular hip issue. So if you had OA, those are the motions that you're going to lose first and become limited. So the PT wound up talking to the surgeon. They wound up getting x-rays of the hip. And this is absolutely incredible, right? And so right hip, right hip, right, completely gone, right? And here's the terminology they use, right? Severe collapse, dissolution, consistent with AVN, right? And an advanced, highly advanced secondary degenerative disease. And so what's the take-home message for this one? We could talk about evidence-based guidelines all we want, right? Should he have had an MRI of his back? Probably, right? But someone should look at his hip first, right? And I don't know about you guys, but this is a complicated differential, especially in these older patients, right? He's only 61, but this hip lumbar spine differential, right, for symptoms, and now you start even in some vascular pathology, right, because they have difficulty walking associated with it, right? The American Academy of Orthopedic Manual Physical Therapy is coming up in Orlando. It's a good meeting. And I was reviewing abstracts. I'm like late on everything these days, but the abstracts were due last night, right? Because they submit abstracts and they get graded out by people and then they get accepted or not, right, to present the paper. I don't know if I'm allowed to tell you guys this, but I think we'll keep it amongst the room and the recording. But it was interesting. One of the papers was patients who had a true combination of, claudication related to the spine, right, spinal stenosis, but they also had vascular disease in their lower extremities and how to manage those complex patients. So I thought that was a really interesting paper. But digressing with that, of this differential, what would have caused this to happen? First off, you always want to screen joints above and below, right? And, another thing with imaging is that the body part you'd like to image, you want to make sure that you expose as well, right? And if you can't recreate symptoms in the primary area, then you have to start looking at where could the symptoms be coming from and look at those as well. So if you go back and look at the case, and this is one of these diagnostic imaging cases that came through. So we wound up having a total hip and doing really, really well, right? But this is a case that was published in those JOSBT cases. And so one page, right? And I think it says down there that the patient did fine, right? Following a total hip. But if you read the case, when they went back and looked, right, he had a history of purse disease as a teenager. And I don't know what the appropriate terminology of that is now with, names on disorders and what happened in the past. So I think it used to be leg calf purse disease, but just purse disease now. But purse disease is essentially AVN of the hip in a kid, right, in a child. And it can be treated, but, this is a case, and I knew the authors on this because like I said, I was editing this and I was very interested in the case. So when orthopedic surgeons have this happen to them, number one, they're not happy. There's an orthopedic surgeon of the spine, not happy, especially with the fact, after the fact, you dig through the medical record and find out the person had purse disease, right? And the hip was the primary cause of the patient's symptoms. It says here he underwent total hip arthroplasty, and he wound up ambulating without a device 3 months later. So he was completely fine, 3 months later after all this happened. So all of his symptoms were related to the hip and not to that massive herniation that he had in his back, which is very interesting. Because if he had any symptoms related to the back, he would have at least had some improvement. You guys follow me? Some improvement in something, right? Even if this medial knee pain, right, was related to the back, that would have improved. Other things didn't, but nothing improved. Everything just got worse, which makes it even more complicated. Yep. I mean, at least we don't see it. I think it's like 2%. And I'll show you the data this afternoon. But if you do those scans on asymptomatic individuals, and that's like people who have nothing else to do with their life. That slide that I showed you that talks about all those asymptomatics, it's just, it's probably PhD students who are hanging out at a hospital someplace. They're probably like these medical physicists who help, design the MRI machines, and they need a dissertation. I'm around the magnet all day. Let's just grind 100 people through and let's see what shows up on their neck. But that really complicates stuff, right? Because these are people, and I'll tell you another thing, the presence of those findings don't necessarily tell you anything about prognosis. And so you could even have a person who's symptomatic, right? And they have those imaging findings, right? But it doesn't tell you whether or not they're going to get better or not. That's the other thing.
That's the point. We have to have the habit of asking all the questions.
You have to.
You
have to. You have to. You have to. And I'll go so far as to even tell you that this complex differential between the hip and the back, right? The surgeons that I work with now, right, when they see these older individuals who potentially have hip OA, right, and they even have stenosis of the lumbar spine, they go ahead and they put a needle into the hip, right? So they'll inject the hip, right, with some type of anesthetic medication, and then they'll reevaluate the patient. Are you better now that I anesthetized your hip? Because if you're better, that means it's the hip and not the lumbar spine, right? You guys follow me? To make sure they're operating on the right body part. But this is what complicates those outcomes I showed you earlier. Because this case, extremely costly, right? Extremely costly. You can think about that, right? And then you'd even ask, I mean, is there a need for all these spine surgeries that go on in this country? That's a whole nother discussion. Sure. There are. We can, and I'll show some cases probably this afternoon, or maybe, yeah, it'll be this afternoon. But we'll talk about it. But I mean, there are varying stages of it. And depending upon where it's at, the only treatment that works for it is a total hip, right? But there are others that it's not as advanced and it's there, and they'll watch it over time and hope that it doesn't progress. Because there are factors that could cause it to progress. So they'll want to hold off on those, right? And so, yeah, I think it's in here, but it's a case that we had published. Young guy, late 20s, smart guy, engineer, and seeing a really, really good PT for hip pain. And he just didn't get better, right? Just didn't get better. And he had a history of asthma that he used the nebulizer for. And that was his only thing that could have possibly caused this advanced AVN in his hip at 28 years old, right? And there's really nothing out there on that, like an oral steroid, right? We know if you take oral steroids, we know that that is a risk factor for this, but something that's inhaled, that there's like one paper on it, right? And how many people are doing that, right? For asthma, that's another one of these disorders that's prevalent, but that's a good question. And you trust surgeons when it comes to that, because they're going to be seen by a surgeon. And as a PT, again, you're looking for how is the patient trending, and at what point does it begin to interfere with function? At a high level, they can't do anything anymore. That's a great point. I don't believe there was. That's a really good question, litigation. was talking to students about that. You guys have heard of these cases where like the surgeons amputate the wrong leg. You guys heard that? Like there was one out there, you could Google it, and the guy didn't sue the surgeon because he liked him, right? And so I'd say be nice to your patients. And I was talking a couple things. Before I came out here, we published a paper, so we put out this musculoskeletal imaging exam. I was in a PhD committee, but the first author put out this, it's a rather lengthy, challenging musculoskeletal imaging exam, and we just got a second analysis published in a journal on it. But one of the things that came up was how many times are PTs being sued in these states where they're ordering diagnostic imaging, and not one case of PTs being sued. And we already know that PTs are really, really good clinically, right? Because we weren't trained to have diagnostic imaging or using meds or using invasive procedures. We didn't do that. So we rely on a history and a physical exam much more than any other provider does, right? Because once you give people imaging privileges, right, you would think that they're going to skyrocket. But as long as you maintain good solid history, good solid clinical exam, I'd argue that's not the case. We don't have any data to support otherwise. And if you looked at even my imaging over 20 years I was in the military, it just goes down, right? The more experience you have, the less imaging you probably do because you're more comfortable in your physical examination. You're more comfortable in your treatment as well. And that's why I'm a huge fan of manual therapy, because you can make changes on that patient day one, right? Test, treat, retest. If you can make changes, right, it's probably not something you need to image, right? Because they're getting better, right? Because that would be most important. I'm not sure what I'm gonna have to do. Oh, here we go. All right. So, yeah, we've talked about this already. The pathology, it's going to show up on imaging, but in my mind, it's the history, clinical exam, and probably response to intervention that's going to tell you whether or not that finding is relevant on diagnostic imaging. And so the remainder of what we'll talk about probably today for imaging is when we look at imaging, you know, and for you guys, you can order it, but it really comes down to, do we treat or do we refer, right? Refer the patient out for diagnostic imaging or a combination of both, right? That's really what we'll focus on. And so again, when to consider imaging early, we already covered this slide, right? There are clinical decision rules. We'll make sure you guys know about two that drive a lot of this. So the Canadian cervical spine rules, the Ottawa knee and ankle rule. So this is a decision rule that we'll probably talk about early afternoon, but it really relates to, you know, some very simple findings. All of these rules are very pragmatic, easy to follow. They're designed for emergency room physicians who are in a busy practice, right? And if you look at this, if you have one of these, including trauma, right? So you palpate the lateral medial malleolus, and you look at their weight bearing. If they can't weight bear, or if they have fracture quality pain and tenderness, medial or lateral malleolus, you get imaging for these folks. So that's the decision rule there. Some other principles here, I already talked about this, that when a patient knows about these imaging abnormalities, if they're not put in the appropriate context, they can lead to all different types of concerns. I showed you the paper that talked about the outcomes associated with education, pain, self-perception, physical and emotional well-being all improve, right, when patients understand their imaging findings and the true impact. And again, these diagnostic imaging, they're data points, and they have to be placed in the appropriate clinical context. Couple key things, and then we'll take a break, but diagnostic imaging, you always want to, if you're ordering for the first time, you always want to get at least 2 views, right? You always want to get 2 views, and they're normally at 90-degree angles to each other. And that sheet that I gave you provides all that information for you. When you wouldn't necessarily get 2 views would be a patient who already has, let's say, they already have imaging for their shoulder, right? But there's a specialty view called an outlet view that looks at the morphology of the acromion. If you didn't have that and you were concerned about some acromial pathology, you could get that one image, right? I just want that outlet view so I can look at the acromion, right? The morphology of that. But you would never just order that one image of its own. You'd want to get the routine views and then that specialty image that goes along with it. Typically, you want to get conventional x-rays or radiographs first. And conventional, all that means is that when it says conventional or plain film, radiography, that just means it's unenhanced. So they're not putting a contrast medium in there, right? Because back in the day when you could do myelograms and things like that, you didn't have MRI, you'd inject contrast dye, right? And you'd see where that dye goes. But we're not doing that. So they're called conventional or plain films. Shielding, request that if you're doing the gonadal region, right? For sure. You want to use lowest dose views. You know, when you think about lowest dose views, this is ionizing radiation here. And if you're just doing one X-ray, there's probably not an issue associated with it. But we do know that. Well, let me show you this picture here. So most of what we do in orthopedic medicine is going to be AP views, right? So AP views are what we normally do. And so if you think about these scoliosis views, because that's the one that we see. I went to school probably before most of you guys were born, but I remember back in the 70s, right? We'd have a couple kids who had scoliosis, have these big braces on, and they'd go like once a month. They'd be out, right? They'd be seeing the doctor, and they're x-raying these kids. And so we knew that, you know, you read the data now that there's typically thyroid and breast cancer associated with that repeated imaging. Why? Because you have to have really three things for an image, right? You have to have the x-ray machine, which is here, the x-ray machine, which is here. You have to have the image that's going to get captured back here on the film and need a patient. But if you're doing this image right here for an AP scoliosis view looking at her thoracic spine, the beam's going to go right through this area right here. So the tissues that are going to expose the most are going to be the breast and the thyroid. And cancer occurs most in cells that turn over a lot, right? So the thyroid turns over a lot, so does the breast. And so those tissues being exposed to the ionizing radiation over time could see cancer. So if you just flip the patient, right, and do a PA versus an AP view, you reduce cancer significantly in those two areas. But you're just flipping it because when that beam comes out of that machine, the first tissue that it hits is going to get impacted the most. If you flip them, right, now the X-ray is going to go through the spine first, and by the time it gets to those sensitive tissues, it's already going to be diminished a bit, the amount of radiation. And so the other point would be is that if you start ordering films for the lumbar spine, now you may know, right, AP lateral view of the lumbar spine is standard, but if you're concerned about a spondylolisthesis or a defect in the pars, the gold standard typically is an oblique view, okay, an oblique view. Now, you may think, if you go back to that form, I want the 5-view series for my patient with lumbar spine pathology, right? Because that would be an AP, a lateral. They always do a cone view. The cone view is right at L5, because wherever the beam goes through, so in this particular case, the beam's going to shoot through whatever level this is. That's where you're going to see best, right? What's going on. You're going to get distortion above and below. A lumbar spine view goes through L3, right? So you get distortion above and below. And where's the most pathology? L5S1. So they do a cone view right through L5S1. And you may say, well, I want the oblique views as well. The oblique views probably are equivalent to the gonadal region in women, probably equivalent to about 1,700 chest x-rays, because it goes right through, right, that region in women. And who gets spondylolisthesis? What population? You'll see them every day for probably about the next month on channel gymnastics for sure. So I just remember, I worked at the Air Force Academy a long, long time ago. And the gymnasts, I think there were like 19 on the team, 16 of them had spondylolisthesis or pars defects. And they got imaged every 3 months. And if you talk to radiologists, when they hear about, this is what I'm saying, if you start ordering these oblique views, radiologists know this, there's no need for that. So I just be cautious, right, when you start thinking that. A one-time deal, no problem, right? But the scoliosis views they don't like, and they don't like oblique images of the lumbar spine because of that. The other thing I'd say real quick, and Chris is telling me we got to take a break, but we will just, I just want to finish these couple slides here. The other thing is before you order imaging, because you guys can, before you order it, all I would say is if they're going to see a specialist, now can you guys just do plain films or can you just do everything? Everything.
someone does a lawsuit between now and then,
Come on,
we
F1.
should be able to.
You'll be-
All
Good, that's great. But I would say, plain films are one thing, but when you send them to an orthopedic surgeon, if this person, you know they're going to an orthopedic surgeon, they're going to redo all the plain films. You guys know that. And they're likely going to redo the imaging, even the advanced imaging. So I would just say, if you know they're going to a specialist, I would just make a phone call and say, look, what do you want me to do? Do you want me to get this image first? They may want it, and they may have a very, very specific type of image that they want as well, right? And so I would just say, develop those relationships with specialty providers, not necessarily primary care physicians, but contact the physician they're going to see and see if they want anything, because it might save the patient just a little bit of cost with respect to the imaging. And all right, let's go ahead and take a break. We'll come back with this one. I think Krista wanted me to take a break. So what time is it? I don't know what time it is. 9:20. So 10 minutes. We'll come back at 9:30 then. There's a lot of questions in the chat. There's a lot. I can answer those when we come back if you want to run them by. That's unfortunate. Huh?
All about pointing.
Yeah. would potentially cause cancer. I don't know if that's probably out there, but I think if you start looking at, I'll give you data on kids. So if you start looking at kids who have CT scans for concussion, when normally it's not indicated unless there's a possible fracture, anywhere between 3 to 5 CT scans in these pre-adolescent kids significantly raises their risk for things like brain cancer and blood cancers. CT scans. It's a lot. It's a lot. So I would say even be cautious with those oblique views, for the lumbar spine unless they're really needed. And if you talk to most physicians, they would say, well, let's just do plain films without the oblique views. And if you're concerned about a pars defect, we'll just do a limited CT at that one level. So you can do CT scan and just look at L4-5 or L5S1 if that's what you're looking at. Yeah, the one thing I'll show you is that when we talk about the American College of Radiology's appropriateness criteria, part of their guidelines deals with the amount of radiation exposure that you should know about. Yeah, it's a really good question. But, if you're doing a one-time plain film, I wouldn't, worry about that. It's repeated exposure that really relates to that, type of a concern. And so this is just an example of, one view. We sometimes hear this one view is no view. And in this particular case, this is a patient who had a lateral ankle sprain and had significant tenderness on the lateral malleolus. And I'd say if you look at that, do you potentially see a fracture? And many of you are going to say, yeah, and maybe you're thinking about maybe this line right here, right? But when you start looking at whether or not there's a fracture, right, you want to look at kind of the cortical margins. We're not going to go through the A, B, C, S, right? Alignment, bone density, cartilage space, soft tissue. We're not going to go through how you'd read a film in this particular course today, but you would look at alignment, right? And you'd look at these cortical margins to see. And I'll be honest, I think it's hard to know. Maybe you'd say this line right here might be it, but that's actually a white line, which would mean maybe increased bone density. The one thing I'll tell you is that for the ankle, remember we said you always want to start with at least 2 views, but the ankle, you always want to get 3, right? So it's an AP, lateral, and a mortise view. The mortise view is a 15-degree internal rotation of the leg. And what it does is eliminates the overlap here between the fibula and the talus, right? So you get a good look at that joint right there. And so if you look at, again, here's the 3 views here. So on your far right is a lateral view. On your far left is that AP view. In the middle is that oblique view, the oblique view of the ankle. And here you can see the fracture line right there, right? See the fracture line there. You can see the lucency and you can see the disruption of cortical margin. I don't think you can pick that up on this. So if you just did an AP and maybe the lateral view, you can see it right here, the fracture line coming down there. But if you just did the AP and the lateral, you might actually miss this right here. And so 3 views are standard for an ankle sprain. And again, so if a patient meets that Ottawa ankle rule where they have tenderness along the medial and lateral malleoli and they can't bear weight, the 3 view series is what you want, right? AP lateral and then the oblique view. And so when we talk about radiographic terminology, we break these down into 2 different components. So those terms that relate to bone building processes, and then those terms that relate to bone breaking down process. So osteoblastic, osteoclastic. On the osteoblastic side, right, we see terms like radiopaque, opacity, sclerosis, hypertrophic bone, and increased radiodensity, right? On the opposite side, if we see bone being broken down, we talk about lucencies. And if we were going to talk about this, we could say, right, there's a diagonal lucency along the distal fibula, right, along with cortical disruption, right? That lucency would be that black line kind of coming through right there that shouldn't be there, right? So there's an area of decreased radiodensity, right, along that line. And so all we're talking about, again, are whether we see increased or decreased radiodensities with plain films and CT, osteopenia as well, and then decreased radiodensity. Somebody asked about x-rays in that patient who had the infection. When you start talking about infection, you're probably going to see 2 different terms being used, infections or cancers. So you'll hear either a blastic lesion or lytic lesion. So in a report, those would be red flag findings if you hear about a blastic or lytic lesion. So a blastic lesion would actually be one where bone is being built. And so these are, this study was done looking at patients who had succumbed to cancer, but had visual evidence of metastatic disease to the spine, right? And then he did x-rays on it. So backstory was that they took these varying degrees of changes due to metastatic disease in the spine. Then they did plain films on it to see if the radiologist could tell based upon the x-ray if metastases were there or not. Bottom line is you'd probably need about 50% destruction of the bone before you pick that up. And so the question about an infection, you know, unless the infection has really eaten the bone away, you might not pick it up. But this is metastatic disease. So the point here is that the more dense a bone is, the whiter it's going to be. So this particular vertebrae right here, you can see, has significant amount of metastatic disease associated with it. And on the x-ray, you can see that the bone has now become more dense, right? It's not a positive finding necessarily. I mean, the bone's getting stronger, but just haphazard the way that metastatic disease is coming in, and for whatever reason, calcium's following it in. That would be a blastic lesion, right? It would be a blastic lesion, right? A reparative or reactive bone lesion, blastic lesion. A lytic lesion would be where we see those lucencies or bone wearing away. So a good example is up here, right? This particular vertebral body, we see two areas right here. If you x-ray it, now those areas are black, meaning the x-ray is just blowing right through it. So that bone has significantly weakened in terms of radiodensity. So now we see lucencies. Those would be lytic lesions. Lytic and blastic lesions are terms that are specifically used for either cancer or infection that's breaking down bone. And again, these varying shades of gray and radiodensity relate to an inverse relationship between the amount of density in the bone and how much blackening you see on the film. So for example, decreased radiodensity, you're going to see a great deal of darkness on the film, these varying shades of gray. And as you get to more radiodense tissues, you're going to see more white on the film. So the most radiolucent structure would be air, followed by fat, water, and bone. And then the most radiopaque would be these contrast media that we talked about. Typically don't do that a whole lot anymore, or heavy metals, right? Or any metal that's in bone. And then so this would be an example of these varying degrees of radiodensity right here. So you can see bone as being the most radiodense, followed by muscle, soft tissue, fat. So this is lipoma in the forearm here, and then air would be least radiodense. So in terms of the amount of radiodensity, air, least radiodense, followed by fat, soft tissue, and bone. And it relates to, right, the color that we see on the image. And there's a couple just films here. So this is a high-grade fracture due to a shrapnel injury. And so the heavy metals are going to show up most radiodense, followed by the bone, right, followed by the soft tissue. I like to throw these in just for a little levity. This, you know, I suppose if you're getting proposed to at Wendy's, that probably isn't great, but he slipped the ring into the milkshake. You can see it there, just for the point of radiodensity, right? The metal, a little more dense than all the other structures around. And then I don't know who this fellow's friends were, but this is probably not a good night, right? So this is a fellow who showed up at the emergency department. He was unconscious with profuse rectal bleeding, abdominal pain, and altered mental status. And they did an x-ray. And I think this is from Mexico. Those are probably Modelos in there. There's no cap on it, so it looks like they drank it. So, but bad news. But for the radiodensity part of it, right, you can pick that kind of stuff up. And then real quick, you know, when would you, that's for plain film, right? Everything we talked about there, those varying degrees of radiodensity. And then let's just talk about MRI and CT and why you would do that. And so again, the colors that you see on X-ray and CT will be the same, right? The more radiodense the tissue is, the whiter it's going to be, right? So the most radiodense we'll see are cortical margins of bone. That'll be white, right? Followed by the marrow being gray, water being gray, and then fat and air. Fat will be a little probably less black, more gray than air, right? But it's all going to be the same, right, for CT and X-ray, because it's the exact same. All CT is, it's ionizing radiation, but now you're getting three-dimensional scans associated with it, right? And then for MRI, we'll just talk about these two sequences here, but there are several, right? This T1 and T2 weighted sequence. So when you order an MRI, right, when you order an MRI, and this is probably, you know, something we should probably add more to this course because you guys can actually order stuff. You want to let the radiologist know exactly what your clinical concern is, right? You just don't want to say pain because, you know, plain film is one thing. You can suggest these are, you're going to say, these are the images that I want. But when you refer a patient to a radiologist, you're actually consulting the radiologist. That consult will be triaged and they're going to figure out what sequences are best for the disorder that you want to evaluate. So if you're concerned about an ACL tear, there's specific sequences that they'll have for that. Concerned about a meniscus, concerned about a labral tear, concerned about a rotator cuff tear. You want to be very, very specific about what pathology is in your differential, because they're going to include the sequences that are going to allow them to best evaluate for that. Because that's all they have, right? Now, if they're in a hospital-based system, they may have the EMR. They're probably not going to look at that. So whatever you give them is really what is going to probably drive what they're going to do. But these T1 and T2s, they're the classic sequences that you see, and everything else kind of works around this. The big thing is going to be fluid. And so on T2 weighted images, fluid's going to be bright. On T1, it's going to be dark, right? Air is going to be dark on both, right? Fat, again, is going to be different. So on a T1, fat is going to light up, right? And it's going to be darker on a T2. And then the same thing here with marrow and cortex, right? And so you're going to see, right, bone marrow being darkest on both, right, followed by the marrow, bone cortex being darkest on both. We'll give you a couple examples here. So on your far left is an X-ray of the cervical spine. In the middle would be the CT, and then on your far right would be an MRI, right? So this is actually a patient who has several fractures in the cervical spine. And so you can see it here at this level. So this is 2, 3, 4, 5, 6, 7. You can see this little step off at C7 right here. This is actually a patient who jumped and landed headfirst into a pool, and she had neck pain. And you can see that little bit of a fracture right there, but you want to evaluate that a little bit more, and you can begin to see the cortical disruption to bone here, cortical disruption to bone here, and here as well. And then here's the MRI of the same patient. You really can't pick up the fractures as well on the MRI as you can a CT. But the MRI is good because now I can see the cord and I can evaluate whether or not the cord or the nerves are impinged upon. And so it depends upon what you want to look at, but CT, best for bone, right? MRI is going to be best for soft tissue evaluation. This just describes what we talked about before. And T2 will always be included. So when you hear about there's a really bad bone bruise, right, associated with an ACL tear, you may have heard that, right? That's because they see it on the T2s. Because water, right, bleeding lights up like a Christmas tree. So they can pick that up really, really well on these T2s. That's going to show pathology really, really well. And again, our T2 and T1 weighted images, T1 on your left, T2 on the right. And if we look at the cerebral spinal fluid, you can see the fluid shows up dark, right, on the T1 weighted image. On the T2 weighted image, the fluid shows up bright. Fat is going to be much brighter, right? The cortex is going to be, or the marrow is going to be bright on the T1s. Here's the fat out here as well, subcutaneous fat, right? And you can see it a little bit darker on the T2 weighted images. And so these are used together in combination to help make a diagnosis. So these little mnemonics that are out there, right? T2, water is white on T2, right? And then T1, fat's bright and water's gray. Those little mnemonics. And MRI, again, best for soft tissue, and then CT is going to be best for bone. CT can also evaluate the chest and abdomen, again, because there's varying amounts of fluid, so you can identify the anatomy in those. And for initial CT, again, you're looking for a bleed, which would be fluid in the brain. You can pick that up on a CT. MRI would be best to look for areas of ischemia down the road. And again, the advantages of MRI are that it provides outstanding anatomical views of soft tissue and neurology. Disadvantages are that it's more expensive. It's about a half hour, 20 to 30 minutes in the magnet for a scan. It's not available everywhere, and you can't pick up bone trauma as well. The other thing that's important to know is that there are some contraindications for MRI, right? Most still, if you have any metal, right, a pacemaker, aneurysm clips, things like that, that can't go in the magnet because it'll get pulled away. You can just go on YouTube, right? And you can type in, metal and a magnet on an MRI, and you can see what kind of happens, how that they'll sometimes put a metal chair, they'll turn the magnet on, the metal chair will just start pinging off the walls, right? Going crazy. Sometimes they'll put on the little thing that slides the patient in. There's Google images. I don't want to put them up here because they say bad words when they say holy, when they put a giant watermelon on the thing and they turn it on, put a little bit of metal in the watermelon and see what happens to the watermelon, how it gets smashed. And so it's a magnet. I mean, that's exactly what it is. But, it's pretty safe for everything else, except for, like I said, metal. And this is a good example here. This 72-year-old fella was getting an MRI for ear and sinus problems. And while he's in the magnet, right, he started to have pain, right? And he started to cough, and he coughed up a nail, right? And the CT scan that was done a year earlier, which would show, and even an X-ray showed this was the nail in the guy's head. The CT scan showed it, but you can't do an MRI for the metal, right? So when you go in the magnet, two things happen to metal. Number one, it heats up, and number two, it gets pulled. So he coughed up this nail. And I always think patients, I never believe patients anymore, anything they tell me. He says he had no idea how it got there, right? He has no idea how it got in there. Now, how would you not know that you have a nail stuck in your face? I have no idea about that. And there's the nail right there. I get a kick out of this picture right here with the doctor, right? Who did the MRI on the guy and cut the nail loose. But yeah, so the other thing is if you work with so we actually published a case a few years back. It was a young soldier who we were concerned about meniscal pathology. Blew right past the MRI or blew right past the X-ray and just went to an MRI. He's in the MRI machine. And the only thing with MRIs is that with metal, the images will be completely distorted. So he had shrapnel in his knee. So while he's in the machine, right, the shrapnel's heating up, and he didn't even know he had shrapnel in his knee, but the metal's heating up and it's also getting pulled. So it's very, very painful. And so when you did the X-ray first, so if you have any patients who have any concern over any metal, this could be like welders or metal workers, you always want to do a pre-screening X-ray. And remember, X-ray and CT cannot be done in women who are potentially pregnant. Okay, so be very careful with that. In most military centers now, if it's a woman of childbearing years, they don't take their word for it. And so they go ahead and the X-ray, right? So the X-ray is contraindicated in women who are pregnant. Most places will do a pregnancy test, but you have to make sure that these women aren't pregnant, right? So that has to be done. MRI, there's a question mark. Risk benefit, right? No one's done the study to determine if magnets are safe in women. Because think about how you'd have to do that study, right? You'd have 100 women who are pregnant, 50 get MRI scans, 50 don't, right? 50 don't. And then you'd follow the babies down the road to see, are there any differences, right, in the development of the baby? That study can't be done. So most physicians will say, if it can wait till after the pregnancy's passed, go ahead and do that, right? But if it's needed, you have to get it, right? So we don't know the risk benefit. Yes, sir. Question?
History on a patient over concern for contraindication.
Yeah, so I think you'd want to ask them, do you have a pacemaker, any metal associated with any part of your body? If it's like a total hip, and you're doing a cervical spine, that's okay. That hardware in the hip isn't going anywhere, right? And it's so deep that it won't be affected. But it's the more superficial stuff. So I think just looking at that and doing your due diligence before you send a patient for imaging. So like I said, if you're sending a young woman for diagnostic imaging for X-rays, right? You want to make sure she's not pregnant for sure. For the MRI, and some of these MRIs now are really, really slick. They even have bypassed some of that, right? Where you can still do some of this stuff, but most of these are still contraindications. So any metal at all in the body, if there's any concern, you just let the radiologist know that there's concern for this. We still want the imaging because they'll do a pre-screening x-ray in the area first. That's all you'd have to do. But you should probably get an x-ray first on most of these, right? And we'll talk a little about that. So let's go into the cervical spine. So the one evidence-based guideline that we have for the cervical spine relates to Canadian cervical spine rule. The good news is that when you begin to look at patients following trauma, only a very small percent actually have significant trauma associated with these injuries or significant injury associated with the trauma. Another question? Yeah.
They affected by MRI.
Those will be okay. Those will be okay because they're locked in. Yeah. Dental implants would be likely okay. Yeah. And again, if there's concern about it, you just let the radiologist know that the patient has that. But as long as they're locked in, you're okay. Yep. But the Canadian cervical spine rules are good because they're very, very sensitive. And what does sensitive mean? Sensitive means that if it's negative, you can rule out the need for the imaging. Okay. They're not specific though, meaning that just because they're positive on the rule, it doesn't mean that they're going to have a fracture. So these are all designed, and you figure out, I live like 5 minutes from Canada. Canada, very interesting country, very nice people, socialized medicine, and the government pays for everything there. And so you're not going to find an Arizona cervical spine rule because in this country, we like to profit from healthcare, which is always interesting. Insurance companies like to make a profit. And so it's a little bit different. But the Canadians are concerned about, and there's a couple hospitals that think they're Canada too, like the Pittsburgh folk. UPMC, University of Pittsburgh Medical Center, they think they're Canada, right? Kaiser thinks they're Canada. Intermountain Healthcare thinks they're Canada a little bit, right? It's groups that, they're HMOs, but they're trying to save as much money as possible, right? And so in this particular case here, these rules are designed to allow the physician or you to proceed with confidence that a fracture is not there. So the rule starts basically if they're older and they've had trauma or a mechanism associated with it or paresthesias, you get imaging, right? And then so if the person comes in and again, they're older, I put down the dangerous mechanisms on the next slide here. Falls from probably more than 3 feet or 5 stairs, 100 kilometers is around 50, 60 miles per hour. You can look at these make sense that if a patient tells you they had this, right, they're going to likely need imaging. But if none of that's present, so they're not older, they don't have a dangerous mechanism, and they have no paresthesias, you look at that middle box, right? Was it a low-speed motor vehicle collision? Was the patient sitting in the ED at any time? Were they ambulatory at any time? Was there a delayed onset of neck pain? Meaning that my injury, my MVA, was last week, Tuesday. It's now Friday, and now my pain comes on Friday, right? That's not how fractures typically work. Fractures typically work, you have the trauma, and then you feel the pain immediately after that, and then you want to palpate. So if these are present, right, if any of these are present, you can then proceed to evaluating range of motion at the neck. So that absence of midline C-spine tenderness is another one. So you're supposed to palpate the cervical spine. And if it's absent tenderness, now we typically have thought about palpation, I think. We look at range of motion first, right? And then we palpate, right? But in this particular case, you're ruling out a fracture. So, and then if they can rotate to 45 degrees in either direction, there's no fracture, right? There's no fracture. And again, it's 100% sensitive. So if a patient, again, they're younger, don't have a dangerous mechanism, they don't have paresthesias, and any of that middle box is present. So they're sitting, they're up walking around. Then you palpate, right? And there's no tenderness, fracture quality, right? Because you guys could stick your thumbs in anybody's neck and probably cause pain. But fracture quality pain is a completely different entity, right? Completely different entity. And then if they can rotate to 45 degrees, you don't need plain films. And again, that 100% sensitive means that if they have any of this stuff, you don't need radiographs. There's not a fracture there. The specificity number, what that means, 43% specific. All that means is that less than half of the time that if a patient meets the rule, they're going to have a fracture. So just because they meet the rule doesn't mean they have a fracture. When the rule was originally published in 2001, it talked about radiography as being the primary screening tool, right, to evaluate for a fracture. But I'm going to go ahead and show you a case here, and we'll talk through this a little bit. So this is a 63-year-old woman who's retired, and she had a chief complaint of neck and left upper extremity pain after a fall 2 weeks prior. So her fall was, she was feeding her cat, right? And she was leaning forward with a water bowl and a food bowl, and she slipped and bent forward, and her head hit the wall when she was trying to set the water down. She lost her balance, so her head hit the wall. So that was kind of what she described as her fall. Now, you might say that's not necessarily a fall, maybe more of a slip, but she leaned forward, didn't want to drop the food or the water, and hit her head on the wall. Okay. And so she was seen by her PCM after that, right? And radiographs were done. I'll show you that. All it said was C4 to C6 DDD, degenerative disc disease, but her pain was significant, 9 out of 10. And if you look at her range of motion of her cervical spine, it was decreased, right? Cervical spine was decreased, and she also had left shoulder pain as well. Strength was decreased through her entire left upper extremity. And when you palpated her, especially her upper cervical spine, there was intense pain, and there was also muscle spasming as well. And so if you look at her body diagram, right, this intermittent sharp pain right here, that was the worst. And then she had this constant low-grade ache through her neck and through her upper extremity. Now, should she have had imaging done? I'll ask you that. Was imaging needed for her? Yes. Now, if you look at the dangerous mechanism, I'm not going to say I'm holding a thing of water and food for my cat and I fall forward, hit my head. But she's 63. And why is that 65-year-old age important? Because we're talking about metabolic bone disease, right? Bone begins to weaken. And so there's a confidence interval around that. So don't be so strict as, well, she's not 65. She's 63, right? And we know that postmenopausal women probably have a little more of a concern for metabolic bone disease. And so she should have had imaging. And so you might say the imaging was done and it was normal, right? All they said, and I had the report, C4 to C6 DDD, because there's still centers out there that do plain films on a computer, right? But they still do hard copy films. That's what this woman had, hard copy films. She actually brought them to the PT, okay? And so I don't know if you would look at films or not. I don't know, show of hands, do you look at images for your patients? I would tell you you should. I would tell you that you should. Because remember, we're supposed to be the provider of choice for musculoskeletal care, non-operative musculoskeletal care. Now you'd say, well, what about it? Yeah, you could treat patient, but non-operative musculoskeletal care, we're supposed to be the provider of choice. Now, who's the true provider of choice for all musculoskeletal care? Probably an orthopedic surgeon, right? Tell me one time an orthopedic surgeon would never look at films. They're always going to look at films. They're probably going to redo the films, right? So they're definitely going to look at films. So at least look at the report. If you have nothing else, but you want to look at the films if you can. So when you look at her films, this is what her films were. This is it. And here's your C4 to C6 degenerative disc disease, right? The space is diminished between the vertebrae. That's all they saw. That's all they saw. So based upon what you see with her presentation, what would you guys do? I mean, that's what this comes down to, right? I mean, you know, number one, did she need imaging based upon the evidence? Probably. She was older and she hit her head and she probably needed imaging. But then was this the appropriate image to get? To start with x-rays, well, I already told you that when this came out in 2001, right, published in whatever it was, New England Journal of Medicine, where they published, or JAMA, right, their go-to image was plain film radiography at the time. But in this particular case, that was done, but these films are not able to be read appropriately, right? So they're completely underexposed. Because they're underexposed, limited clinical utility, you should know that the number one reason for lawsuits is imaging that's done where the films are either under or overexposed, right? And so even though you get images, make sure you look at them and make sure that they're quality, right? Because sometimes that happens. In this particular case, all the radiologist says was pain, or I'm sorry, the primary care doc, his referral was pain. If it would have said, this is a 63-year-old woman who has severe neck pain and upper extremity pain following a fall, please evaluate for a fracture, they probably would have redid them, right? But all they got was pain. So it could have been a woman who just had garden variety neck pain. So anyways, the PT contacted the physician. Emergent MRI was ordered. Why? Significant trauma, right? Constant neck pain. It was worse at night. She also had some symptoms up into her face. And then she had significant cervical spine motion limitations, and she had positive neurologic findings, right? So this is kind of a stocking glove distribution, right, through her entire upper extremity. And she had strength decrease in her left upper extremity that was not necessarily associated with pain. So she had weakness through her entire left upper extremity. So what would be the next imaging modality that you'd recommend in this particular case? Because there's concern over a neurologic issue, right? MRI would be the way to go. If she didn't have neural findings, you could get a CT because you want to evaluate bone. But in this particular case, what we see is this area of increased signal. This is a T2 weighted image. I told you that bone typically is darker on this image, but that area right through the odontoid right there, that area of increased signal is consistent with the fracture. Does she have any cord compression? At least not on this image, right? Because you can see CSF anterior and posterior to the cord. You'd say, well, maybe she has a little disc herniation here, right? This would be C4, C5, 6, maybe a little disc herniation there, but it's not abutting the cord. So the cord does not seem to be, right, compressed in any area. If you look at the CT scan, so here's your CT scan. So this is what this looks like when you do these axial CTs. So here's the odontoid, the anterior arch is C1, right? And you can see the fracture line right through there. So the fracture line is much easier to see on the CT. Like I said, all you see is this area of increased signal right through the odontoid there. And so in this particular case, you went on to have surgery. And looking at the rule again, is radiography the go-to image first if you're concerned about a fracture? If you look at the ACR and you look at how these shake out, so this is what you see. And so if you go to the American College of Radiology appropriateness criteria, you're going to get these charts that look like this. And so if you look at variant 1, right, so age greater than 16, less than 65, suspected trauma, right, but imaging is not indicated. Nexus is another clinical guideline, and CCR is a Canadian cervical spine rule. So imaging not indicated. This is what you'd expect, right? Here are all the possible procedures you can do. Nothing's appropriate. If they don't meet the rule, there's no need for imaging. And who asked about radiation? This shows you the amount of radiation associated with each type of scan. What if you have suspected trauma and they meet the C-spine rule, but there's no neurologic findings? The go-to image would be CT scan, right? Why? I already told you this, that X-rays are a screening tool, but screening tools are supposed to have high levels of sensitivity. What do I mean by that? That means that if you're screening for pathology and you get a negative finding, you're comfortable in ruling out pathology. We know that's not the case with X-ray. X-ray misses fractures all the time. Where? Wrist, neck, ankle, all the time, right? So that's why they recommend a CT scan as being the initial modality. So when you guys say, come September, right, you can assess with anything. If you have a patient who meets a C-spine rule, because they may see you first, right, you get CT scan. You get a CT scan. Because there's a chance that they X-ray the neck and it comes back negative, there's still a potential for fracture there, okay? You'd say, well, what about the ankle? A bad ankle sprain, and I'm concerned about a fracture. X-rays come back negative. What does the radiologist typically say? If you're concerned, bad ankle sprain. We didn't see a fracture today on this scan, but if clinical symptoms persist in 7 to 10 days, consider re-imaging, right? So if you think you need to get a CT scan for an ankle, I would say put an air cast on them and offload them for a couple days and see how they feel. If they're still really, really sore 2 to 3 days later, it's probably a fracture. And if you go ahead and do the x-ray, then now you're going to see the fracture likely there. But for the neck, can't do that because there's too many sensitive structures up there. Here's the variant that shows if there's neurologic concern. So if you have a patient with trauma, they meet the rule and there's spinal cord or nerve injury concern, right? MRI would be the first study that you want to get because it will show fractures, not as good as CT, but now we can see the cord and we can see the nerves, right? Yes, sir.
For a moment, in relation to fracture, you know, that there's
Yeah.
they may not.
Yeah. And I think if, you know, and we think that there has to be some time for the injury to the fracture to displace, right? And so even if you get a patient who has suspected trauma, right, and you image immediately, right, you may not see that. It's going to take time for the fracture to develop, right? You're going to need time to see that lucency, right? And that's why that even if you're talking about an ankle sprain and you image them the same day, you may not see it, right? You may not pick it up. It takes time for that to displace. And that's why if you talk to radiologists, ankle's a good example, 5 to 7 days, re-image it. Because what's going to happen to that fracture site? Osteoclasts are going to start to go in there and clean it up. Osteoblasts are going to start to form to start to heal it. That's what you're going to see on a plain film, even in a short period of time. It's a really good question, though. But I think when you start thinking about using these higher level imaging techniques sooner, the chance of you missing a fracture is going to be much less. Any other questions on that case? Yes. Yeah. So, yep. Should you do, if a patient meets the rule and you need imaging, and this is the other thing that students always want to sneak in. Well, before I send you off to get that, right, let me show you cervical retractions. No, put them in a collar, have a couple collars around your clinic, right? Put them in a collar and make sure they're imaged. Should they drive themselves? Probably not, because there's vasculature there too, right? That could potentially be implicated, right? And so, you know, you need to make sure that if you're concerned about a cervical spine fracture, that they're taken care of appropriately. So the first line imaging is going to be CT. Where would you get yourself into a jam, litigation wise? If you ordered plain films, the plain films came back negative and the fracture was still there. That's an easy one. Because all they have to say is what? The guidelines suggest if they meet the rule, CT scan is what's indicated. You could get radiography if nothing else, may be appropriate, but usually appropriate. The first one there is going to be the CT scan. So that's how you get yourself into a jam. You start treating a patient who has a fracture, you know, conservatively.
Patient has an automobile accident. He goes to the ER. The first thing they do is run him down to the
That's right.
radiology. And you know, you're saying in a sense that it's really not appropriate within
X-ray?
hours of the incident.
The x-ray you're talking about?
Yes.
Probably not. We'll talk about the scaphoid. Scaphoid fractures are missed all the time on plain films. So are some injuries in the foot. Yeah. I mean, x-rays are not sensitive, meaning that just because they're negative doesn't mean you're ruling out fractures. If a fracture's there on x-ray, it's there. Just because it's not there doesn't mean it's not there. We call that a false negative, right? False negative. Yes, sir.
Do you see in the future, whether it's ACR guidelines, CCR Nexus, anything like that, with the emerging data with MSK ultrasound for
Yes.
sensitivity, specificity on stress fractures and fractures alone. Do you see those changing anytime soon?
I think so. Yeah, musculoskeletal ultrasound can pick up fractures. It's not the first line imaging for it, right? So if you go to the ACR and you say, well, let me take a look at what the best thing would be, it's not going to be that. But if that's all you have access to, if that's all you have, because there are PTs who do this all the time and have them in the clinic. We have them in our clinic. And so you can pick up fractures, but it's not the best modality for it. But if it gets picked up, then you'd want to go ahead and still go ahead and get those next line imaging. But just because it's -2 doesn't necessarily mean, but it's pretty good for fractures. I think you're right. I think it probably will come up. That's a good point. Yes, sir.
Sorry, do you ever recommend ordering x-rays for the neck, the wrist, or the ankle?
Yeah, I think if you're looking for other conditions that we'll talk about, so if you're just evaluating, I'll show you a case right now. If you're evaluating for cervical radiculopathy, you're concerned about that and you want to get plain films. Yeah, but for trauma, right, for the neck, CT would be the first image you should probably consider. Because if a CT is negative for a fracture, you can be 100% confident that it's not there. And that's what you want to be able to do, right? Rule that out because of the sensitive structures. Yes, sir.
We're seeing a lot of these young kids, especially teenagers, that are playing soccer,
Yes.
and all of a sudden their cervical area is hurting and they're running them in for, where's your opinion where we should?
Well, I think, are you talking about like a concussion type of thing or just neck pain? Yeah, I mean, young people, you need a lot of force to fracture somebody's cervical spine in a kid. You do. So I don't know if soccer would do it. I'm not in that literature and the amount of soccer injuries that cause fractures of the cervical spine. I can look it up over lunch and see. But I think, over time, you can think about maybe some degeneration in the neck just because of the trauma associated with it. But if they meet the rule, right, you go ahead and you do it. So they have whatever happened playing soccer, playing football, right? They had trauma and they can't rotate their neck to 45 degrees. Go ahead and get imaging. Yeah. Go ahead and do it. Yeah, that's what it's there for, to rule out those significant pathologies. So here's a good example of why you might start with plain films. 52-year-old physician. He has mid-back pain times 3 months. And he has paresthesias into his middle finger and tricep weakness for the last 2 weeks. He likes to exercise and doing his tricep pushdowns. He notes that his right triceps has gotten weaker. And he has this area tightness right there in his periscapular region. The onset was 3 months ago. He fell asleep in a couch in the surgical waiting room for physicians, surgical restroom, in right cervical side bending. He's a golfer and he does exercise 3 days a week, weights, stationary bike daily. He has thoracic spine films normal. C-spine films are pending. And so here are C-spine films that you see. There's no report yet. The one thing I'll tell you, though, is that these areas of thoracic spine pain, right, you can evaluate the thoracic spine, but this is classic, right, for cervical referral. We call these Cloward signs. Is anybody familiar with these? These are pretty cool, these Cloward signs, because Dr. Cloward was a neurologist back in the 40s and 50s. I think originally he was from Hawaii, but he hung out in San Francisco. So San Quentin was still a big prison there. And so he would go to these prisoners and offer them like a gigantic steak dinner, big thing of iced tea, the salad, the baked potato, if you could probe their neck, right, with a needle and probe the disc, with minimal anesthesia, probe the disc, probe the periosteum, probe the ligaments, and determine what type of symptoms the patient had. So this study came out by probing the disc and injecting the disc. And what he noticed was the patients didn't complain of neck pain, they complained of these periscapular symptoms. So this is classic cervical spine referral, right? So the patient that we have, his main concern is that thoracic spine pain, right? So they ordered thoracic spine films, which are negative, but when you evaluate his neck, right, it's likely it's coming from his cervical spine. Plus, he also has tingling into the middle digit as well. right, which would be consistent with radiculopathy. So here is the lateral view. So normal on your left, on the right are his films. You can see C6 and C6-7. There's significant change associated with that level, right? We have some anterior osteophytes. We also have some decreased disc space associated with that. That would be consistent with degeneration, probably the normal aging process for him as well. But he has symptoms into his hand. So the oblique images would probably help. Here's the left side, the neuroforamen. So all this is at 45-degree angles. So now we can see the neuroforamen right here, which are kind of nice. And then we can look at them here as well. And what you notice at that C6, C7 level, what do you note with that neuroforamen? Stenosis and bony encroachment into that. So he had a pacemaker inserted, so he couldn't have an MRI, but we did get a CT scan on him. So this is that single level CT at that one level there. So again, his feet are away from you and you're looking up. So this is actually that right side right there. And you can see that neuroforamen has bony encroachment. That's the facet joint right there. So facet joint hypertrophy, and is this bony encroachment coming in there as well? So the question is, how would you go ahead and treat that, right? So in his case, we gave him one of those little home traction units that you have with the bicycle pump, which works really, really well. And he used it a lot. Like he used it, he said, like 3-4 hours a day. Gave him a steroid dose pack as well to calm things down. So if you talk to neurosurgeons, they're going to tell you that neuroforamen, the nerve probably takes up a normal nerve, probably 20 to 30% of that neuroforamen. But if you have encroachment, right, from soft tissue or bone, and the nerve begins to swell, now you have a concern, right? Now you have a concern. So if you look at this neuroforamen right here, that nerve was likely being compressed. That degenerative process took place over a long period of time. But when he fell asleep in that right side bending, what happened to that foramen? Closed down and probably encroached on the nerve, irritated the nerve, and caused the symptoms associated with it. So I think that gives you an example of how plain films can be used in a patient without trauma. A couple things I'll mention real quick here. So how do you diagnose cervical radiculopathy? The gold standard would be EMG nerve conduction velocity testing, but there's also a cervical radiculopathy clinical prediction rule. If you treat all neck patients the same, this doesn't matter. If you think patients with radiculopathy should receive a little bit different treatment, right, than patients who don't have that, this would be important to you. And so we look at upper limb tension test A as being positive, cervical spine rotation less than 60 degrees to the involved side, positive Sperling's test, and then if you traction the neck, the patient has decreased symptoms associated with that. Here's the upper limb tension test. Here's the Sperling's test. And so if you have 3 out of the 4, the probability of having radiculopathy is 65%. If all 4 are present, right, it goes up to 90%. And so these rules are nice because they don't require diagnostic imaging or electrophysiologic testing. And as a PT, you can do this, right? Look at these rules and see, and then implement your care for that particular diagnosis. We'll give you one more on the C-spine. And so this was a 65-year-old retired male, avid golfer. And why he's coming to PT is that he feels unsteady over the last couple of months with his follow-through with golf. No heavy household ADLs outside of normal, stuff that he does, and he wants to play golf. And if you look at his body diagram, this is actually what the PT did. So he has low back pain. There's an ache, sore, right? The check marks mean there's no symptoms in those areas. He also has a shooting pain, right, into his left groin region. And his worst pain, right, this P1 area, is this cramping, swollen feeling, and maybe even possible numbness down his leg, okay? Per the patient, increase in P1, possibly related to P2. So these two are related, but they're not related to P3. What does that mean? It means that if his back pain gets worse, that doesn't change the symptoms in his leg. If his back pain gets better, doesn't change the symptoms in his leg. So anytime you have multiple areas of symptoms, like in the spine and the extremity, you want to know if they're related, right? So if I ask that physician with that Cloward point, when that Cloward point really begins to act up, what happens to your hand? My hand starts to throb, my numbness and tingling gets worse. That means they're related, right? If he says the Cloward point acts up and there's no change in my hand symptoms at all, and the two are completely independent, you could have two potential things. T-spine can refer in that area. You guys follow me? And so in this particular case, these symptoms in the lower extremity were not related to the lumbar spine. So he had diagnostic imaging done. I'll give you a little more information here. That P1 in his low back, right? He's had it on off for the last 3 years. Low back pain. He thinks the low back pain, I'm sorry, P1 is related to lower extremity. That's constant. That's constant. And it's not changing. And he had a meniscectomy 2.5 years ago because they did an MRI, showed maybe his meniscus was involved, didn't change it. He's also had 2 recent steroid injections in his knee. That hasn't changed it either. The back pain started a year ago when he was moving furniture with his son. But again, no change in the lower extremity symptoms. They wound up doing an MRI of his lumbar spine, and they noted he had lumbar spinal stenosis. Okay, lumbar spinal stenosis. And they were setting him up for surgery for a decompression because they thought those lower extremity symptoms were related to that. He's going to have surgery in a month, right? That's when the surgeon can get him in. And he said, well, why don't you go to PT in the meantime? Okay, do PT in the meantime. And so if you look at what his physical examination findings were then, he had left calf atrophy, right? So he had neuro exam findings in the S1 myotome, meaning numbness and tingling, as well as calf atrophy. Lumbar flexion extension causes low back pain, right? And when you do accessory motion testing on a lumbar spine, it was stiff. So he definitely had lumbar impairments. But this is the bottom line. Nothing that the PT did altered the lower extremity symptoms. And I would say that if you're looking at your physical exam and there's a region of pain and you can't change those symptoms, that's a concern, right? That's a concern. Because at the very least, I still treat patients. And at the very least, you get patients who come in and, you're not sure exactly what's going on. At least if I make them worse, sounds terrible, I at least know I'm in the ballpark. I'm in the right area. Because sometimes we monkey around, these grade 1s and grade, well, that's not changing anything. Now you don't know what you're doing. At least I know I make you worse. Okay. I'm in the right area, right? At least I made it worse. But when things don't change, that's a concern, right? When things don't change. And so nothing they did changed those symptoms. Like I said, he had moderate to severe canal stenosis at L5S1. We've already talked about the differential with that. So he's treated for a month. He's getting better with respect to his low back pain, right? 75% better with the low back pain. But this PT would always ask, any numbness, tingling in your hands or feet? Yes, I got the same thing in my legs, but now I have some tingling in my hands. And I'm also having some balance issues in the morning. So the question comes up, with that finding, what would you do with that as a PT? He's scheduled to have surgery like next week, right? But now he's telling you that he has some tingling, right, in his upper extremities, and he's also having some balance issues. Remember, the reason he came in wasn't because of his symptoms necessarily, is because when he was playing golf, he noticed unsteadiness that's getting worse. That's a balance issue, isn't it? That's a balance issue, right? And so if you look at the exam that the PT did when he found out about that, he noticed that there was bilateral upper extremity hyperreflexia. So testing DTRs, he also had a positive Hoffman's, which we'll talk about in a second. No other neurologic findings in terms of tone, clonus, no Babinski. But then active cervical extension elicited tingling in the upper extremities. And then when he flexed the cervical spine with overpressure, that was the first time that he actually felt a decrease in those lower extremity symptoms. So flexion of cervical spine with overpressure, and they hold it, sustained it, right? He finally noted that my lower extremity symptoms are changing. So at the very least, those lower extremity symptoms might be related to the neck, believe it or not, right? And he also has upper motor neuron findings, positive Hoffman's, right? And upper extremity hyperreflexia. Hoffman's reflex, you guys familiar with this one? So you just flick the middle digit, right? You flick the middle digit. What you're looking for is if there's any movement between the thumb and the index finger, that's a positive Hoffman's. It's indicative of upper motor neuron pathology, right? If you did this on a patient following a stroke or a TBI or MS, they would have this. This particular patient had a positive Hoffman's. And I've had this conversation with tons of neurologists. And so if you get positive upper motor neuron findings in patients that should not have it, okay? Again, MS, stroke, they're going to have it. But in these patients that you're seeing with garden variety neck pain that start to develop neurologic symptoms, if they have things like Hoffman's, Babinski, probably more than 4B clonus, you want to go ahead and image that, right? Probably with an MRI, okay? And again, if they're cascading neurologically, this is time-sensitive stuff. So they probably can't wait 3 weeks, right? They can't wait 3 weeks. So this guy is getting worse, right? And so again, cervical MRI, what are we going to look at? We're going to look at the cord on these T2 weighted images. I like to show those cadaveric specimens as well, so you can kind of see what's kind of going on with the cord. So again, on the left is a normal scan. On the right is his scan. And you see a couple different findings there. So he has what looks like a congenital fusion between C2 and C3 right here. And then he has a retrolisthesis of C3 on C4. He has disc bulging at C3 that's compressing the cord. This is ligamentum flavum back here, okay? Ligamentum flavum. So sometimes what they call that is buckling of ligamentum flavum. Sometimes they'll call it hypertrophy of ligamentum flavum, but it's really more of a buckling because as you lose height in the cervical spine, it's almost like taking a rubber band and taking out the stretch and compressing it, right? So that's what that looks like. So he has compression, and he also has cord signal intensity change, right? So the gold standard for cervical cord myelopathy is what we call myelomalacia. So you see a whitening in the cord, right? That's the gold standard for cervical myelopathy, right? So, but he has compression, and you can see that little bit of whitening right there in between those two black bulges, right? So he's cascading neurologically. And so the reason that they didn't do his lumbar spine and did the cervical spine instead was because of the upper motor neuron findings that showed up in the PT exam. And so he underwent, so this is what this looks like, but this is a degenerative process, right? You look on your left, that's what these cadaveric specimens look like who have this spondylitic compromise of the cord. And then on the left, or your right, you can see what a good specimen looks like where there's no compression on the cord. This takes a lot of time to happen, right? This took a lot of time to happen. And when they went ahead and decompressed his cervical spine, right, his symptoms went away. Lower extremity symptoms went away. And here's the paper. You want to read it. But it was a very interesting patient. So we had what's called this backdoor laminoplasty, right? So they put these polymer spacers in, right? And they basically just open it up to give the cord a little more room to breathe. So these are CT scans of what it would look like after they do that laminoplasty. All they're doing is increasing space for the cord. And he actually had a good recovery. This is a little different, and this is what it looks like as well after these laminoplasties. Here's the cord compression. After surgery, you can see how that space opens up, which is good. And so what are the signs associated with this? This is probably one of the 4 or 5 conditions you want to be careful with the cervical spine. So paresthesias, but paresthesias in a non-dermatomal pattern, right? The physician that we evaluated, that's a dermatomal pattern, right? That's a dermatomal pattern, right? These are dermatomal patterns. If you get a patient who has these vague lower extremity symptoms or upper extremity symptoms that are multiple dermatomes, that's what you want to be concerned about. Couple other concerns, weakness. The weakness, again, will not be in one myotome. It'll be in multiple myotomes. The first patient we talked about with regard to the neck, the woman who was feeding her cat, her entire left upper extremity was weak, right? 4 out of 5 weakness. Wasn't pain related. Ataxia. They could have gait issues. They could have these upper motor neuron findings, Babinski, Clonus, or Hoffman's, right? Babinski, we stroked the bottom of the foot. What's a normal finding? Toe should go down, right? Toe should go down. We see a little baby here. The reflex writes itself at about 6 months, but if you stroke the bottom baby's foot, big toes going up and toes are going to fan. So you don't say positive or negative. I think it's either toes going down or toes going up. Up going, that's a problem. That's a problem. And then Romberg test. Talk about that in a second too. So again, cervical myelopathy, one of the big concerns, if patients are cascading neurologically, surgery is indicated. I will tell you that you could potentially get a patient. So let's say we're evaluating him. He had these upper motor neuron findings that you found, but his neurologic examination, even if he had multiple dermatomes, multiple myotomes, but he was stable, meaning functionally he wasn't declining. If you look at the literature on surgery for those people, there really is no difference between leaving them alone and doing surgery. So they have to be declining, right, in order to really consider surgery. Now, you might get a surgeon who says, I want to go and decompress them anyway. If they're not declining, they're essentially a neuro patient at that point, right? Some balance issues, right? Some weakness, and you treat them as such. And so here's the examination we recommend for all our C-spine patients. Any numbness, among all the other things, any numbness, tingling in your hands or feet, any concerns with balance recently. And it might not just be with gait, right? You might have to ask them, yeah, you know what? When I run on my treadmill, I had a patient just tell me this, right? I used to be able to walk on a treadmill for an hour at 3.5 miles per hour and not use my handrails, 80-year-old guy, right? Now I can only walk a mile. I have to decrease the speed and I got to hang on. I'm like, all right, when did this start to happen? Just over the course of the past 2 weeks, right? So that's an acute change that needs to be evaluated, right? Neuro exam, strength, sensation, DTRs, right? Strength, C4 to T1, uppers, L2 to S1 lowers, sensation same, and then our reflexes. And the more I practice, the more I appreciate some of these balance assessments like Romberg, right? So Romberg is an interesting test. Talk about that a little more in a second. But the bottom line is that if you're, well, let me say it this way. If you're looking for a couple studies to read, if you can't fall asleep at night, yank these things out. But they're interesting. We can't do these studies anymore, but they built spondylitic models in the neck of canines, meaning that they built these bony bridging models that compressed the spinal cord. And what they found after they unfortunately sacrificed the animal was that if you have compression on the anterior aspect of the cord, could be from a disc, could be from bone, over time, the lateral columns and the dorsal columns are going to be affected. So now we got to think about and it's completely variable as to what gets affected, right? And so remember, the dorsal columns affect what? Proprioception, stereoagnosis, vibration. So that would be your balance issue, right? Cortical spinal is what? Motor. So that would be your strength. That would be things like Clonus, Babinski, Hoffman's, if that's affected. Spinal thalamic tract would be what? Pain and temperature, like the gentleman we talked about. For whatever reason, in his neck, right, he has pain into his lower extremity. And you know what? It gets funny because when we submitted that case, we submitted, I think the journal was Spinal Cord that we published it in. And we had to make a statement there that even though his leg symptoms got better, that we cannot state it was directly related to his neck. Because it's not of one, and you don't know. But I mean, if you do surgery on the guy's neck and his leg symptoms got better when nothing else affected it, I don't know. What do you think? It's probably related to his neck. You flex the cervical spine and overpressure, you open everything up, and all of a sudden, that's decreasing the symptoms of my leg for the first time in 3.5 years. That's an interesting finding. But, pain and temperature, spinal thalamic, motors, cortical spinal, dorsal column. So the bottom line is that if you're going to do a neurologic exam, we tell students this, you either have to do it all or don't do any of it. Why? It goes back to those concepts of sensitivity, specificity. Nothing here on this list is sensitive, meaning that, let's just say I'm looking at DTRs, and the DTRs appear to be normal. That doesn't matter at all. Now, if they're hyperreflexive or hyporeflexive, that's a different story. Just because you have a negative Babinski, does that mean you can rule this stuff out? Nope. Just because you have normal gait, does it mean I can rule this stuff out? It doesn't. So you have to evaluate all of this. Now, if you have a Hoffman's and it's positive, what did I tell you? You should get imaging because that likely relates to a concern. So some of these are specific, meaning if they're positive, that matters, but you have to do the whole thing. And think about Romberg. So what's Romberg? Varying degrees, right? I'm standing here, got my eyes open, right? Because I need 3 things to be able to keep my balance. What are they? Vision, vestibular, and dorsal columns. So if you all of a sudden, you close my eyes and I start losing my balance, if my vestibular system's intact, what's the only other thing that can cause that problem? Dorsal column disease. And so don't underestimate the power of some of these tests. You close a patient's eyes and all of a sudden you start to see some changes. You got to ask yourself, is that age appropriate, right? Because you may have to tandem some of these folks and then close their eyes and see what happens. And, so it's a very complicated differential diagnosis, right? So even if you have the findings, you may not necessarily know what to do with it. So we'll end with, these are the red flag conditions for the cervical spine. Myelopathy's off there on the left. I've already talked about cancer a little bit in terms of what might happen to bone, but if you have concerns over that, those are patients that need to be imaged. Upper cervical ligamentous instability, they could have signs of myelopathy. It's that atlantodental interval that's now no longer intact. Those patients, the gold standard diagnostic image would be motion films. Flexion extension to see if I get a gapping in the atlantodental interval. How might they present? Number one, they may have trauma. There are some disorders like rheumatoid that will actually eat away at that transverse ligament. Kids with Down syndrome as well are prone to that. So what you're looking for would be symptoms into the head and face because upper cervical spine. They're going to have apprehension with movement and the cord could be involved. Because if my transverse ligament is no longer intact and I flex forward, where's my odontoid going? Back. And it's going to compress the cord. And so you could have any of those findings. So in those patients, flexion extension radiographs are going to be indicated. Vertebral artery, there's a wonderful paper written by the IFOM folks that talked about the new screening for vascular pathology guidelines that I recommend that you take a look at. Inflammatory systemic disease, where I talked about that in terms of infection and fracture on the far right that you'd want to be concerned about. Corticosteroid use, again, can cause AVN, but it can also break down bone. And those folks are at risk for fracture, and as well as folks who are older. And the older you get, the less trauma you need to cause a fracture, right? Because in young patients, again, it's pretty tough to break a bone. You need a lot of trauma. Once you get older, it doesn't take a lot, right, to break bone in some of those folks. All right. Any other questions? Let's go ahead and take what time is it? Do we got? 10. All right. Let's take a quick 5-minute break. We'll finish up the lumbar spine and we'll let you guys have lunch. Yes.
Started, one, if your computer's losing power, you got cords down in the floor, there's power all throughout. You need that. Also, if you're not question, please use the mic so the people online can hear it. And then at 11:30, Jesse and I are going to give tours of the building if anyone wants. We can also do it at the after lunch too, right before we start.
All right, let's go ahead and get started back up. We'll introduce the lumbar spine. We'll introduce the lumbar spine with a quick case. And so this is a 32-year-old woman. She's 22 weeks pregnant. And she's coming to see PT proactively. She's concerned about an increase in her low back pain during her final trimester of her pregnancy. So her main question to the PT is my back pain going to get worse? And if it is there anything I can do about it? And so she was diagnosed with a spondylolisthesis at age 18. She fell out of a tree when she was about 12 years old, had back pain all through her adolescence for whatever reason. She was finally worked up at age 18 and they diagnosed her with the spondylolisthesis. She's had no low back pain at all for the past 7 years and now just has this intermittent ache that is thought to be maybe related to her pregnancy. Clinical exam, normal neuro exam, meaning DTRs, strength, sensation, all intact, right? Pain-free lumbar spine, active range of motion. She says, right now, I'm not really having any symptoms. And I would ask you, what the next step for this particular patient might be. And so just for the sake of time, I'm just going to kind of go through this with you. I've presented this case a lot over the last several years at different venues. And, you present it to PTs and I say what the next step would be. PTs usually say I would go ahead and I would educate them. We show them maybe some exercises, give them some tips and some, things to do to minimize their low back pain. The low back pain's likely probably going to get worse as she works her way, to the point of delivery, and give her some things to do. And the question always comes up, well, is there anything else you would potentially do? Right. And so for this particular patient, the PT had just asked, has anybody talked to you about your spondylolisthesis? Now, why would that even be important? Well, for her, during her pregnancy, she was going to have her pain managed with a spinal epidural, right? And probably the number one precaution to putting a needle into a joint would be abnormal anatomy, okay? And so abnormal anatomy. And so because she was going to have that done, the PT just asked, well, did you discuss this with the anesthesiology staff or your physician? And she had not, right? Her obstetrician, she had not discussed any of that. So all he did was pick up the phone and just call the obstetrician. I'm seeing Mrs. So-and-so, for her back, that's fine. But she mentioned to me she has spondylolisthesis and that she was concerned, about her back pain getting worse and could her pregnancy influence this? And the next question from the obstetrician was, does the anesthesiology staff know about the spondylolisthesis? And no one knew about it, right? So the PT had a very interesting piece of information that no one knew about. And you say, well, how would that even drive this particular case? I already told you, right? The number one precaution for putting a needle into a joint would be abnormal anatomy. And now we're dealing with the spine, right? Now we're dealing with the spine. So if we wanted to evaluate that spondylolisthesis and determine the extent of that, what imaging could we do for her to evaluate spondylolisthesis? Ultrasound is interesting, but it probably wouldn't get deep enough to determine if there's a slippage. CT scan was mentioned. Can we do CT scan on a woman who's preggers? Or flexion extension films, can we do that? Radiographs? No. So CT and X-ray ionizing radiation, you wouldn't want to do that to the baby. Ultrasound, you certainly could do. Sound is not going to harm anybody. We do ultrasound all the time on babies, but it might not pick up the CT, it might not pick up the slippage. Could you do an MRI? You could. You could do an MRI. That would be the modality of choice. So we do the MRI on her. On the right is a normal sagittal T2 weighted scan, right? So vertebral bodies. All stacked up nice the way you learned them, right? And then here's her scan here. L5 slip forward on S1 with significant bony compromise and compression of the cauda equina between the posterior elements of L5 and the posterior elements of the sacrum. Here's where the cord terminates, and here's the nerve roots at that point coming through there. And so when you, again, think about an epidural injection, it's going to go through the area of about L1 to L2 and promote anesthesia, right, down below that area, right, to decrease some of the pain. But if you look at, right, where that cord and where those nerve roots are positioned based upon this slippage and the tethering of the cord between those posterior elements, that probably wouldn't be in her best interest. There could be concern with that, right? So in this particular case, this is one of these cases that we got through JOSPT. They did a prophylactic C-section. So the obstetrician was very concerned about the trauma of childbirth, what that could even potentially do. And so they took her to the OR under general anesthesia, right, and performed a cesarean section. And the baby and mom came out great on the other end of all that. So I present this case for a couple different reasons. The first is that this really shows you the tenuous relationship between pathoanatomy and symptoms, because she had an injury as a child, didn't get worked up, got films done at some point. We didn't have access to those or the report, right? Because she's how old? 32. It's 14 years ago. We didn't have access to any of that. She just knew she had it, right? The PT found out the information, right? Forwarded that on. But again, if she had back pain and you did a scan on her and you saw that, what would you conclude? That has to be the cause of her back pain. She went for the last 7 years without a problem. It wasn't until she started to grow a little bit, right? And she's hyperextended a little bit. And when she's standing at the sink doing dishes or vacuuming or walking at the grocery store, right? Then now my back pain's coming on. If I sit, I'm fine. Classic symptoms, right, of that particular pathology. Or even if you're talking about just a woman who's pregnant, general. The other thing is that patients tell us information that no one else may know about, right? And it could potentially have downstream effects for the providers involved. And so you want to share that information. Now you may say that I don't know if I would ask those questions, right? I don't know if I would have gone down this road, and that's fair. I think the PT did a really nice job in thinking all this through. But the second part is she comes back about 6 months later with one of those beautiful wicker baskets, right, with the water crackers in it, couple bottles of red, couple bottles of white, the nice high-grade pepperoni, not the stuff you get at Hickory Farms, but the good stuff, cheese. And she says, I just want to thank you for everything. The baby's great. And she brings her husband with her this time. And she goes, well, can we talk a little bit? And, and then they asked the question, I've gone to see my husband was very concerned about this. I've seen 2 different neurosurgeons. One said I should have surgery to treat this. No back pain, by the way. She's fine. Right? She's back to where she was. The second one says I should leave it alone. And then the question comes to you, what do you think? Now she's asking for your opinion. Yeah.
If she was 22 weeks pregnant when this was found, what did they do to mediate her pain or anything else if the baby went to full term?
Yeah. And the baby did go to full term. And so it was just the basic PT interventions that you would teach anybody. Yeah.
Right. Difference in relationship to gravity with what was going on in her
Absolutely.
body. Yeah.
Absolutely.
Okay. Thank
Yep.
you.
But she still is going to respond as a patient who would have a spondylolisthesis, right? So extension activities make me worse, flexion activities make me better. Yep. I can repeat it.
Thanks. Better. My question is about postpartum issues. Often women have
Yes.
postpartum issues related to the pregnancy and they don't
Yep.
quote snap back to where they were
right.
structurally and they're
That's right.
offset and so on.
Yeah, and I'll be honest, I think the symptoms that she had in talking to these authors, the first author in particular, who I knew, her back pain was truly mechanical, right? So it was mechanical back pain that you would see in a woman who's pregnant. And so this follow-up, when she showed back up, was 6 months later, and she wasn't having any symptoms. So she was completely asymptomatic. And so one surgeon says, go ahead and treat it. The other one says, leave it alone. And so when she asks you for that, you're right, you could do one of two things. You could say, I got to go to the bathroom and maybe go on the computer and do a quick search and see. And if you did that, you might come up with this paper. So I always say part of this is that there's a huge body of literature out there that's probably looked at all these questions. And when we develop our PTs, we want them to be clinician scholars, not meaning they're doing research, but they feel comfortable asking a question and looking for an answer based upon data. And that particular paper looks at these patients who had high grade slippages, but were asymptomatic, not asymptomatic, but their back pain wasn't of a surgical concern. Because what could happen to her? What could develop? We already said that X-ray results, MRI results can cause catastrophization on the part of a patient and fear. If you were going to talk to her, what does she need to know could potentially happen with this? Cauda So what would those symptoms look like? Changes in bowel or bladder, saddle anesthesia, paresthesia, tingling down the legs, maybe weakness in the legs. And can you blow that off? No. You probably have max. If that stuff, especially if the urologic system's involved, you probably have max, probably 48 hours before that stuff is not coming back, right? And so you have 48 hours, probably max. And how do we know that? It's unfortunate, but I mean, we learned a lot with the conflicts that we had in the Middle East. Saw a lot of blast injuries, a lot of cauda equina, and we knew that you probably have 24 to 48 hours decompress those spines, or else they're at risk of permanent neurologic and urologic damage. And so you're not scaring her, but you're letting her know that that is a concern. And if those symptoms begin to develop, no matter where you are, you have to get to an emergency department to be evaluated. She has to. But you're not trying to scare her, right? But the bottom line, someone raised their hand. Did you? Yes.
Once you know there's an abnormal anatomy, is it standard to then pursue more imaging, or is it just because of the pursuit of this case it was done?
Ask it one more time.
Okay, is it standard to always do imaging once you know there's an abnormal anatomy in the lumbar spine?
Yeah.
For a pregnancy.
Well, no, I don't think so.
Pregnancy.
Pregnancy, if you have like a spondylolisthesis and if you have a history, I guess I'll say it this way. If you had a history of a spondylolisthesis or some type of anatomical variant, that would be a concern to putting a needle in there. Because right now we know there are probably better ways to do injections, like in the military now. They don't do, military PTs are taught to do injections for a bunch of different reasons. But now they do ultrasound guided injections because the likelihood of you getting into the joint is that much better. I mean, there's studies on orthopedic surgeons doing subacromial injections. Half the time they swing and miss. I don't know if you guys know this. That's the subacromial space, which isn't that hard to find. Go in the back, right? You put a little thumbnail and you just drop down half an inch and you're in the space. You just got to angle the needle in the right direction. But you can miss a lot, and so I think that if there's a history of it, you'd want to image it and see what the concern would be. Yeah. Yes.
I'll use this. So my question, you kind of went over it, is talking about when people do ask your opinion and what you
Yes.
think, because like legality wise, you want to be careful. And it seems like a lot of patients will ask our opinion because we spend time with them.
Yes.
They share more information. They feel comfortable. So with that patient coming, like, what should I do?
Yep.
You kind of answered it with going through like just educating her
Yes.
options, but I tend to err on the side of like, well, I can't really tell you what to do because of legality wise. So how do you really approach that of like, this is what I would do, this is what I would not do? How do you approach that and still answer their question?
This is somebody asking your third opinion. This is someone looking for a third opinion. That's fair. What I would say is that when someone comes and tells me, I have an x-ray in my back, and they said I got a badly degenerated disc and I got a muscle strain in my back. That's what my back pain is. Well, has nothing to do with a muscle strain. I wouldn't say that. I could care less. I would say, absolutely, we're going along with your physical, because it doesn't matter. It matters what I say if I add uncertainty and concern to the patient. It has nothing to do with a muscle strain, and that degenerative disc probably isn't even your symptom. I'm still going to treat the patient, and the patient doesn't need to know what I'm doing and how it relates to that finding. You follow me? I don't want to add uncertainty if it's not necessary. I don't need to be right in that case and let the patient know that that's not even a diagnosis for what you have. And that might not even be based upon my examination. That's not even a symptom generator, that level. They don't even know that. But this is somebody asking your no kidding opinion. Like someone coming to you and saying that I have this finding in my knee and they want to know if I should have surgery or not. I have an ACL tear in my knee. Should I have surgery? Right? Maybe I'm dealing with a surgery, so let's do a non-operative course of care. Give your opinion in that case. So in this particular case, this paper showed that in patients who do not have neurologic decline, pulling these patients back and fixing this is at significantly more risk for permanent damage than leaving it alone. That's what I would tell her. I'd base it on the data. And so if you want to give your opinion, that's where you get yourself in the problem. But if you base it on a paper that says, this is how I would proceed. However, this is your decision, right? This is shared decision-making between two surgeons who have different opinions, and somehow that's got to get resolved. But regardless of what I'm telling you, in that paper, if these patients start to develop urologic symptoms, neurologic symptoms, you have to be seen ASAP because there's something there. But to pull this back, having talked to a neurosurgeon about this, number one, this is completely fused, right? Whether or not you believe in neural tension or not, those nerve roots are probably adhered to the sacrum. So having to dissect that out is extremely dangerous and tenuous, could lead to permanent nerve damage. There is scarring of the nerves, and there's probably scarring there. She probably has an element of neural tension that she doesn't deal with, right? Because she doesn't probably move in that direction to alter it. So I think if someone's asking your opinion, like a second opinion, that's different than someone saying, yeah, my doctor says I got a muscle strain in my butt and that's what's causing my back pain. It doesn't matter. That's fine. We'll work together on that. I wouldn't add uncertainty unless it's necessary. But in this particular case, I think it's fair. I don't know. What do you guys think about that?
I think you said something very important just a few minutes ago. Use the words based upon the data.
Yeah.
That I think will cover you
That's
a
right.
lot.
And I think that's key, especially if you use the caveat that if these symptoms develop, because that's the concern, because there are red flag findings like cancer, infection. We had to talk about infections. Infections, those are life-threatening conditions. If you have a patient that you think has an infection, those are life-threatening conditions that if those infections break off, like the first person we talked about this morning, right? He had severe neck pain, but once fever develops, what does that mean? Those are probably abscessed, right? And then once they break off and get into circulation, now you're going to get things like fever, malaise, body aches, things like that. That's what you're going to get. And so those are life-threatening conditions. And so it's a great question. But I present this case, I presented it a lot, presented it when I was here last time, and I think there's a bunch of really good talking points that you want to think about, right? About the information that we get, who else needs to know about that, and the tenuous relationship, again, between pathoanatomy and symptoms in the lumbar spine. So we've talked about this already real quick. I mean, if you do imaging in asymptomatics, you're going to find all kinds of different things going on that may or may not be related to their symptoms. Those two bottom bullets, those disc extrusions, sequestered discs, and frank nerve root compression are rare in individuals without low back pain. We don't see it. And any of these findings that we do see don't predict whether or not low back pain is going to develop, and it doesn't tell us who's going to get better. Meaning you could have a spondylitic back with degenerative changes, and they could do just fine. You could have a patient who has a pristine X-ray and MRI, and they may not get better, right? And so, again, in the spine, unlike other areas, the relationship between all this is very, very concerning. So again, when should you consider advanced imaging? We've already talked about all of these here. And if you look at the most current kind of clinical practice guidelines for this, there's really two reasons to get imaging. One would be progressive neurologic deficits or a concern for a serious or specific underlying condition. And the stuff that we treat is nonspecific low back pain. You guys know that, right? Nonspecific mechanical low back pain. Specific conditions relate to the things we had in that cervical spine slide before: cervical myelopathy, fractures, infections. Same thing with the low back, right? This is a bit of an eye chart, but I think as long as you know that those are the conditions that we don't treat, those are specific conditions that cause symptoms that are not mechanical in nature, meaning cancer, infection, fracture, inflammatory disorders like rheumatoid arthritis, ankylosing spondylitis, and then cauda equina. This chart, the way you'd read it would be, if you look at cancer, those areas that are darkened in, those are the findings that you might get, right, in a patient who has that disorder. We just talked about cauda equina, right? What would we see? Potential incontinence, loss of tone in the anal sphincter, or fecal incontinence, saddle anesthesia, right? Widespread progressive weakness or gait disturbance, right? Those are all things we would see in that patient that might lead us to needing diagnostic imaging for that particular patient. And again, all these are time sensitive as well. That case we talked about earlier this morning, if that first ER doctor had likely done imaging, that might, when the guy was functioning at a high level, that may have led to a better outcome. If when they saw the physician 4 days later, if that physician thought that neck pain was related to an infection, and he did imaging that day, surgery the next day, it probably would have had a better outcome because he was still ambulatory at that time. But that 2-week window, as he began to cascade downward, once he got to the point where he could no longer ambulate, right? I mean, there was no coming back from that, right? That's beyond that window. And so these are all time sensitive in nature. Real quick, just on the classifications of these things, these extrusions, right? We talked about those already. Those are ones that, because it's oftentimes easy to say, the imaging findings in your back, that's great, but they don't matter. They don't affect outcome. Again, if you hear something about an extrusion, even protrusions, right? That's probably the second worst type, right? Those are the ones that probably you have to have some concern over. Protrusions will be in about 15, 20% of normals. Extrusions, we just don't see them. And it relates to the AP diameter of the herniation compared to the medial lateral distance. And so in a protrusion, the medial lateral distance of the herniation will be greater than the AP distance. Extrusion is just the opposite of that. So the AP area of the extrusion is going to be larger than the medial lateral. So that neck of the herniation is much smaller, right? Which means there's probably more force going through that disc and that herniation. And so the other thing I'll mention is that if you start looking at MRI scans, the vertebral body, these T2 weighted images on these magnets now that are very sensitive, you're going to see this area of increased signal, right, in the back of the disc. Don't get thrown by that. That's the area of blood flow to the vertebral body, right? So you should see that area of increased signal on those, and that's normal. And these are all normal scans. The discs on these T2 weighted images show up nice and bright, meaning what? There's fluid in the discs, and a normal disc should have that fluid. As the spine begins to degenerate, you'll see changes in that as the spine degenerates. So these, again, are normal scans here, lumbar spine. These are disc protrusions here. Most commons at L5S1, right? This one here looks like at L3, L4. And then these are extrusions here, a little bit larger that we talked about. And then these are some really, really bad extrusions here, right? Large extrusion. This one's actually indenting the cord, right? This one's indenting the cauda equina here as well. Okay, so those are those findings that are important. And the last thing I'll talk about real quick is just what time is it right now? Yeah, and so we talked about this morning about those outcomes with low back pain, and I just want to talk about this a little bit before we break. That the prognosis for patients with low back pain is challenging, right? And so this particular study looked at, it's a great study because they took patients in this study that typically are excluded from others, right? So they needed patients to have a frank neurologic finding, right? Either an absent reflex, weakness, dermatomal changes, and they had to have one of those large herniations. One group got surgery, the other group was left alone. And they were left alone to pretty much do whatever the heck they wanted. They just couldn't have surgery. So this was a trial that was set up really, in my mind, for success for the surgical patient, right? Because the surgery was very clear. Dr. Weinstein's the first author there. He's the editor-in-chief of Spine Journal, which is probably the top spine journal probably in the world. There's a bunch of other really good surgeons on there as well. And these are the outcomes. And I would ask you, what would you think would happen, right? And so here's the data between the two groups. So the non-operative groups on the right, surgery groups on the left. If you look at the data, just in terms of the herniation, so these are patients, 2/3 had those large extruded fragments, right? Some even had sequestered fragments, which are fractured segments that break off from the disc and are floating around the canal, right? And here are your neurologic findings up here too. So these are complicated patients to treat, right? And so if I would ask you, do you think one group would do better than the other? What would you say? Non-surgical is going to do better? Even with the neurologic findings? Yeah. So, I'd ask you this too, just before we break here for lunch too. How do you determine if your patient had a successful outcome? Objectively, though. So real quick, so I'll tell you. So these are Oswestry scores on the far right. Do people use the Oswestry? Does anyone use the Oswestry Disability Index? It's great. I think it's a wonderful tool to use. The average score in this study for both groups was about 47 or 48 coming in, which suggests a moderate level of disability, right? That's a moderate level disability. These patients came in and they had definitely functional levels affected. If you wanted to objectively state this patient got better, I had a successful outcome, how would you do it? Number one would be if that score dropped by more than half. Okay. So if they went from a 47, whatever half that would be, down to somewhere around a 22 or 23, that would be one way of determining it. The other way would be to determine, because think about this, even for you that use that, let's say patients are in the low 20s. Are they telling you they're feeling great? I have an Oswestry, they're not. They still have symptoms. They maybe can function better, but they still can't do everything they want to do. So we found in the military with like thousands of data points that until you probably get less than 15 or 10, right, patients are still going to tell you they have functional limitations. So if you really want to say I have a positive outcome, you probably want these folks down below 15 or 10. So let's just say we're going to use 20 as our cut point, as we're going to say that's when the patients really start to feel better. How long does it take for them to feel better in this trial? These are months, probably 6 months. So for your patients who have chronic low back pain, because I think part of that chart, when we talked about this morning, I think part of that is due to expectations on the part of the patient. Because in Buffalo, I don't know why, but we just did our site visits for all of our students doing their internships. And how are things going? Well, we do our 8 visits in 4 weeks, and if they're not better, they go back to the doctor. Let's say it's one of these patients, and they got their 2 visits a week, their 8 visits over the course of 4 weeks. Are they going to be better? No. No, because they're here. They're here. So they're still going to be somewhere, maybe around 30, 35, maybe 40. They're not going to feel better. And so what are their options at that point? Yeah, I failed PT. Now I'm a failed PT patient, right? Now I don't even know if you did the right stuff. That's a whole nother argument. Because I just had this conversation. Oh, well, the same patient could see 10 different PTs and have 10 different treatment plans. And that's great because we'll probably all get to the same point. And I said, no, we won't. I don't buy that anymore. I'm convinced there is a best way to treat a patient. And you need to find what that best way is based upon the data. And you need to say, I've been treating patients this way for a long period of time. That's not the best way to treat this particular patient. That patient needs something else. I'm convinced of that because we're not going to get the same outcome with those 10 different treatment plans. I can guarantee it. There's a best way to do it. So my point would be, patients that I see, I set them up and say, look, be completely honest with you. I don't think you're going to have any tangible change for probably at least 6 months. But if you can hang in there till that period of time, I'm going to work with you. And if you're willing to do some work too, I think ultimately we're going to see a difference, but it's going to take time. And no one wants to have that conversation, right? That's a hard conversation to have. Because, patients want to know 2 things. And I saw that they want to know 2, and the most important questions I ask a patient are these. What do you want to be able to do? And in what period of time? Right? I need to know that now. What's your expectation? Well, I want to go back to my job working construction. What's your expectation? I'd like to be back in a week. All right. It's like going on a first date, a blind date. All I want, is to buy 1, get 1 free steak and maybe have a little conversation. But the person I'm with is thinking about marriage already. It's a first date. Expectations are completely different. So unless you know what the patient wants to do and when they want to do it, because who makes that decision? You do, based upon your examination of the patient, your knowledge of basic science and healing principles, this type of data here, you need to let them know. I appreciate that, but that's probably not going to happen. At least what we're going to be doing. It doesn't matter if you do surgery or not, because there's no difference between any of that. What were you going to say?
Yeah, just to share some of our data. Our data is for chronic back pain is about 8 months.
Yep.
But one of the things that we do see, and I think that's based on our modeling for central sensitization and other things, is that, and we do tell the patient, and that helps, is that what we do expect to see is a windows of relief. That
Yes.
a lot of patients will say, oh, it got a little bit better, but then it got worse again. What you want to educate them about is once you start getting those windows of relief, that's the sign that neurologically you're starting to stabilize.
That's right.
And that's an indication, prognostically, at least from our data, that they will get there at the 8th month.
That's right.
So you want to give them some things to observe during the process.
That's right. I agree, because their improvement's not going to look like this. This is the mean of all these patients. It's going to be jagged lines up and down, and that's what they need to know. And I think it took me 30 plus years to figure that out. But to figure out a way to have these complicated conversations with, and if this isn't the way you want to go, I'll help you with something else, and have some other options. But I think that plays into what we're talking about here. Yes, sir.
The factor that you have is if their insurance carrier,
Yeah.
i.e. Humana, has no expectations of reasonableness.
Right. Right. And so you get those 8 visits, right? And if you can't fight for it's hard. It's tough, right? And you get young PTs and it's tough. Yeah.
So my question then is how do we treat these people? I mean, what's appropriate with
Yeah.
visits and whatnot? I mean,
Yeah.
we can't treat them twice a week for 6 months.
No, you
They're-
can't. You can't. And I think, let's say you have the 8 visits. You know, you have the 8 visits over the course of this period of time. Do you front load a couple up front to try and maybe manage a couple of really, really relevant impairments and then space these out, right, over the course of a couple of weeks, right, 3 weeks maybe, and use a telephone to manage them as well. And I don't charge for that stuff. I probably shouldn't get in trouble for it all the time, but telephone visits for me have become absolutely imperative because you made a really good point. These exacerbations are what really, really concern people. And there's good data on what causes those or who gets those exacerbations. A lot of people who sit, a lot of people have psychosocial overlay, a lot of people who don't have PT. I can show you the studies, right? So if you're seeing PT, right, and you can control that fear and you can avoid some of those postural positions, you can probably prevent some of that stuff from happening. But that is a tricky question. When you're limited on visits, but you know, we knew this with ACLs. You know, I knew enough back in the early 90s that we would see people 3 times a week. Then Dr. Shelbourne started publishing data. Dr. Shelbourne was an orthopedic surgeon in Indiana, right? Dr. Noyes was in Cincinnati, right? And they had patients from all over the country seeing them, right? And they wanted things done their way. Remember, he published a paper, Dr. Shelbourne, and says, I need 8 visits in the course of a year, 8 visits with the PT, because the rest of the stuff they can do, as long as they get their motion back, they're getting their quad back, they can do everything else on their own. And that pissed people off. I don't know where we're at with it right now, but he showed, I mean, as long as these folks are educated, it's a whole different paradigm that we deal with right now with these limited insurances, and they don't budge. They don't budge. There's your 8 visits. You realize they're going to surgery at this, and who are you talking to, right? I mean, you're talking to a clerk on the other end, you know, who just knows the party line. It's difficult. I think you have to be purposeful in how you plan it out. Let these people know what they're in for. That's all I'm saying. Yes.
So you're basically saying that if it were up to you, you would be seeing someone for about 6 months for.
I'll
this
tell you
kind
something
of-
right now. I don't know how they did it, but we joked about this in the military all the time because you did not have to see a primary care provider ever in the military for preventive care. You did an online assessment where you could lie. Do you smoke? No. How many drinks do you have per week? 0. How many fruits and vegetables do you have today? 5 per 7. How often do you exercise? 5 days a week. How long? 30 minutes. How intense? Heart rate and training range. Perfect. What's your height? 6 foot. What's your weight? 185. Lie. And that would be your annual physical. But guess who you have to see every 6 months? The dentist. You have to physically see the dentist. So why do we see the dentist every 6 months? How did they figure it out? Do you follow me right now? Keep your patients for the rest of their lives. Be their musculoskeletal manager for the rest of their lives. So when something flares up, who do they feel comfortable calling? You. And bring them back every 6 months. I don't know, do a pro bono visit. I get in trouble for that stuff all the time. But we know that if you look at these studies that have been done, these high quality studies have been done on OA, you can treat them, front load them up front. They're going to get better, but eventually what's going to happen 3 to 6 months down the road? It's going to flare up. It's going to get worse. You bring them in for these quote unquote booster visits, right? Think about patients, think about some of your family members who would benefit from seeing a PT every 6 months. Tweak an exercise program, tweak some education. We haven't figured that out. And I don't know how we're not doing that. I say we hold on to patients for the rest of our lives. I give everyone my cell phone. I don't care. No one calls me. I know there's therapists that are very concerned about that, but call me anytime. No, I'm serious. I don't care because you have a hard life and stuff is going on and I'd be happy to talk to you about it. That's how I feel. But these are challenging patients. Why is it an imaging course? Because when you say they're no better with PT, what's going to happen? They're going back to the primary. Primary doesn't know what else to do. They're getting imaging. Something's going to show up and they're going to a surgeon and they'll find a surgeon to do something, right? I just had a patient with a multiple level cage fusion and I didn't, she was adamant on having surgery. And I told our staff, I said, that outcome is not going to be favorable. And so she's worse after surgery. And the surgeon finally told her that it's going to take 3 years for you to feel better. And he never told her that before surgery. And I don't know if I had the nads to tell her up front. I just don't think this is indicated for you. But you get a patient, that's exactly what they want to do. And you know what? I'm not going to fight with people anymore. You know what I mean? You the surgeon, that's the surgeon. And he spoke so, and he was so confident this is going to help me. I'm not going to say I told you so, but I feel terrible for her. Because now and you guys have all seen these patients, right? She has changes. And I don't even think the surgery that he did was she had claudication related issues. He's putting spacers in between the disc with this cage fusion. He thinks it's individual nerve root related issues. What I thought she needed was a complete decompression, which he didn't do. He fused her and put spacers in between the disc, like thinking it's a radiculopathy type of thing, which doesn't make any sense to me. But I'm not a surgeon, but she's not better. She still can't walk from here to there, right? Without having to sit down. So let me see if there's any other quick slides I just want to share before we break for lunch. But the bottom line with lumbar imaging is just be careful. Once you start doing it, right, you have to be concerned. If any of these conditions come up, and this is what I would say too, that lack of conservative care, you need to think about that. Patients who are acute, those are chronic patients. Patients who are acute, if they're not better in a month, 1 month, I would recommend getting imaging for them, right? Especially if they're getting worse for no apparent reason. So 1 month of symptoms, patients who have acute low back pain should be getting better in the course of a month. If they're not, you should probably get at least an x-ray just to see what's going on. X-ray, don't do MRIs unless they have neurologic findings. All right. Anything else?
There was a question from online earlier about cervical. When do you need to do flexion extension versus just regular?
Flexion extension views would be anything related to potential instability or atlanto dental instability, right? So that little space up between C1 and C2. How are they going to present if they have instability there? Well, if it's someone with rheumatoid, right, we know transverse ligament can be compromised. Who else? Trauma. And so this would be symptoms related to the head and face. So they would have maybe numbness, tingling in the face. They might have headaches. They're going to be apprehensive with movement, right? So they're not going to want to specifically flex their cervical spine because they're gapping, right? And that odontoid is moving back into the cord. And they could potentially have vague neurologic symptoms as well. So those are the patients you want to get flexion extension views on who potentially have instability. And there's cut points, like if there's more than 3 to 5 millimeters of gapping with flexion, those are patients that if they have an abnormal neurologic exam, might be considered for surgery. So you want to do a good neuro exam on them too, because if they're stable neurologically, they may leave them alone, right? But there's set points in the surgical literature that says this needs to be fixed. Because even if they have even a low speed, think about this, they even have a low speed MVA, like a whiplash associated disorder, that could be it with that instability up there. And so those are good questions. Anything else? All right, let's break for lunch. Come back in an hour? Perfect. Any questions at all from the earlier session? All right, very good. So what I want to do is just present one case that relates to low back pain. We mentioned some of those sinister causes of low back pain in terms of things like cancer, fractures, infection, rheumatic inflammatory disorders, things like that, cauda equina. But those are things that are germane to the spine, but we could also potentially have um, disease in the abdomen that could potentially mimic low back pain as well. This could be related to maybe kidney dysfunction, dysfunction in the gastrointestinal system or urogenital tract, or potentially an abdominal aortic aneurysm. That's the other, variable here. And so this was an interesting case study published in JOSPT a few years back. It related to a 38-year-old male patient who had low back pain, and his primary complaint was low back pain when he played volleyball. And so as the physical therapist is evaluating the patient, the exam was essentially benign, right? Full range of motion, no palpatory tenderness, no concerns regarding neurologic findings. The only finding that popped up was when the physical therapist was palpating the lumbar spine, they felt a pulsatile mass, right? So there was a pulse in the low back when they were palpating the low back, right? So they felt like a rhythmic sensation. Now, you guys have all palpated a lot of low backs. That's not normal, right? To palpate the lumbar spine and to feel a pulse. And so that prompted them to evaluate the abdomen a little bit. And what the concern was that there was an aortic abdominal aneurysm associated with it. And so when you palpate the abdomen, we'll talk about it just a little bit. When you palpate the abdomen and you appreciate a pulse, what you're looking for is if there's lateralization of the pulse. And we'll talk about that. And when they palpated this person's abdomen, right, they were out probably, almost a good 8-10 inches before they couldn't feel the pulse anymore. And that's not a normal finding. And so the workup for this, if you were concerned about the aortic abdominal aneurysm, would be a CT scan potentially. Of course, this isn't working. See if we can just forward it there. So here's the abdominal aorta. A couple pictures of it here. Normal, right? Sits left to midline, right? Little left to midline, and it bifurcates at the umbilicus into the iliac arteries. Here's what would be an aneurysmal abdominal aorta. So the abdominal aorta would sit between the renal arteries and that bifurcation, that area and through there. And that's where you get the majority of your aneurysms in that area there. Yes. Yes, that's right. Let's share this again here. You get it. I'm seeing there. Right. Yep. So the renal arteries are going to be here, right? And then that's the, cartoon drawing there of the aneurysm. And so this is his three-dimensional CT scan here. So remember, it should kind of come down and be straight and then head off into the iliac arteries here. And so here's his aneurysm here. So it comes down like this, and then it kind of bifurcates off at this 90-degree angle. And then here's the aneurysm right here, right? Here's one iliac artery here. Here's another iliac artery here. And again, all that torsion and angulation there is very, very concerning. Now, here's the lateral view, or I guess call it the axial view, the lateral view of these three-dimensional CT scans here. Here is the axial CT again, looking at the size of that. And this was a 14-centimeter aneurysm. And normally the aorta is about 3 centimeters. And anything more than 3 centimeters is considered aneurysmal, but this was absolutely incredible, seeing the size of that. Here's the ultrasound image that you can get. Hard to kind of understand what that is, but I mean, you look at these different hash marks here and you can measure the size of it through an abdominal aorta. This is what the aortic aneurysm looked like during surgery. So there's a couple different ways of treating this. This was an open repair. You can also do an endoscopic repair, but the open repair requires a graft to be placed. So here would be the new abdominal aorta, the new iliac arteries here. And I think this PT probably saved this guy's life because this was literally a ticking time bomb, right? And the funny thing was that it was his primary cause of low back pain. And so once it was treated, his back pain went away. A couple points about it. It did. It did. It did. But a couple things here. So what are the risk factors for this? So it's more common in males versus females. Age is also a factor. Tobacco use raises the risk significantly, as well as a positive family history. Coronary artery disease and hypercholesterolemia are also related to it too. And so all that really, you think about the pathogenesis of this, you think about, for whatever reason, there's a weakening of the tissue, right? And you begin to see that ballooning, but this is absolutely obscene, the size of this one here, right? The majority of these can be asymptomatic at the time of diagnosis, and you may get back pain or abdominal pain. But if you look where it's related to, right? So here's another cartoon drawing here, but the aorta lays right up against the spine, right? So it's likely you probably could get back pain versus abdominal pain. You could also get pain generated by the aneurysm actually eroding into the vertebral bodies. And what tends to happen with these aneurysms sometimes is you get a dissection, meaning that there's 3 layers to these vessels, and you can get a separation of the layers. And it's often described as a searing type pain that is, kind of immediate, right? It's an acute searing type pain that goes away over time, but it's the layers actually separating and blood now flowing in through there. When that blood coagulates in that area, you get a hardened mass. So this is an actual CT view. Again, feet are out toward you, heads that way, slicing the body in half. This is an L3 vertebral body. That part of it looks like it's gone, right? And so once you crack past, right, that cortical margin, you break into that spongy bone. If you have anything hard up against it, it'll continue to break that down. So this is a much different scenario than what we talked about. But here are the kidneys here, right? Here's the aneurysm, right? And then this is this area of thrombosed blood, probably related to a dissection that is now hardened up and turned almost into like a giant blood clot. And once again, it's up against that vertebral body, right? It can erode away at the vertebral body and cause almost pain like fractures. And so the screening for this would be risk factors, number 1, and then looking for this palpable pulsatile abdominal mass. But dependent upon the girth in the abdomen, you may not be able to palpate that pulse, right? And if the girth is of such that you can't palpate the pulse, you got to look at other things. And so the one thing we will try to do is palpate. Here's the abdominal aorta again, next to the spine. You place your hands right next to the abdomen, right just above the umbilicus, and you're palpating again for the pulse. And you work your hands out toward the side, and hopefully that pulse is going to diminish quickly, because it's only supposed to be about 3 centimeters. And anything bigger than that, like I said, is considered aneurysmal. But if you can palpate the pulse and there's lateralization, meaning your hands are now out a little farther than they should be, that's something you'd want to report. The other major finding here too would be auscultation. So we would listen for an abnormal auscultatory sound. So we'd take the stethoscope and place it over the abdomen, and now over the abdomen, over the abdominal aorta. What we're doing now is we're listening for this turbulent flow, right? Because you can imagine if you have that dilatation of the aorta as the blood flows in there, right, you're going to hear that swooshing sound, and you shouldn't hear anything, right? And so these auscultations for bruits, they're highly specific, meaning if you hear it, it's there. But again, just like the abdominal aortic pulse, if you don't find it, right, you can't comment on it. Same thing with this. It's low sensitivity, meaning just because you don't hear a bruit doesn't mean there's not one there. It might just be subclinical and it just hasn't manifested yet. So the screening gets a little bit difficult. And so, these are the areas you want to auscultate over: the aorta, the renal arteries, and the iliac arteries as well. And then again, that dissection is a potential complication where you get a tearing, right, of those layers and blood flows in there and forms into blood clots that form into that. And so I just wanted to bring it up just because it's something that I think is prevalent, right? Especially in older gentlemen who have a smoking history and a cardiovascular history. The other thing I'll mention is the treatment of this is kind of interesting. And so anything more than 3 centimeters, I already said this, is considered an aneurysm. And 5 centimeters is kind of the cut point to determine if you do surgery. Anything between 3 and 5 centimeters, they usually watch it because the risk of dying from surgery is higher from the risk of it rupturing. Anything more than 5 centimeters, the risk of it rupturing is higher than the risk of surgery. Follow me? And so, and there's 2 different types of repairs that they can do, that open or the endoscopic repair, where they're basically placing a stent in there, to normalize the blood flow. Yeah, I think it's going to be based upon what the surgeon finds. And so what you're looking for would be a couple different things. So number one, when you start to look at these areas of angulation in the aorta, anything more than 60 degrees is concerning because you just can't stent that, right? That has to be surgically repaired. So if you look at this as well, the iliac arteries are aneurysmal here. So this was a no-brainer to do that. But you're looking at the size of it, and then you're looking at whether or not there's angulation in terms of the vessel in order to fix that. But if it was straight down and just this little aneurysm like we see here in this cartoon drawing, a stent would be perfect for this, right? You just put that tube in there, that would facilitate blood flow and not be a concern with that. But it's a concerning condition. Like I said, it can mimic low back pain, something that we wanted to talk about. So any questions on that at all? All right. Yes. It'd be good. So we're going to move ahead to the shoulder. Okay. So that would be like slide 175 for those that printed things out. I'm not sure. Do people have this? A couple of you have handouts here, the 6-slide version. If you printed that one out, it would be shoulder. Yeah, we're going to start. Yeah. Page 30, if you double spaced them, double-sided them, slide 175. So we'll start there. So we'll move into the upper extremity for a little bit, and then we'll move into the lower extremity, cover some of the highlights here. And so, we don't have real good evidence-based data to determine why we would get shoulder imaging, but really the key findings would be if there's suspicion for a fracture. So who would be concerning for that? Older individuals, history of trauma, and if we have bruising, right? So humeral ecchymosis, we see that, or if there's deformity present, you sometimes can see that, the AC joint. And then the glenohumeral joint or subacromial space. Sorry. Let's see. Okay. We're good to go now. Good. Yep, perfect. No problem. And then, so when you think about, examining those regions of the shoulder, glenohumeral joint space or subacromial space, and getting imaging to look at those, you have to ask yourself, how is that going to influence your plan of care, right? And then, of course, non-responsive to appropriate treatment will give you an example of that as well. So this is an example of an interesting patient case. It was a 58-year-old retired male who had a chief complaint of shoulder pain and weakness for 6 weeks, insidious in onset. And so how this whole evaluation came about was he was doing a routine physical with his primary, and the primary noticed that when he was taking his shirt on and off, he was having difficulty lifting, right, his left arm. And that's not the patient, that's actually an opposite side, but that's what this looked like. That's about as far as this fella could elevate his arm. So his injury history was interesting because he lived in an area that had a lot of snow, and they got like 6 feet of snow. He was worried about his roof collapsing. So he snowplowed his driveway. Then he took his snowplow up to his roof, or his snowblower up to his roof. and he fell off. We said to his wife, he probably should have kept the snow in the driveway and went up to the roof first because it would have cushioned his fall, but he wasn't thinking about that, right? And so he fell off the roof, right? Landed on his shoulder, never was really worked up really for anything. And so a very well-meaning primary care doc ordered plain films as well as an MRI for him. So we'll show you that in a second. He's awakening 3 times a night now, secondary to the pain. And again, this is a 6-week exacerbation, due to a chronic history of shoulder pain that he had. So he describes now this constant low-grade ACV, so constant varying. So it's constant, but it increases and decreases with activity. And he has this low-grade throb going through that left shoulder region. His physical exam is positive for impingement signs. So Hawkins, Kennedy, near, those type of things are all positive. He's weak in external rotation as well as abduction. In his active range of motion, like I said, he can only get to about 85 degrees, and it's weak and painful for him right now. And so here are his plain film radiographs. And so these are 2 views, right, that you would get kind of as routine views. And so the AP view on your left, you can see that. And then there's an outlet view as well. And these are classic orthopedic surgery views. And so if you look at that handout I gave you, the classic orthopedic surgery views would be an AP view, an outlet view, what we call an axillary view. So it's a view where the shoulder is abducted to varying degrees and the angle is coming up through the axillary region to look at the humeral head in relation to the glenoid, see the AC joint as well. But these are the 2 that we see for him. And so if you look at these images, right, this is an AP view straight on, and then that outlet view is at about a 15-degree caudal incline through that subacromial space. So you can profile the acromion really, really well. And you can take a look at the AC joint too. So you can see his AC joint is affected, and here's his humeral head. And so when we look at this type of study, the first thing we want to know in terms of, because you'd have to think, what would be in your differential with this guy? It's as far as he can lift his arm. Fell off the roof 4 years ago. Yeah, and he's weak, right? Weak, right? With this, right? You think about a rotator cuff tear. And so you'd want to, corroborate this. The imaging findings for a rotator cuff tear are a high riding humeral head. So if we look at, right, these outlet views here, this is his view. This would be a normal view here. So let's first talk about the AC joint, right? The AC joint should be consistent and contiguous, right? There shouldn't be any sharp kind of step off there. So when he fell, he probably injured his AC joint, probably tore his rotator cuff as well, because you should have at least 5 millimeters of space in between the humeral head and that AC joint, right? So this is his right side, right? No pain there. And then it's cool that he got the comparative view, because you wouldn't know unless you saw his contralateral side. So if you do get these outlet views for a rotator cuff tear, get the contralateral side as well, so you get a comparison. Because here we see concern over the AC joint as well as a high riding humeral head. You can see there's no space there at all. And so this is just another image of a different patient, but this is the same type of story here. So these are these AP views looking at the position of the radial head related to the subacromial space. Normal. This is abnormal here, again, consistent with the high riding humeral head. So the question is, should the guy have a surgical referral, right? Should he have a surgical referral? And the PT got kind of upset a little bit because he thought this is absolutely a surgical referral. Sent him to see an orthopedic surgeon. Orthopedic surgeon sent him right back. He said, there's no way I'm doing surgery on this. But the question is why, right? Why wouldn't the surgeon consider surgery? So here's his MRI. And I'm going to tell you right now, shoulder MRIs, I think, are one of the more complex imaging modalities to look at and understand. And I'm going to try and be as scientific as I can on this. All I'm going to tell you is that this is a coronal view. So again, when we start thinking about cross-sectional anatomy, we're cutting through the shoulder this way, okay? And we're looking at T2 weighted images. Remember, fluid shows up bright on a T2 weighted image. This is about as scientific as I can get. This is a normal study. Here's the belly to supraspinatus. Here is the glenoid, and here's the humeral head in a normal patient, right? The tendon is a little bit darker, lower signal, and then here's the muscle belly. Bottom line is, when you look at these MRIs, you should see no fluid, no white at all in this at all. That is consistent with a normal rotator cuff. When you look at his film, number one, the humerus is essentially abutted right up against the acromion, and you see fluid in here, in here, and in here. This is a high riding humeral head. Here's the glenoid, and you can see where the humeral head's riding. And here's what's the remnant of what appeared to be a supraspinatus tendon right here. And you can almost see it kind of snap back a little bit, right? And so if you think about this from an anatomic perspective, right, this is a cross-sectional view we got from an anatomy text, right? Here's the deltoid, right? Here's the deltoid. Here's supraspinatus, right? Here's the humeral head, and here's the supraspinatus tendon attaching all the way down here. And so the deltoid is trying to drive that thing up while the humeral head is being held down by the supraspinatus. So if you tear the supraspinatus, there's nothing to oppose the deltoid, right? So it yanks it up, and you'll see that high riding humeral head on plain films. But this is the kicker. So there's the tendon, right? There's the tendon. And this is the kicker, though, because this is a sagittal view. And you say, I'm not even sure what I'm looking at there, right? That is something, because we don't think about the sagittal view, right? And so I took these pictures off this thing called eAnatomy, which is incredible. I mean, this is like probably the best site you could ever have, because there was 2 anthropology students who started this site probably 20 years ago. I got grandfathered in to the point where you don't have to pay a fee for it, but it's essentially cross-sectional anatomy. Like if you take an MRI scan of the shoulder, every single scan, they've outlined all the anatomy on it. It's incredible. And it has all these different areas on here. But this is how we studied the shoulder, right? We studied the shoulder this way. Here's the acromion, right? Here's supraspinatus, right? Here's infraspinatus, right? Etc. But this is a sagittal view right here. So we're slicing the shoulder in half from the side, and we're looking at it from the side. And the 2 main components that I want you to know about, right? This is supraspinatus right here, right? And here's infraspinatus right here, right? Those are the 2 main muscles that we're concerned about. And so in his shoulder study, again, this is healthy. This is a healthy shoulder, supraspinatus, infraspinatus, right? I'm not sure, but I think this is what's left of his infraspinatus, and there's no supraspinatus at all. So what you'll see in a radiologist report is severe atrophy associated with supraspinatus and infraspinatus. And that's the bottom line. There's no muscle left. It's just fatty infiltration at this point. There's nothing to repair, right? There's nothing to repair. And so that's really the bottom line here. And so interesting case, and you can still treat these patients and still get a decent outcome, right? It's going to take some time, but you think about these secondary stabilizers, the shoulder, that type of thing. But again, think about imaging for the rotator cuff. Number one, you want to get that AP and that outlet view, get a comparison of the other side too, and see if you have a high riding humeral head. And then for the MRI is great because it's going to tell you if there's a tear or not. They're going to be able to tell you the significance of it and that fatty infiltration. And once you get that fatty infiltration, the ability to repair it really makes it difficult. And so remember, he fell 4 years ago. That's probably when you need to get worked up, right? And so if you're dealing with younger people, younger patients who have trauma and a potential rotator cuff tear, you got to work them up quick because what ends up happening is the tendon retracts and then the muscle atrophies. And then if you go beyond probably 4 or 6 weeks, the likelihood of successful repair drops significantly. So in younger patients, you want to make sure you work that up. Yes.
When you say high riding humeral head, are you
Yep.
talking about a decrease in the subacromial space?
Yes.
Okay.
Yep. Yep. And the only way you can see that subacromial space is with this outlet view, right? Go ahead.
How soon did you say that surgery should be done?
Yeah, I mean, in talking to orthopedic surgeons and knowing that we've been burned by young patients who've had, you know, because you can get an older patient as well, but the concern would be in these younger patients, less than 50, who have trauma to the shoulder and tear their rotator cuff. You probably have about a 4 to 6 week window to repair that and have a good outcome, because otherwise, as the tendon continues to retract, the humeral head begins to ride up, right? And everything begins to atrophy because, they can't lift their arm past here typically. You know what I mean? And so the one thing that we used to do in the military, don't do it anymore, but, the one thing you can do, because there's always pain associated with this. And so you don't know if it's a frank cuff tear or not, because all that weakness, right, is typically associated with pain. So if you put a needle into the subacromial space, this is what these primary care docs, when I was doing my fellowship, would do, to determine quickly. You put a needle in the subacromial space just with a numbing medication just to make them feel better, take the pain away, and then repeat the exam, right? Remember the one primary care physician would call it the Napoleon sign, right? He knew to do thumb up this way and thumb down this way. So they're weak. We inject them with some numbing medication. Now all of a sudden they're strong, right? They're strong right here. That's not a cuff tear, right? That's just a nonspecific shoulder strain, right? That can be managed probably without diagnostic imaging, right? And so little tricks like that sometimes help, with these complex cases here when you're dealing with patients who potentially have these type of pathologies. Any questions on that at all? Yeah, and let me just give you one other example here. That you don't have to have a lot of diagnostic imaging for this. And so again, this triad of weakness of supraspinatus, right? Either thumb down or thumb up, weakness of external rotation, right? And then a positive impingement sign. If you're over 60, you only need 2 or 3 of those with a 98% chance of a tear. The kicker is, though, that weakness of supraspinatus external rotation can't be inhibited by pain. So it has to be a pain-free, because once it's weak due to pain, you don't know if it's pain inhibition or not. So that's where those little tricks, like you guys can't do that. But what I would say to do is do whatever you can to calm the shoulder down and then reevaluate and see. We take that pain away, right? Take the pain away. How's the weakness going to change? Because if it's a cuff tear, it doesn't matter if there's pain-free or not. They're going to be weak. Yes.
Yep. No, I was waiting for it to load. So with the patient like that, the one with the fatty infiltration,
Yep.
what do we do to help?
PT-wise,
Yeah.
anything you can.
Okay. So
Whatever's left, you're going to strengthen.
would there be any surgery? Would a shoulder replacement do anything?
could.
If there's not.
You
Okay.
could now if he had OA, right? But he doesn't have
Right.
He doesn't have OA, and this probably isn't. Again, this is a discussion probably for another day. But there's an AP, and there's also a true AP, right? In a true AP, because you figure that you got the scapula laying on the shoulder blade, and then you have the humeral head. A true AP would be angled through the joint line. This is just a routine AP, so you can see overlap right between the humeral head and the glenoid. A true AP, if you were concerned about shoulder OA, you'd want to get the true AP because it profiles the joint line. And I don't have that in here. This is just a routine AP, right? And this guy knew enough to get these orthopedic surgery. If you look at that handout I gave, these are orthopedic surgery views, AP, outlet, and then an axillary view. But what I would say is that if he can only lift his arm to here, I think I'd want to make sure that he has full passive range of motion. Because now if we're dealing with some types of adhesive capsulitis, that adds a whole nother layer to this as well. So I think as long as he has full passive range of motion, you're going to try and strengthen anything that you can that's left, and hopefully there's actually decent evidence that they can have a positive outcome. You do anything you can to stabilize or strengthen up any of those secondary muscles that can elevate the shoulder. And so that would be the key with that. Because in the differential, again, if you think about this, when we present something like this to students, they're weak here and they have active range of motion 85 degrees. Well, could this be a frozen shoulder? It could be, right? There could be an element of frozen shoulder, but if we say he had full passive range of motion, that takes that off the table there. Very good. All right. Let's present another one to you real quick here that shows you that outlet view again and how that's helpful. And so this is an 18-year-old male going down 2 cases down in the shoulder, but this is an 18-year-old male baseball player, high level, thinking about playing in college, shortstop. He's unable to throw due to the pain. He's had shoulder pain on off for the last 2 years. And the last 2 months that he took off, he's not responding to rest. It's a kid from California. And they play baseball almost year round down there. And so he took these 2 months off, hoping to get better, didn't respond. He has secondary impingement, probably an unstable shoulder to some extent, but he's unable to, got better, right? His physical exam improved with PT. So he got a little bit stronger, right? His impingement sign started to diminish a little bit, but the bottom line was he tried to complete a throwing program and wasn't able to do it. His primary symptom complaint is this intermittent sharp pain and a catch, right? When he elevates his arm, especially with throwing. At some point, you'd probably want to image this. And so the kicker here with him was this outlet view. Remember the outlet view? It profiles the acromion, and you can see his acromion right here, right? Kind of hooked down like that. So he had a type 3 acromion. And I don't care what you say, you can do anything you want for this kid, but this kid's going to have surgery to take care of that. And that's exactly what he needed, and he did fine. But if you want to profile the acromion, so these would be for patients who have, right, impingement signs that are not getting better, right? You can take a look at the acromion here and try and profile that. Because we know with pretty good literature, it's been around a long time, that these folks who have these type 2 and type 3 acromions, they're not going to respond to conservative care, right? Especially anytime they elevate their arm because of that acromion kind of coming down. Right. Any questions on that at all for the shoulder? We do one more that kind of was an interesting case here. So this is a woman, if you look at her body diagram, again, kind of interesting because she developed shoulder pain following a fall. She's 70, following a fall, right? And you look at her body diagram again, and there's a couple things that kind of shake out here. So this has been going on for 3 weeks. Anytime you hear a patient telling you that after 3 weeks, my pain is still constant, right? And sometimes you have to clarify that, right? So is it pain that's there all the time? It's there all the time. So do you happen to have it right now? No, I don't have anything sitting here right now. Okay, that's fine. I used to argue with patients. That's probably why I have an ex-wife. I used to argue with her too, but I don't argue with patients anymore. You just want to find out, right? So it's not constant. But she said, yeah, it's there all the time. It hurts while I'm sitting here right now, but I also have this tingling down into my hand. So I don't know about Arizona, but in Buffalo, we are overwhelmed with McKenzie therapists, right? McKenzie therapists. So everything is prone press ups for the back, right? And everything is retractions for the neck. And if they were here, I'd say it. That's 90% of what these patients get, right? And so every time I get a patient, just had one, former college wrestler, rugby player, it's his bucket list. It was one of our students' husbands, right? And he wanted to try and run a marathon, right? And that was on his bucket list. Older, you know, not young, I think 30, but you know, she was a little bit of an older student. For us, 30. But you think our students are 22 years old. He was 30. Now that's all right. That's all right. But he's not a 22-year-old kid married to one of our 22-year-old students. And so, but you know, I knew I was concerned because he'd seen a therapist in Buffalo. And I said, well, the clinic's all McKenzie. I said, what they have you doing? Prone press ups, right? Prone press ups. And I'm like, you didn't respond to that, did you? So I said, we need to get an x-ray, right? So he had like a grade 2 slippage, right, of L5 on S1. So he had a spondylolisthesis. But this is the same thing here. So this person first saw a McKenzie therapist. And when they hear tingling in the hand, that's all you're going to get is this, right? And I don't mean to bang on them, but I mean, that's what they're thinking, right? And when I said this before, and it's a good example, that when you start thinking about a pure McKenzie therapist, right, they don't do stabilization exercises. They do thrust manipulation very, very late in the game, right? And they're looking at repeated movements. Nothing wrong with that. But I think there's good evidence that we should be strengthening stuff. And if they were here, I'd say it. And if you talk to them, they'll tell you, well, that's how I presented at the courses because that's what we have to say. But in my clinical practice, I do things a little bit differently. You know what I mean? Just saying. So anyways, she saw a McKenzie therapist for 2 weeks, right? Went on and wasn't getting better. wound up seeing another therapist. Therapist was on vacation, who wound up going through the exam 3 weeks out. Again, she's still constant, right? Constant pain, tightness in the upper trap. Look at her physical exam. So active and passive shoulder flexion to 90 degrees. And it was an empty end feel, right? So get it to here. Can I go any further? I can't. So it wasn't necessarily stiff due to capsular stiffness. It was just limited by pain, right? It was limited by pain. It's kind of locked down. Weakness and external rotation, abduction, again, limited by pain. And this was the kicker. When you do turn her head to the left, right, it does increase the tingling in her hand. Just curious, ma'am, how long have you had that tingling in your hand? For probably about a year. Okay. So there's the question. Is the pain in your shoulder related to the pain in your hand at all? Well, what do you mean? Well, when your shoulder starts to act up, does your tingling get worse in your hand? No. When the tingling gets worse in your hand, right, what makes that worse? And she said, if I turn my head or if I'm reading or something like that, does that make your shoulder worse? So there's no relation between the tingling in her hand and the shoulder. And that's important, right? Because if you hear tingling, you're going to think neurologic concerns. But she had, now again, a fall in an older woman, right? And when you look at her shoulder, I don't know if you guys can pick it up, but that's 3 weeks out. That's her shoulder. So there's still bruising there, right? So she still has bruising in her shoulder 3 weeks out, right? And so we got a plain film on her, right? And this is an AP. So you can get, for the shoulder, you can just get an AP internal and external rotation view. That's perfectly fine. And that's on your handout that you got. It could be an AP internal, external rotation view. That's it. That's all we have here, but it doesn't look like she can move very well. But you can see the fracture line. This is the internal view here. You can see the fracture line right through there, right? And again, when you start to look at things like this, and she has some osteophyte formation under here, so she has likely, there's also a little bit of a fragment up here in the subacromial space. And I think I have her radiology report actually down here. Let's see here. So let's see what they said here. And her first initial and last four of her social, which I shouldn't be sharing with you guys probably. Sorry about that. But yeah, so mildly comminuted, impacted fracture of the humeral neck, diffuse osteopenia, right? You see a little bit of blackening in through there, all those shadows in through there, right? Subchondral cystic changes would be these little black circles in through there. That's consistent with OA, right? Glenohumeral joint space loss, you can see that. That's consistent with OA. And then these calcific fragments that she's talking about up here and there. And so it's a mildly comminuted, impacted subacute fracture of the humeral neck with underlying osteopenia. She was left to be treated conservatively, but at least it was nice for her, nice to know that that's what the cause of all my pain is, right? And we can still treat you in PT. We're going to back things off a little bit, but you should feel better, right, in time with that. So, yes. No way.
So for the previous case, the 18-year-old baseball player who
Yes.
had the episodic shoulder pain for 2 years, I'm assuming he didn't just start picking up baseball in the last 2 years, that he was playing prior to that,
Yep.
but he experienced no pain prior to that, even though he had a type 2 acromion probably his whole life.
Yep.
Why would it suddenly appear in the last 2 years and not prior to that?
I think the only thing I could think of, and I don't treat shoulders anymore. I haven't treated a shoulder probably in 10 years, but we saw these a lot. And especially when I worked at the Air Force Academy, a lot of these kids had hypermobile shoulders. The only thing I can think of is that over time, with all that throwing, I think things just get loose and get kind of sloppy. So they get that secondary impingement due to instability, due to unstable shoulder. I mean, I remember he had a positive sulcus sign. You could apprehend him out here, so any position you put him in, you could move his shoulder really, really easy. So the only thing I can think is that over time, some of those secondary restraints probably became affected, just more movement in the shoulder, and that humeral head was probably stabilized, and as he gets more pain, There's likely more weakness associated with it. And so even though his signs and symptoms got a little bit better with some visits with PT, 5 visits over like 6 weeks, it still didn't allow him to get back to that throwing program. And so I don't know. Is anyone else? You guys probably treat shoulders.
Shoulders ever, but as he ages, he gets older and stronger, there'll be more force that generates when he does throw versus
Yep.
when he was like a 10-year-old.
It's true. It's true. It's true. Yes. Sloppy mechanics after a while, Wayne said, and you said, yeah, they're generating more force. That's true. Generating more force.
Quick relation. I had a patient. He was pitching since he's 5 years old. His father was his coaching for pitching. Was 19, being scouted by the major leagues, had a 94-mile-per-hour fastball, and he came in exactly with the same thing.
Yeah.
And that was at the end of his career before it got started.
Yeah, I mean, it's a different world with these kids now. We don't even have to get into it, but I mean, Skeen was throwing a no-hitter the other night, and they stopped him at what, 80 pitches? I mean, Nolan Ryan was throwing 140 pitches at 100 miles an hour on 3 days rest and never had a shoulder issue or an elbow issue. I don't get it, but I mean, that's what I mean, though. You know what I mean? Who'd warm up by throwing a football, right, in a half kneeling position, but it's a different world today. I mean, I don't know, but that's a really good question, though. All right. Yeah, and so that would be your routine view. So I could pull that form back up, but if you look at that form, I'll pull it up. It's easy. I'll show you guys. Go all the way back to the beginning from today. I think Krista had sent these out to you guys. Hopefully, if not, I can send them to you. But your basic study for the shoulder could just be an AP internal external rotation view. And that would be your two views, technically at 90-degree angles to each other. That would be it. I mentioned the ortho views. True AP, they try for a true AP. It's tough to get it, right? Because you have to get the angle just perfect to profile the joint. But it's an AP, an axillary view, and a scapular outlet that we just talked about, right? And then if you were concerned about subacromial impingement, right, you could do the AP internal external rotation view to profile the shoulder, right, the glenohumeral joint, and then you could include that scapular outlet view as well. And so I think the shoulder, like I said, I think it's a little bit tricky when it comes to all this. But, those Hill-Sachs lesions, the Bankart lesions, things like that, they show up a little bit better. The AC joint, you can stress view where they're actually holding a weight to stress the joint. That patient with the rotator cuff tear, we didn't even need to do that, right? He had that step off already that you could see when he took his shirt off from an old AC joint injury. And so there's a lot. Shoulder's complicated. And, especially when I talk about the MRI and all those crazy views and things like that.
Been any scientific study, diagnostic study, that says at 80 pitches you stop them?
I don't think so. I think they're just worried. I mean, that's their whole investment.
Well, yeah, but Nolan Ryan was an old partner and he was throwing 150 pitches.
I know. And that kid was throwing 120 pitches on average for his college skiing. I think I heard that this morning, that he's used to throwing. So I don't know. All I can say is that working with athletes, I mean, we have a rotation with the Buffalo Bills, and I can't believe some of the stories I hear from the students that were there. I mean, I don't know. It's a different time, different place. Like you would think with sports science the way it is, nutrition the way it is, all the coaching, all the biomechanic data that we have, that I'm surprised. But they're worried about elbow issues. And, people in here who aren't sports folks are saying, what are we talking about here? But it's a big concern. If you work with young athletes, it is an investment. I mean, look at, throw another one out, Shohei, right, for the Dodgers. I don't know. How's that kid pitching and hitting, and now he's, I don't know if he'll ever pitch again, right? What's his second Tommy John surgery? And oh, what was he making? Like 700 million or something? He still can hit, but I mean, I don't know.
Just a quick question on the shoulder views that you have up
Yes.
here. I was trying to see if I could see it up here. Every once in a while in clinic, we hear Y view. Is there something that's synonymous with Y view?
The scapular Y, the transcapular Y is like the outlet view, but it's just angled at a little different view. So you can see that Y view of the scapula. Yep. Yeah. And that, like I said, for a fracture, that's what we want to look at, because you could have a fracture that goes up into that part of the scapula, and that would pick that up. Yep. That's the transcapular Y. Very good. Let's talk about the elbow a little bit. Elbow. There is a clinical decision rule for the elbow that I think is helpful. And so we'll talk about that here in a second, but your routine views for the elbow, really easy, AP and a lateral view, right? So here's your AP view right here. Nice profile of the humeral head and the capitellum, right? And then here's your lateral view right here, right? And so we'll give you a quick patient case to kind of help with this a little bit. So a 44-year-old male electrician was up working on a step ladder and fell off that 1 week prior. So his elbow pain still bothering him. Seen by the physician the day after the injury. And this is the reality of clinical practice here. They ordered films and they sent the guy to PT. I think presuming that the films were going to be negative. So the guy shows up at PT with the films in hand. Again, these were hard copy films that they gave him. He was seeing a workers' compensation physician. They gave him the hard copy films, but the films had never been read. So there was no read in the system. So how the patient got the films and wherever they were in the system, it had never been read. And so he's referred to PT, like I said, I think with the thought that the films are going to be negative, it's a non-specific sprain strain, go ahead and rehab. Passive range of motion of the elbow, and this is the important point here, painful and limited. Limited, couldn't get to full extension, and limited in terms of flexion, but the most pain was with extension, and this was passive. Couldn't get him straight. Look at the body diagram again. He's a week out, constant low-grade stiffness, and if he tries to extend his arm, he gets that intermittent pinch in the posterior aspect of his elbow. So would you look at his films? Why not? They're not going to take your APTA card away. So first off, should he have imaging? He should. And this is pretty easy here. And so there's 2 studies that have looked at this that have been validated pretty good. So these, again, emergency room physician journals, right? And so if you don't have range of motion, if you have trauma and you don't have range of motion equal to the opposite side, go ahead and get films, right? And then even on patients who have, right, normal extension, flexion, supination, you don't have to get imaging. And so what you want to do here based upon this one, if you don't see equal range of motion side to side after trauma, go ahead and get films. I think the bigger movement though, based upon this one, is that extension's really the kicker. So if they can't extend their elbow fully following trauma, right? Following trauma, you probably want to go ahead and get radiographs. And then again, if you have a patient who can fully extend their elbow, radiography is deferred if you don't think a fracture is there, right? If, however, the patient comes back 7 to 10 days later, right, and they're no better, despite what you're doing, you probably want to get imaging, okay? 7 to 10 days, things should calm down a little bit, which is the appropriate treatment. But this would speak to, right, if you decided, right, to not image them, right? Because again, they have full extension, but if they're not better, you probably want to look at it again. But anyways, let's look at his films. So here's his AP and his lateral view. So for the sake of time, I'm going to show you what this normal radiograph looks like. And when you palpate over his radial head, he's tender, right? That's where his primary tenderness is. And so if you look at that normal radial head, right, you see this nice, smooth transition here. What do you notice here? Yeah, so there's no 90-degree angles between the radial head and the shaft of the radius, okay? So this is the concern right here, and you'd say, I would never notice that. And this is what I'll say. You come to a course like this, I don't know, your background in looking at this type of stuff, but the only way you get good at diagnostic imaging is just to look at films. I don't care what they are. Normal, abnormal, doesn't matter. Online, look up stuff. You just have to study them, right? And you'll pick it up over time. And the good news is you got radiologists who sit in dark rooms all day, introverted, and they just want to talk to somebody, right? And so, you know what I would tell you? Because all of you guys can order imaging. I don't know where you're sending people, if you're sending them to your hospital physicians or you're sending them to a private practice center, but I would say spend a couple hours with these guys and gals. Go hang out with them because they all do different things. And if you're musculoskeletal, find out when they're doing their musculoskeletal day. So if the general radiologist, they read everything. They have half-a-day mammograms, they're doing chest films, they're doing MRs, gastroenterology studies, but find out if you have maybe even a musculoskeletal fellowship trained radiologist and hang out with them for a morning when they're doing MRIs. And then hang out with a neuroradiologist and see what they're doing in terms of brain and spinal cord. And just hang out for a couple hours with them and just get some tendencies because you'll learn a ton just by hanging out with them. Hang out for a plain film day. How long are they going to take to interpret this? Plain film day, this might take 30 seconds. It's up, it's dictated, and they're out fast, right? They're not going to sit around and study this stuff because they've seen it a million times. So he had this impacted humeral head fracture, a radial head fracture, this D right here. There's a couple other things. So here is his AP view. You can see that right there. And then here's his lateral view. And the thing about the lateral view where those arrows are pointing, the arrow here is pointing to the radial head and its angle on the radial shaft, right? The proximal radial shaft. You can see that 90-degree angle. That's not normal. This is pointing to this lucency, right? So this darkening that we see right here, right? That's called a sale sign or a fat pad sign, right? And so I'll show you this right here. And so kind of a complicated image, but that's an elbow, a coronal view. So we're looking at it from the side, right? And T1, it's a T1 weighted image. So the bone, which is fat, shows up bright. So here's the trochlea here, right? And then here's the olecranon. This is the fat pad in the coronoid fossa and the olecranon fossa. Here's the coronoid fossa right here and the olecranon fossa. It sits in deep, right? That's fat that sits in there deep. However, when you have injury to the elbow, you get a hemarthrosis swelling, just like you would at the knee. That swelling intraarticular pushes the capsule out and it pushes the fat pads out, right? So now you can see them. Remember, fat is going to be relatively radiolucent, so you'll see it as a darkening. So here's a normal elbow here, right? And then here would be what we call a fat pad sign, where you see that olecranon fat pad being pushed out and then that trochlear fat pad being pushed out, right? So it's being pushed out. And anytime you hear that, they may say there's no evidence for a fracture, but there is a positive fat pad or a positive sale sign. If there's trauma, I would just treat that as a fracture. That's pathognomonic for a fracture. What if they didn't have trauma? What else could cause that? Then it could be some type of an infection, right? There's something that's causing an intraarticular swelling associated with that. And so if there wasn't trauma and they had elbow pain and this stuff showed up, really ask him, any falls, right? Any trauma to your elbow at all? And if there's nothing, right, now you're concerned about possibly an intraarticular infection or whatever would cause that degree of swelling. What's that? Gout. There you go. The gout. You've been eating any organ meat, sir? How about sardines or anchovies? We'll talk about the gout a little later. Did someone raise their hand? Question? Yeah, it's a good point. So fat pad or sale sign again. Yeah. Okay. We'll go through the wrist real quick. The wrist is the one area that we do a PA view. Okay, so in orthopedics. And so everything else is pretty much AP. But an AP for the wrist would have to be, they would have to fully supinate and place their hand down on the film plate. And sometimes they can't do that. So we just say, just lay your hand down this way. So it's a PA view. So if you're asking for films at the wrist, it would be a PA, a lateral view, and PA, lateral view, and you can also get this PA and ulnar deviation. The PA and ulnar deviation is kind of cool because it gives you a nice profile of the scaphoid. So before, let's say you have a foosh, just make sure you palpate the scaphoid, right in the snuff box. If there's palpatory tenderness, right, go ahead and get a routine PA, get a PA and ulnar deviation, and you'll always get your lateral view as well, right? So get those films, but it's a PA that you're getting. And again, if you have an order set already built into your EMR, if you work at a hospital, it might say wrist 2-view series. But then you got to figure out what your scaphoid view would be, right? And so these are just images of a scaphoid fracture here, of what it would look like. And these things, this is a patient that was actually seen. This was, I don't know if I have it in here, but it's a patient that was actually seen following a fall, following a foosh, and the plain films were negative. He was a kid who weightlifted a lot, so he was bench pressing, right? And he couldn't get back to high level bench pressing. And so 6 months later, you see this non-union here of the scaphoid. And I knew I put something in here someplace. Yeah, here's his case right here. Yeah, so 22-year-old kid, worked in nutritional medicine. He had a fall 5 months prior, never really got back. X-rays were done at that time and everything was normal. But it's not uncommon. So here's the film 5 months prior, right? You can't see a fracture there. So I would tell you that you don't even need to probably even get plain films for this. If you have tenderness at the scaphoid following a foosh, they need to be immobilized for probably minimum 2 weeks. That's probably the standard of care. The problem with this is that the farther you get away from the distal pole of the scapula, or I'm sorry, distal pole of the scaphoid, the less blood flow that you have, right? So if his fracture was in this region right here, he has anywhere between a 60 to 80% chance of that would be 20 to 40% chance of non-union, right? And the farther you move down proximally, right, that's your biggest chance of non-union there. And this causes a ton of disability in people, right? People don't realize when you break a bone in your wrist and you have just chronic pain, you can't do anything with that hand. And so this is one of the top 3 reasons ER physicians actually get sued, because of missed scaphoid fractures. They get the plain film, plain film's negative, and they don't do anything about it. But if you have tenderness in the snuff box, right, you go ahead and you keep that patient immobilized every 2 weeks, check them, palpate again, and you could get the film at that point, but sometimes it doesn't show up. That MRI paper I gave you guys from Gail Dial, he does a nice job of articulating what the next step for imaging could be, because you could get a CT scan. You could also get an MRI for that as well. But again, the treatment's going to be the same. They're going to be immobilized right off the bat for that type of thing. Right. One other quick case. So the other thing I'll mention is that when you look at the wrist, I don't know, but I think the wrist and hand is always complicated, right? It's always a very complicated area. There's alignment concerns that we always want to look at. So there's normal alignment. So these scaphoid bones, like I said, these are bones that get missed a lot in terms of fracture. They're small. The fractures, need to be pretty significant to get picked up, but there's 3 arcs, right? These arcuate lines. Arc 1 is here, right? And it outlines the proximal articular surface of the lunate, the scaphoid, and the triquetrum, right? Those 3. Arc 2 is the distal convexities or concavities of those same bones. And then arc 3 is going to be formed by the capitate and the lunate, right? Those lines there. So it should be those 3 lines. And that's really your alignment when you start looking at the wrist. And this just gives you an example of where those things don't line up. Here's your scaphoid, right? Here's your lunate. Here's your triquetrum here. And here's your capitate coming down on top, right? This is actually like a dislocated capitate bone here, but the arcuate lines are completely off here, right? That's something you can just kind of look at, right? Those lines are not parallel. There's disruption of them, and there's likely concern associated with that. But this is an interesting patient. So this was a patient who had a long history of wrist pain. And so she was 75 years old, retired homemaker, 5-year history of this, and it was worsening. So she had this low grade, constant varying deep ache. And if you've ever had wrist problems, I was in the military for 20 years. And I mean, between treating patients especially after my fellowship, manual therapy, and doing all these push-ups they would want you to do, my wrists were always killing me, and you wake up and it's the first thing you grab it's like, it's back, you know what I mean? And it just hurts. And so I felt for this poor woman, because she had that constant low grade ache. If she moved her arm, this intermittent, severe, sharp pain. So she's to the point now that she can't even really use her hand for even simple tasks. The precipitating trauma she thinks was a fall like 30 years ago. She had wrist pain on and off, but it's really bad for the past 5 years. And then her physical exam, about a 50% motion loss, right? She can't move it as far. Flexion extensions, everything's limited. So if you look at the radiologist report for the plain film, mild to moderate OA. Now she's seeing a PT. Now, what do you guys do for OA? You mobilize stuff, don't you? You mobilize joints, right? How do you think she did with mobilization of her wrist with her mild to moderate OA? Not good. So sent her off to an OT who was a certified hand therapist who looked at the images. And here were her images. Okay. These are her images. So the lateral view is kind of tough to see, but here is her PA view right here. And I'll put, see if I get, all right, I got the normal here. So here's the normal view, right? So here's the scaphoid lunate interval right here and the capitate. What do you notice about her scaphoid and lunate interval? There's a gap there, right? There's a dissociation between the scaphoid and the lunate, and her capitate is sliding proximal, right? So depending upon when your radiologist would train, they might call this the Terry Thomas sign, the David Letterman sign, and I even heard there's rumors that that's the Michael Strahan sign now amongst more contemporary radiologists. But it's a gapping between the scaphoid and the lunate, and this sets people up for prolonged disability. And so the other view you can get, let's say you get these views and you palpate right over that region and it's painful, and the AP view doesn't show anything. The other view you can get is what's called the clenched fist view. The clenched fist view will cause, if there's a separation, it will cause that thing to gap even more, and it'll push that capitate into that gap. So what does she actually need in terms of treatment? So all that mobilization that you guys were doing, right? Taking her home and do those ball squeezes. What are the ball squeezes doing? Just gapping it even more, right? So what did she need? The PA just put her, or the OT just put her in a little off the shelf cock up splint. And within a week, she felt a ton better, And then it was interesting because in talking to her husband, he goes, she's sleeping in the brace, but I don't know if you knew, she slept with her hands up around her head like this every night. So she was sleeping with her hands up in this forced flexion. So the brace actually helped with that. So the OTs treat wrists and hands much different than we do as PTs. I don't know if you guys know that. But sometimes for the wrist, I think this is one area that it's not sometimes a bad idea just to immobilize them a little bit and see what that does. So again, this would be related to trauma. And if that doesn't get fixed, right, that could be surgical early on, or it could be a conservative management to hopefully hope that that ligament heals that's holding those two bones together. Otherwise, you're going to have issues. Right. Let's go ahead and take just a quick break. This is my plan. I'm going to come back. Let's take 5 minutes just to stand up and do what you got to do. I'm going to cover a little lower extremity, but I want to do 2:30 to 4:30 on medical labs. Okay. So I got about 45 minutes to cover a little lower extremity. And you've already got some of the principles though. So this should be a good 45 minutes. Let's go ahead and take a good 5 minutes, get some fluids. Still teaching at university? Damon. Huh? I teach at Damon. At Damon? Yeah, they used to be a college at their university. From Boston. Yeah. So. Moved you up? Yeah, well, it was default. After you would be an associate professor, you have to actually see PhD or equivalent for. Very good, sir. All right, let's go ahead and get started. Right. Ready? Questions on anything? Upper extremity? Right, so for the lower extremity, let's start with the hip. And I just want to give you guys the routine radiographic views that you have an option of ordering at the hip. And so there's always going to be an AP variant, right? There's going to be an AP variant. So you could get an AP of the pelvis. You could also get an AP of one hip. Now, the AP of the pelvis, the beam goes right down the middle, right? Right down the middle. So what you could potentially get is really, really good imaging, but as you move laterally, you might lose some of that detail. So if a patient, let's say, had maybe following trauma, they had significant tenderness over the greater trochanter, and that was what you really wanted to see, and you weren't concerned about the other side, you could just get an AP view of that side. Okay, the beam's now going to go right through the hip, and you'll probably get a better view. If you want a comparison, that's why this is really, really good. And so this is a great view, especially you want a comparison. And for hip OA, right, you definitely want to see that. What clinical findings would lead you to hip OA? Age, right? Age, lack of morning stiffness for more than 30 minutes, and then decreased flexion and decreased hip internal rotation, right? Those are really the four key findings that we look at. 115 for flexion, 15 degrees for internal rotation are really the two main range of motion findings that we see. And that's according to the American College of Rheumatology too. And remember, you're going to need a second view. So the second view isn't like a cross table lateral. The second view is going to be this frog leg view. That's called the frog leg lateral projection. And so you get a nice profile, lesser tuberosity, but this is your second view for these particular patients, okay? So your AP and a frog leg are going to be your routine views. Let me mention one other thing real quick about labral tears. Labral tears are challenging to diagnose. Depending upon the size of the magnet that you're dealing with, you might be able to get away with some of these 3 Tesla magnets about picking these labral tears up. But I would say this is, if you're concerned about a labral tear, I would say consult with a surgeon first. Because in my mind, and I think you look at, again, all those websites that we talked about, the ACR appropriate criteria, they're still recommending hip MR arthrograms. So an arthrogram would be contrast medium being injected into the hip, okay? And you inject the contrast medium into the hip. And the other thing you do is you can add a little bit of anesthetic medication into that as well. And so I think I actually have the radiologist report for this one down here. And so, yeah, and so you would do gadolinium with an intra-articular steroid, and Marcaine would be your anesthetic. And I would tell you that, you know, for this particular patient, I actually went with him for the MRI so I could examine his hip, because these labral tears, right? I don't think when some of us went to school, number one, there wasn't a vestibular system. And I don't think there was hip labrums. We didn't learn about the hip labrum, right? It wasn't until somebody figured out how to design a table, right, and do hip arthroscopy that the labrum really kind of blew up, right? And so these were physicians on the University of Pittsburgh, right, who were just so uber focused on this disorder that their outcomes were great, post-surgical outcomes. But now you take a weekend course, you got the right surgical equipment, everyone's doing labral repairs, and the outcomes aren't that great. One of the reasons is that this stuff shows up on normals all the time. It shows up all the time, labral tears, right? And so the reason that I think that you want to do the Marcaine, probably even more so than the steroid, is to evaluate the hip following the injection, right? So the MRI is going to be done. It's going to show, right, they possibly have a labral tear. And it's not very scientific. What you're looking at, this is like the old days of an arthrogram for the shoulder with contrast medium. And I guess you could still do those, right? You're looking, all this white stuff here is the intra-articular contrast medium, and this is the labral tear, right? Because that contrast medium should not move up into the labrum if there's not a tear, right? But if there's a tear, now the contrast medium is going to move up. And these are 3 sections separated by probably 2 or 3 millimeters. So you're talking about a labrum tear that's probably pretty significant in this person. But the question is it a symptom generator? So I actually went and evaluated his hip afterwards because I knew what his comparable signs were, and he was better. So if you probably want at least a 50% improvement in their physical exam with the Marcaine or whatever anesthetic they're going to use before you consider the labrum as the pain source. Otherwise, they're going to repair the labrum and they're not better. It was likely an extra-articular concern or coming from someplace else. And you guys know how complicated these patients are. I mean, the SI joints there, all this other extra-articular stuff, lumbar spine, etc. And so if you have concerns over a labral tear, right, I'd say probably consult the surgeon first and see what they want to do before you go down that road of ordering diagnostic imaging and such and, you know, come up with this stuff. But that's a hard one to try and figure out sometimes, I think. The other concern, if you're working with athletes, are going to be femoral neck stress fractures. And this is something that you definitely want to be cognizant of. And so I'll share this case with you here. 42-year-old man. He had an onset of symptoms 5 days ago. His onset occurred during a 3-mile run. So he was actually a military person who was in a position that he didn't have to do any physical activity, went to a new unit. They trained every day. They would run 3 to 5 miles every day. And so he was into this now for probably about a month. And then 5 days ago, he felt this pain come on, and he hadn't run probably in a year. And so you can see those arrows, sharp shooting pain, the front and back of his leg. The onset of pain came on during a 3-mile run, and he wasn't able to continue. Aggravating factors, walking and even lifting his leg makes it worse. Negative lumbar palpation, and look at those range of motion findings. All we could get was 70 degrees, it wasn't me, all we could get was 70 degrees of hip flexion, no internal rotation, 5 degrees of external rotation, and gait was antalgic. And here's his plain film, right? Here's his plain film, right? He was seen in the emergency department, sent to PT, right? And the plain film was read as normal, right? And so you got two choices here as a PT. The differential could be possibly a femoral neck stress fracture, and you could treat it as such and work it up, or you could do what this therapist did and suck it up buttercup. Nonspecific sprain strain, your plain films were normal, and, you know, go ahead and continue to do your thing, right? Don't avoid activity, keep doing your stuff. And so 10 days later, right, he shows up to the emergency department again, can't walk, right? And then here's the full-blown fracture right here, right? So there's the fracture, right? And this patient case was a little bit concerning because they wound up treating him with these screws, and you can see that he doesn't have union, right? This isn't probably the best way to do this technique. There's another way that I'll show you. He doesn't have union, so he developed avascular necrosis about a third to half due, underwent a total hip, dislocated his total hip, had a revision total hip, which got infected. So it turned into a train wreck. And all this PT had to do was offload the person and get a bone scan, right? Or do an MRI, right? Offload it. That had to be in the top of her differential, right? And it wasn't. And so we learned a lot from this, okay? And so I'll say a couple different things here. So stress fractures are challenging to diagnose, especially early on, but you'll know if a stress fracture is present because you could potentially see a little bit of radiodensity in the area of the fracture because the fracture is trying to heal up. So the osteoblast will actually exceed the osteoclasts. And, you know, I talked to a couple different radiologists about this. So here's the fracture right here, right? And this is the area of the fracture on the initial film where there's some areas of increased radiodensity right there, right? That probably was the sign of a femoral neck stress fracture, even though you didn't see the break at that point. And so, you know, this is another patient case. You know, and the military PTs would pick this up all the time at these basic training schools because the basic trainees are not in shape. And they come in and they run and they pound and they develop these, you know, femoral neck stress fractures, which all I'm going to tell you is if you want to destroy a relationship with an orthopedic surgeon, you know, miss one of these. Because at least in the military, all those orthopedic surgeons are typically residents and fellows. And in order for them to get board certified, they have to have every one of their patient surgical cases reviewed. And if you start having bad outcomes, it makes it challenging for them and they don't dig this kind of stuff. 2 questions, yes.
Did you mention bones, why there was not a bone scan? Do they pick up stress reactions?
They would.
Right.
So you can do a bone scan. The bone scan will tell you if there is likely a femoral neck stress fracture, but the kicker is determining if it's on the top or the bottom. And a bone scan won't give you that level of detail. An MRI will, okay? And so this is another patient case, basic trainee, published in this imaging feature here. Kid wandering around for 2 days with this. You know, this displaced femoral neck fracture. And here's another, and this is probably the better surgical technique. So this is actually a pistoning pin for this, right? That'll pull those 2 pieces together, and there's probably a better chance for union associated with that. This is just a quick algorithm that I'm not necessarily have time to go through, but the bottom line is if you have concerns over this, you should get imaging. If the x-rays are normal, still offload them, treat it as a fracture, and go ahead and get either bone scan or get an MRI, okay? And then the bottom line is if it's a tensile or compression sided fracture, that drives the management. And so I'll give you another example here. This is a marathon runner, again, published in this JOSPT cases. Marathon runner with left-sided hip pain, got his MRI, plain films are normal, right? But then again, this is a T2 weighted image. And again, the areas of fracture are going to show up bright white. And so we see a fracture down here. This is actually a compression sided fracture. What do I mean by that? So when he weight bears, ground reaction forces coming up, body weight coming down, right, will actually compress that fracture site together. If it's on the top, like the first patient we talked about, that's a tensile sided stress fracture. And those are absolutely bad news, right? Because think about this. What caused this? Body weight coming down, ground reaction forces coming up, separating the top of that bone, right? And so if you look at this algorithm these Army PTs put together, right, these compression sided fractures with less than a 50% cortical break are managed conservatively, right? If it's a tensile sided compression fracture, those are folks that are going to ortho and they're probably going to be prophylactically pinned. They have to non-weight bear for like 6 weeks. And if those tension sided ones cheat, and they really have to non-weight bear, because if they're weight bearing, they're beating that fracture site up and they could fracture, right? And once they fracture, like I said, the chance of having AVN anywhere between like 30 to 50%, and those numbers are just not good. And so that's the one thing I did want to mention talking to you guys is if you have, but they have to, I come to see you for hip pain. That should be the last thing in your differential is that, well, I'm concerned about a stress fracture. They have to be doing some activity to stress the bone, right? They have to be doing some activity to stress the bone. And so, you're looking for a recent change in activity, enough that would cause, some bony stress reactions. I don't have a picture of a bone scan in here, but the bone scan is just looking at metabolic activity. And the MRI is probably a little, and you'll know because it'll light up, but it won't tell you what side it's on. So then you got to do the MRI. I think if you can do the MRI is probably better because let's say you do the MRI and there is no stress reaction. You're still going to get information about the labrum and all the extra-articular structures in the hip. You guys follow me? So that might help you with your differential. The bone scan is just going to tell you if something is active or not. And that might be enough to say we're going to offload you for 6 weeks, right? But I think these tension-sided fractures are the ones need to go to ortho. I would send them all to orthopedics and let them get the evaluation there. And then they'll probably get sent back to you, but they have to evaluate that. Yes.
So Adi, before you go,
Yeah.
so question that's been sitting from online for a little bit is with all of this imaging of the hip, with the plain film x-ray, do you ever do them standing or is it all supine?
You can do standing, and so you can do standing for the knee and the hip. Yeah, and the standing of the hip, I think actually, and the knee probably gives you a little, and you can do standing of the foot too, because there's these Liz Frank injuries of the foot we don't have time to talk about. But yeah, they're ligament tears between the first and second met. And, you do an x-ray in just non-weight bearing is much different than in weight bearing, right? And it's the same thing with these clenched fist views where you start to add a little bit of stress. And so I think the weight bearing views are actually probably better because it gives you a little better indication of what's going on when the patient likely has symptoms. That's a great question. Yeah. Weight bearing views are perfectly fair. The frog leg you'd have to do probably non-weight bearing though. Too bad you couldn't. Yes.
Just another comment about population that to pay attention to is the female college distance runners.
Yeah, I mean triad. The triad, right?
Yeah. The amenopausal, so hormonally they're
Yep.
susceptible, and then they load the joints way more than they can recover from.
Yeah, if you're dealing with these young women who don't have menstrual cycles, they need to be seen by a women's health specialist. They have to. Because that's not good for anything they got going on. And you know, they're training so hard, and we would see that all the time at the academy. And so they also have likely bone issues in terms of, you know, bone density issues. And a lot of them have body issues too, which relates to poor eating habits. And so I think that's the triad, right? And so that's a bad situation. Yes.
What, okay, sorry. What's your opinion on the tuning fork method for like screening
Yeah,
stress
the
fractures?
tuning fork is definitely something that wouldn't work for the hip because the hip's kind of deep. So you could probably tuning fork that. The one test you could do for the hip is I can't remember the name of it. You put the stethoscope over the pubic symphysis and you tap the patella and you're listening for sound, right? And so pelvic pubic percussion test. So that's probably a better one for the hip because you put the stethoscope over the pubic symphysis and then you either put a tuning fork on the patella or you percuss the patella. And if there's a break, you'll pick that up, right? If there's a break in the bones, that's probably a better test for that. The tuning fork, I think, is an okay method, probably not best, because I remember talking to the fellows from West Point. So West Point probably has one of the, in my mind, just one of the best athletic training / PT fellowships. And I would ask them about, you know, what do they think about that? But these are PTs who have access to anything. But they said it's better than nothing. But the concern would be if you get a false negative. So if you're still concerned about the fracture, go ahead and get the next line of imaging because you have to get that tuning fork directly over the site of symptoms. So you got to have really, really good palpation skills and make sure you're right over the right area.
It's kind of interesting that you say that with the tuning fork because when we do ultrasounds, sometimes they'll have like a discomfort because of the sound waves,
Yeah.
because the vibratory space over fractures. Even if we weren't suspecting a fracture, even if it's like on a tibia or anything that's superficial,
Yep.
a lot of times they'll be like, that doesn't feel good right there. And they're like, wait a second. Now your radar starts picking up.
It's probably a better test is the ultrasound, but let me show you this one here and I'll get off the stress fracture thing, but this is another one here. So this is a 34-year-old, I'm moving my way down to the knee, but since we're talking stress fractures, 34-year-old female deployed. And again, she was somebody who wasn't running at her home unit. Now all of a sudden she's running while she's deployed with her unit and she developed shin pain bilaterally. And so you can see here, so what might you see with a stress fracture? You might see a stress reaction, right, where you see cortical thickening, right? And we talk about soft tissue. Cortical thickening is one of the components of soft tissues when we start thinking about looking at bone. Lots of things can cause cortical thickening, but stress reactions certainly could. You see a little bit here as well. But when you look at her lateral view, you see this black line here, right through the tibia. And if you read this report, and this is one of these cases too, right? So lateral conventional radiographic view demonstrates cortical thickening, right, with stress reactive changes, and all they're going to say is a transverse lucency, right? Transverse lucency. That transverse lucency is what we call the dreaded black line. What happens if this if this woman continues to pound? She's a kid to me, but what if she continues to pound on that leg? What's going to happen? Yeah, you're going to get something like this. This is what's going to happen. So this is Kevin Ware, played for University of Louisville basketball team. University of Louisville had a coach named Rick Pitino at the time who had very, very sketchy, he had a lot of sketchiness, but the medical team, the only reason I know is because last job I was at, one of our faculty members, their son was in the neurology department, University of Louisville athletics. And they said that their whole athletic department was really, really sketchy in how they treated athletes. And so if you had pain, you played. If you didn't play, you lost your scholarship. And so these kids were made to play. And so Kevin Ware actually had a tibial stress fracture that they made him play with. And so I'm not going to show the video because it's hard to get the video on Zoom, but you can just look this up on YouTube and you can see what happened. So he's running, jumps up and lands, and it just snaps. And that is catastrophic. That's catastrophic. So that led to the entire athletic department being fired. Tina, who had some other stuff going on that they overlooked, but after this happened, everything was done there, right? And the good news is the fellow recovered, wound up playing, I think, another university, but that's just, you know, this is stuff you don't want to have happen. And so, again, transverse lucency, what does that mean? It's that black line right through there. You know, she keeps pounding on that, you know, that can't be a suck it up buttercup mentality. That's all I can say. This is the case that I was telling you guys about that dealt with those oral inhaled corticosteroids. And so somebody asked about, well, when would AVN be managed conservatively? When you start seeing this degree of change, right, to the femoral head, there's no coming back from that, right? And he's getting worse. Here's his other side where you see it, and the images are really, really small, and I apologize for that, but there's very, very subtle change, but there's definitely AVN on the involved side, the other side. And so that one here, that's going to be managed conservatively for the time being, but the other side is going to have to be a total hip. And so I said 28 earlier, he was 24 years old. And so that's unfortunate. But like I said, I mean, there's really no evidence that these inhaled corticosteroids were a concern, but I think that had to be related because there was nothing else there for the kid in his history. Let me talk to you guys about the knee real quick. And so the knee is another area that has a lot of complex imaging associated with it. But go back to that form and you can see your routine views could just be an AP and a lateral of the knee. AP and a lateral. So why would you want to get imaging at the knee? If you have any of these risk factors here. So if the patient's less than 12, because the growth plates could be implicated, if they're older than 50, and you want to do a nice physical exam, palpate the fibular head, palpate the patella, look at their range of motion. If they can't flex to greater than 90 degrees, or they can't weight bear, and all you need is really one of those physical examination findings in addition to trauma to say that we need imaging, right? And the cool thing is that if you guys can do imaging, let's say you come in and you see a patient who maybe twisted their knee the night before playing basketball or volleyball, they can't bear weight, you give them a pair of crutches, get some imaging done. If the imaging comes back as negative, they're coming back to see you, right? The problem is if you can't order imaging, what are you going to do? You're going to probably send them to an ED. You're probably going to send him back to his primary, and you may never see the person again. You know what I mean? You may never see him again. And so this allows you guys to work these patients up and then move forward. And then the other thing you want to do too is, if those x-rays come back negative, you can still do a good ligamentous meniscal exam on these folks. Sometimes if they're in pain, it's hard to do that. But if you're concerned about MRI, if you're concerned about ACL, PCL, menisci, go ahead and pull the string on an MRI. I mentioned before a little bit about MRIs of the knee, right? They profile the ACL really, really well, right? And in this particular case, this is a torn ACL, almost looks like a firecracker, kind of goes off in the knee. And I'll just present one quick patient case to you that kind of highlights some of this. And so this is a patient who had, was a soccer player, and he had a varus stress to his knee. And so came in, couldn't bear weight really, really well. And a varus stress would mean, right, he's getting hit on the inside of his knee, right? So his foot was planted, got rolled up on, right, and came in the next day and he had knee pain. And all that showed up, right, was this little fracture right here. And they're going to call that a Sagone fracture, right? And those Sagone fractures probably relate to a little avulsion from the MCL, but it's also pathognomonic for an ACL tear too, that particular fracture. Because think about what happens here. So when I'm hit on the inside of my knee, the first thing it's going to go is what? Right? I'm sorry, the LCL. Yeah, probably the LCL, right? The LCL is going to go first, then probably the lateral meniscus, and then the ACL is going to tear, right? So you're going to get each one of those probably to go. And so if enough force was put on the LCL, right, to get that partial avulsion, you're going to want to do a good intra-articular examination of the knee, right? Evaluate the ACL, evaluate the menisci. And then here's his MRI. And so femur, tibia, coronal cross-section, patella, the big fat pad here. This is where his ACL would be sitting. You don't see it, right? All you see is kind of that mush kind of in there. You don't even see the remnants of his ACL. And then I mentioned about the bone bruising. And so when you deal with athletes, and so one of the athletes that, well, I'm not going to say names, but when you see these NFL players and even college players having trouble coming back 9 months, a year later, it's not because their knee isn't stable and their quad isn't healthy. It's because they're still having pain from the bruising associated with this. And so remember where he was hit, right? He's hit on the inside. You get this gapping laterally, right? And then all of a sudden those bones kind of come back really, really hard. And so all of that contusion that you see on that lateral femoral condyle and the tibial plateau, this probably relates a little to the Sagone fracture as well, but this is all from that rebound effect. When they're hit from the inside, that joint separates and it comes back dramatically, right? And you start to see that bruising there. So that's the bone bruise that you'll see. And that's one of the reasons that it's hard for folks to come back, because it just hurts. That takes such a long time to heal, that bone bruise there. Right. We mentioned one other thing about hip pain in kids. Hip pain in kids, not good, right? The limping child, right? There's books written about these things, and that's not good when you see kids limping for whatever reason. So this was an 11-year-old female who had what she called knee pain for the last 5 months. Had hip pain for the last 5 months. She'd seen her pediatrician once a month for the last 5 months. The primary, and I got to tell you this, I mean, as a military PT, like I had no problem ever, like even getting people out of deployments, getting people off work, getting people out of doing, PT physical training stuff. But it was literally impossible to get a kid out of gym class. That's all I can say. Anything more than 3 or 4 days, it was like an act of Congress, right? To try and get a kid out of gym class. And so this poor girl, little overweight, 11 years old. And, I don't know if you guys follow this, but I mean, not every little kid wants to play dodgeball and volleyball and basketball. So now some schools have some different physical education activities, like maybe yoga or dance or just stretching for kids that don't want to get involved in some of that stuff. But she didn't have that option. And of course, mom and the doctor are saying, she just needs to do it. And, we can't keep writing you these, because she's going to fail PE. And so they sent her to PT, and she's had no trauma, right? And her physical exam now, she's limping on her leg, right? And she complains of this intermittent sharp pain in her knee. There's always a low grade ache. And she also talks about, I can't even like straighten my leg out sometimes. But this is the problem. Her knee exam was completely normal, right? So all aspects of her knee exam were normal. So full range of motion, pain-free with OP, overpressure, and her ligamentous and meniscal eval was completely normal. So this goes back to the second case we talked about this morning. When you have a normal joint, right, but that's where the symptoms are, you have to look to see, is anything referring into that region, right? So the second patient we talked about this morning was this fellow with the large herniation. We thought was causing radicular symptoms, but it was actually his hip. So in this particular case, good PT, you scan the joints above and below, ankle was fine, but the hip, right? The hip was limited in terms of range of motion. I forgot what we said in the paper. I didn't put it in here, but this is one of these JOSPT cases, but she couldn't flex her hip more than 90 degrees, right? Couldn't flex her hip more than 90 degrees. And so you offload them and you get plain films, right? No internal rotation, right? No flexion more than 90 degrees. And when you flexed her hip and kind of pushed down a little bit, that caused pain in her hip, but it also recreated her primary complaint of knee pain, which is interesting, right? And so if you look at these films, So these are AP views of the hip. Here's the right. And sometimes you'll see these here. It's a really good question about the weight bearing. Sometimes they'll put these little magnets here, right? And they have these 3 little BBs in them. And you'll know that if the BBs are in the middle, it's a non-weight bearing film. If it was a weight bearing film, the BBs would be down here at the bottom. Yeah. It's not a magnet, just a circle with those little things in it. So you'll know that. But the bottom line is that if you look at the hip, right, the femoral head should sit a little bit lateral to the femoral neck, right? This is her left uninvolved side. Here's her right side, and what do you note? You note that that femoral head is now flush with the femoral neck, right? So that would be consistent with not avascular necrosis. That would be consistent with slipped capital femoral epiphysis, SCFE. Could lead to possibly Pear's disease and AVN. But the goal here would be to stabilize this in the position that it's in to avoid further slippage. There's a couple other things that kind of intrigued me about this kid. So the first is that you can see how the growth plate is separated a bit here. The growth plate is a little bit separated here, which is consistent with long-term pain. And I don't know if you guys can see it, but look at the bone density of her right femur compared to the left. Does that right femur look darker to you? It does. And so that's that decreased bone density that she has through that entire femur, which would tell you that this is a kid who's been trying to offload that leg for a long time, right? For a long time. And then, when you go back to the pediatrician with this, I mean, it was an interesting conversation. Well, I didn't know. I mean, someone should have told me she had hip pain. And, she didn't have hip pain. Because again, orthopedic surgeons don't like this stuff, right? They don't dig this. How did this happen? 5 months of symptoms and no one scanned the kid's hip? You know what I mean? And it's like, what are you doing here? This was like one of the first cases we ever published in those JOSPT things. If you look at where the screw is placed, so all they do is they just put a percutaneous screw right up and through just to stabilize the joint, right? So stabilize the femoral head. But if you look at this image here, this is what we published in the journal. The screw should cross the growth plate. And it doesn't look like that screw crosses the growth plate, does it? So we actually had a little controversy with this on purpose, but then we had a radiologist write in that said the screw didn't cross the growth plate. Could you please respond? So we published the frog leg view that then shows how the screw crosses the growth plate and stabilizes it. That would be the frog leg view. But that would be the treatment. And I'll be honest with you, with the size of some of these kids we have today, I don't know why this isn't more prevalent. Kids doing running, jumping type stuff, because you think about that femoral head could easily slide down, right? That growth plate on that femoral neck. And I'm surprised we don't see more of this, but.
That screw then impede the growth plate?
It shouldn't. It shouldn't. They call it in situ fixation. So the thought was that, would you try and reposition this thing into a normal spot? You wouldn't. And you just want to put it in the position that it's in. Now, we also have a couple other cases too, where you get one screw in a kid, and they get back to playing running, jumping sports and the screw breaks. And so it gets tricky, it gets tricky. We just wrote an updated book chapter on this, and there's tons of really, really good information about some of the endocrine issues associated with some of these kids and why they're dealing with this. But it's, again, kind of a complex phenomenon. But my point is that if kids are limping and there's no apparent reason why, right, offload them and just get a set of plain films and start to look at it, and just see what's going on.
So make 2 questions. One from online is asking about the dark line around the trochanter. Is that a fracture as well or no?
Dark line around the trochanter. Here, maybe?
I guess.
That would not be a fracture. I don't know. I don't know about the growth plates, but there might be another growth plate out here, even at the trochanter.
Okay.
That would not be a fracture though.
Okay. So then another point, so I've had actually it was a personal case a few years ago where a 9-year-old paying for a couple months. They kept saying that it was a strain of the quad,
Yeah,
and I instructed them to get X-rays, osteosarcoma.
that's just brutal. Yeah, I mean, no offense, but strain of the quad in a 9-year-old. I mean, yeah, yeah, yeah. That's kind of a bummer. That is a bummer.
Yet I mean, went in soon as that popped up on the X-ray. Went to Phoenix Children's, surgery, chemo, everything. She's 16 now, so
Good. It's great. It's a nice outcome. But yeah, I think I overstated it, but that's one clinical population I don't think you mess around with. They're limping because it could be even those more sinister causes too. And again, it's a, the reason I was intrigued by it is because I remember taking a course by George Davies, probably before some of you guys were born. And he was, first off, he's still out there, and he probably taught the best knee course I ever took in my life. I mean, he runs it like he's like a drill instructor, you know what I mean? But I know, I mean, it's incredible. Guy's probably like 80 years old and 2 total hips, and he's still doing, black belt karate activities and running marathons and stuff. But just remember all those sports guys. I mean, in that sports group, I'd even say it, that APTA sports section, there's a lot of old guard still in there, but man, that is some serious corporate knowledge. And anytime I get a chance to hear those guys talk, I always take advantage of how much longer those guys are going to be around. But I remember him saying, that this primary complaint of knee pain could be referred from the adolescent hip, and so they have a primary complaint of knee pain. The knee pain can't be reproduced by any exam, but you go up to the hip and all of a sudden you begin to take a look at that. So we used it, and there's certain departments that, think they know what they're doing. And it's been my experience that pediatricians are actually pretty open to being educated on some of this stuff by PTs. There are other departments that typically aren't. Family practice typically is a train wreck in these hospitals. And if you said, I'd like to go down and maybe spend a couple mornings a week seeing your patients with musculoskeletal concerns, they will say, thank you. Thank you. And please help us. Other departments, I mean, they're a little bit different, right? Where they think that they kind of got all the answers. And so, and that's the challenge. But pediatricians, they were pretty open to, some training, because they don't even know how to screen a hip. They don't know how to do a Lockman's or a McMurray's or anything like that. So they're open to that kind of stuff. Last thing I want to mention about imaging, before we switch off to medical labs, I'll make sure we have enough time for that. Ankle fractures, and when would you want to potentially image for that? So we presented this one earlier today. Again, there needs to be trauma, right? And you're going to palpate the lateral medial malleolus, and then you're going to look at weight-bearing status. And if there's any concern with that, it'd be an AP lateral and that oblique view, right? So those would be your 3 views that you'd want to do. Offload them while they're doing that. And even if they come back, and I would tell you, if it's negative, right, just keep a close eye on, right? Don't have them do a ton of stuff. Just rest it, right? Air cast them, ice it down, and bring them back in 3 days and see how they feel. If it's an ankle sprain, they're going to feel better. If it's a fracture, they're probably not. And you may, even if they're not better, I'd say give them another 3 days and see. And then at that 6-7 day point, go ahead and re-image them, because they've probably not listened to you. They're probably weight bearing. The fracture line will now show up, and then you'll know, but you can still treat it as a fracture. And then the clinical decision rules for the foot. And I would say, even in these folks who have ankle sprains, you want to go ahead and you want to palpate the base of the navicular, or the navicular and the base of the fifth. And again, look at weight-bearing status as well. And I'll give you a quick example here of, this is an interesting case. I don't know if I put it in here. I did. So I got this one. So this was a former patient that we had seen in our practice. And like I said, she texted this to me. So, hi, I hope you're doing well, question mark. I don't mean to bother you, dot, 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 but she fell last week. And she actually was a adult patient with CP, but not the type of CP that is completely activity limiting, but she had CP. And so she fell last week, hurt her ankle. She's not able to weight bear on it. I just wanted to know how long I should wait before getting it looked at. I absolutely not want to waste anyone's time if it's going to get better on its own. Anyways, hope you're doing okay. Again, question mark. I'm not sure if you're going to read this, but here's a picture. Thanks. And so she can't, did she say she can't bear weight? Yeah, she can't bear weight. And there's the picture. So what would you guys, huh? Yeah, she's worried, hope you're doing well, question mark, right? So, you know, I learned, I think all of us did with COVID. I learned a lot, you know, managing patients through, you know, video and pictures and talking to people on the phone and, you know, and so, yeah, she needs imaging, right? I don't need to palpate that. She can't bear weight. She's got bruising in her foot and still a week out. And so, you know, that's probably the mechanism there. I don't think that's her image, but she had this fracture, right, through the base of the fifth, right? And the concern with that fracture through the base of the fifth is that, again, blood flow is not that great. And so, you know, she wound up seeing, luckily in our area, she's a former graduate of our program PT who went to med school. And so she's a female, which is listening to her talk, I guess, really hard. You know, it was like an emotional talk. It was like Women's Day at our college, and they had all these women who had, you know, done great things. And she was like talking about her fellowship and how it was so challenging for her as a woman being in this male dominated profession and how she really had to work hard, and she's great. And so she's probably the best foot and ankle specialist probably in the area of Buffalo, but she was able to treat her. And so she had a decent outcome. But the bottom line is you get something like that, you know, it meets the rule, needs imaging, you know, teach her how to walk on crutches and get her to, you know, a good foot and ankle person who can take care of that type of thing. All right. Questions on any of that? Right. We're going to absolutely do like a 360 shift here, and we're going to switch off to medical labs. And we'll take a break at some point with this too to give you guys one more. We'll go right to 4:30. I think that was the time that we had until. Good. And so medical labs, indications and implications, huh? A couple websites there that give you some good information too. So we just got to talk about a little bit as to why PTs might want to do this stuff. Okay. And so this isn't a medical screening class, but I just have to talk about this a bit. And so I would say that every patient that you see, right, you at least want to do a basic general health screen for these folks. And every patient you see, you're going to want to ask about these questions, right? Is there any, and you can use them on an intake. The only one you can't use on an intake is malaise or mentation cognition, right? If patients have altered mentation, they're no longer adequate historians, and you probably have to get the information from someone else. But you're looking for these type of things. Believe it or not, mentation cognition, one of the reasons we see that, I mean, COVID, right? Why did COVID hit the elderly so hard? Nursing homes. Well, the primary reason is that the elderly lose the ability to generate a fever. So you think about pneumonia being the number one infectious disease killers in the elderly. And so they can't generate a fever. And so they couldn't generate a fever with COVID, but they'd have altered mentation. So if you're dealing with an elderly individual who's having a bad day or two, seems to not be with it, what are they going to chalk it up to? They're 90 and they're having a bad day. Well, it's probably an infection that is now turning the patient septic and threatening their life. And that's what goes on with this stuff. So mentation cognition in the elderly is a major red flag. You definitely want to get labs on them. But any of this other stuff, right? You're not the paresthesia stuff, but weight change, nausea, vomiting, fevers, chills, fatigue, etc. All of those things you want to think about. And anytime we have a yes answer for these type of things, just to talk about it, how long have you had it, right? How long have you had it? So you're dealing with fatigue. How long have you had it? Is there an explanation for it that makes sense to you, right? And if there's not, right, is your physician aware of this? And if your physician is aware, has it become worse? because some of this stuff could be there, right? We have patients who have altered mentation cognition that we deal with all the time, but has it changed, right? We have patients who potentially have paresthesia for some reason, right? But has it changed? You know, there's other concerns with this as well. And the other part of this too is that, you know, we teach people how to do a review of systems, you know, so that general health checklist is up at the top. And then depending upon where the patient has symptoms, let's say they have symptoms in the upper quarter, we might want to look at a cardiovascular or a pulmonary screen, looking at symptoms to see if a patient has symptoms associated with those areas that could potentially be mimicking musculoskeletal disorders. So don't have time to go into this. I just did a course for Krista, Wyoming 2 days. This is all we talked about for 2 days. You're saying, man, it must have been a real ball of fun. But it was, because you can talk about these, there's case reports, and it helps you in your screening, right? Your screening to determine if patients are in the right spot. And so labs, I think, are important for PTs. I really do. Despite the negativity of some PTs, of you guys doing imaging and doing labs and stuff like that, look, bottom line is that it's hard for patients to get seen. You guys see a lot of patients that trust you, that tell you things, and it's difficult to get these patients off to see someone else to have these things done. So the bottom line is that it improves decision-making, and I think it improves the continuity of care that patients are going to receive. When we talk about lab values, we'll present normal values to you. Just, you know, note that when they do these labs and normals, this is probably 95% of the population's in that normal range. And you'll have a hard time sometimes knowing, right, if a patient's out of that normal range, what does that mean, right? And we'll give you some of those guidelines as well. Trends are unbelievably important, right? So you could have a patient who has a white blood cell count of 13, right? Normal should be around 10. What does that 13 mean? Well, if their normal for the past couple of years has been around a 7 or an 8, and now they're a 13, that's concerning. What if they were up at 18 a week ago, treated for an infection, now they're down to 13? You guys follow me? And so those trends are going to be important. And then the differential diagnosis and causes, it's beyond us, right? That's beyond us. That's where physicians are trained with this stuff right here. All the other stuff we talked about today, I don't know. That's tough. But this stuff, they're absolute experts in, right? And you want to get them off to physicians to get worked up. You may think one thing, physician thinks another. I'd say with their training in this stuff, I mean, there's no comparison, right, between the training they have for this. So let's first start with a complete blood count, CBC, basic CBC. Basic CBC includes white blood cells, red blood cells, and platelets. And so when you sometimes look at how these are written up, you'll see these diagrams put together. In the old days, when physicians would document in records, you'd see this. White blood cells are off on your left, hemoglobin on top, hematocrit on the bottom, and then platelets off on the right. So we'll go through each of these briefly, but we give you some indication as to why PT would be contraindicated, right? And so contraindicated for sure with hemoglobin and hematocrit, because that deals with red blood cells. And red blood cells do one thing, probably more, but the big thing is they carry oxygen. And so when you have low hemoglobin, low hematocrit, there are 3 organs that are going to be affected: the brain, the heart, and the kidneys. Those are the 3. And so you could have symptoms related to any of those. And so if those numbers are present, you have to be concerned about that. Then platelets, the risk there is for bleeds, right? And so if they're down below that level of 5,000, you don't want to do PT for those folks, right? Because they're at risk for a spontaneous bleed. So let's kind of work our way through some of these here real quick. So white blood cells, you guys know these are immune cells. Leukocytosis would mean there's an elevation in white blood cell count. And in that particular case, there's a bunch of different reasons for it, right? Inflammatory conditions, infections, cancers, or even trauma, stress, or intense exercise can bump that white blood cell count. A low white blood cell count could be due to a couple different things. These blood cells come from a couple different areas. One's the marrow, right? So if you have bone marrow failure, maybe due to an infection, right? You could see low white blood cells. Liver and spleen are also involved in this as well. Autoimmune disorders, and certainly radiation or chemotherapy. The one thing I'll say in the differential is that these white blood cells become mobilized when there's concern for an infection. Lots of different reasons you can have infection. So you'll commonly see CBC with differential. And the differential relates to these different types of white blood cells here. And I've listed them in the order of how they're most prevalent in the blood, right? So you'll see probably around 40% of white blood cells being neutrophils. You'll probably see maybe about 15, 20% lymphocytes, and the rest will be those other ones down there at the bottom. And the two biggies are going to be your neutrophils and your lymphocytes. So neutrophils fight bacterial infections, right? That's what you're going to see with that. Lymphocytes fight viral infections and unfortunately cancer. Monocytes will be elevated with any type of pathogen, right? Any type of pathogen, and eosinophils and basophils are going to be there as well. But these help the physician, right, understand if there's an elevated white blood cell count. The differential helps them to see if one particular cell is involved, right? What should I possibly be thinking in terms of treatment and differential? Red blood cells, easy Stevie here. These biconcave discs carry oxygen and hemoglobin, right? And hemoglobin transports oxygen. And hematocrit is when they spin these red blood cells down in a centrifuge, the percentage of the concentration of red blood cells in that blood that they're spinning down, right? Normal ratio is about 1 to 3, and men have higher values than women. We'll talk about elevated hematocrit first. So why would you see more red blood cells? Polycythemia is just the body making more red blood cells, and the risk for that would be blood clots. There's a whole bunch of secondary reasons as well. And most of these, the hemo concentration there, so if you're dehydrated or vomiting, or you're dealing with issues with burn patients, they're going to be dehydrated. You're going to see an increase in hematocrit there. The other ones are adaptations, right? Adaptations to it. So if you're dealing with a smoker, you're dealing with folks who are extreme physical exercise, folks living at high altitude where the air is kind of thin, right? The body is responding by making more red blood cells, right, to compensate for that lack of oxygen that these patients have. Decreased hemoglobin hematocrit, hemorrhage, right? That's going to be the primary reason for that. So it could potentially be trauma, peptic ulcer disease, put excessive menstruation down there as well. And sometimes no one really knows why, right? There is no trauma, right? There is no bleed. So now the anemia would be due to some type of chronic disease like cancer, infection, immune activation, etc. Okay. And then last is platelets. Platelets are the other component to this. So platelets are our primary response to bleeding, maintains vascular homeostasis, and sometimes we see patients who potentially have, right, these antiplatelet agents, because there's too many platelets, you can get clots, right? So Plavix is a really good example of that helps prevent vascular ischemic events and atherosclerosis, right? And again, the implication here is if they're low, risk of hemorrhage. And so the bottom line, why would you consider ordering a CBC? Now, you'd probably never get a CBC on its own, but why would you want to know about this? First and foremost, if you're dealing with patients who have those constitutional symptoms. So is everything okay? Yeah. So if you're dealing with patients who potentially have what? A fever, right? Potentially have some type of indication for an infection. And what are probably the two most common infections that we see? In the elderly, pneumonia, right? So they might have a cough, right? They may feel lousy. Urinary tract infection is another one, right? And so urinary tract infection, how's that going to present, right? We go through this whole urogenital screening checklist here. But again, I mean, that can be dangerous, right? And so we're dealing with probably painful urination, right? They could even have, depending upon how bad this is going up in the ureters into the kidneys, right? Pyelonephritis, that type of thing. And those are things that you want to get worked up fast, right? And so that's where I think, and you hear someone say, well, you're a PT, you're working up a urinary, yeah. I mean, they're here for another reason, but these things show up on an intake and you have to kind of deal with them. And
Mike,
so, yes,
UTIs in women over 50 is exceedingly high,
absolutely.
and it becomes dangerous and will kill.
I agree. And I don't have my pictures of the urethras up here, but I mean, you know, you only got that far for the bacteria to go. And then you're in trouble. Then you're in trouble. And again, I mean, you know, that's one of the ones that in the military we would always learn about when we learn these type of things. And so, because it can get backed up to the kidneys and cause all kinds of problems there. So UTIs, pneumonia, you know, COVID's still out there. You want to work these folks up and kind of see where they're at. That 5 to 11K there, we'll give you some examples of that. But like I said, when you start talking about things like infections, you'll be up around 15, 16. Things like cancer, stuff like that, you'll be up around 20 or 30 sometimes, right? What's that? Yeah. Yeah. And so I'd say anything out of that normal range, you want to get evaluated, right? Because especially when you start looking what the normals for these patients were. So let me give you an example here. 28-year-old woman, distance runner. So 14 days ago, question.
Sorry. How frequently? Some, I've seen patients come in with lab values within, you know, X amount of time. And talk about trends. How frequently do you think that they should be retested?
I probably, well, I'll say it this way. If I had we did labs in the military, when I would look for trends would be, and this is for probably a completely different discussion another day, but we would screen all of our patients for cardiovascular disease. So we had a form that we would complete that looked at all the risk factors for our patients. You know, and we might get a fellow who's 50 years old and he's a smoker. And I already told you about how our screening was in the military for physicals. It wasn't very good, but he's 50 years old and a smoker, right? So we want to quantify cardiovascular risk. What are other cardiovascular risk factors that I could run labs on to see how he's doing? Glucose for one, cholesterol for another, right? So we would run those labs. If those were normal, blood pressure was okay, there was no need to see his primary care physician for that type of stuff, right? So that's why we would do it. So trends for me, I'm not worried about monitoring infections because we have no business treating that. So when we talk about you guys ordering labs, it would be to determine at baseline when I'm seeing this patient with a clinical concern, let me get baseline labs and let me see where those are at. In my mind, it would be the physician to look at the trends. But I still think, let's say you're acute care PT, you should be able to look at those labs and determine how the patient's doing. I mean, at what point are you going to say, okay, I'm not going to see the patient because their hemoglobin hematocrit's low, right? They have orthostatic hypertension and they're passing out. They get a transfusion. Go back and look at the labs and see what the trend would be. It should bump up. And with the bump up, what should you see? The patient's now more alert, right? They're able to do a little bit more. So that makes sense in my mind. So I think the trends would come from you looking at the function of the patient and when those things are going to be indicated. I don't know if I answered your question. I think you got to be a little bit cautious with looking at trends for medical disorders, especially if you can't treat that, right? But you could look at what's going on out there and hopefully have some understanding of it, okay? So let me go through this case here. Yes. Question.
Is there anything that's not part of a standard lab checkup that you wish would be part of a routine checkup?
We're going to go through a ton of them. Yeah, so the CBC is just one part. So you'd always get a CBC and a basic metabolic panel as well. We'll talk about that in a second. So you'd always get probably those two together. And again, if you listen to these physicians, you know, they're not going to look at, it's just like we talked about. This is a data point. At one particular point in time, they're looking at the entire picture of the patient, right? So they're looking at a bunch of other things associated with this. 28-year-old woman, distance runner, partial medial meniscectomy 14 days ago. She was being treated in a knee class. And so they would do all these surgeries and then to try and save time for some of these patients, they would come into a class. This was visit number 2. There were like maybe 8 other people in this class. So when she came in like day 1, which was like maybe 5 days after surgery, She remember talking to us that she was, training for a 5K, and when could she get back to doing that? And, if I'm doing this much for my quadriceps, if I do this much more, will it get me better quicker? So she was really into it. This particular day, though, do you guys know what malaise is? Yeah, it's kind of, I got the blahs. It's kind of, that day or two before you actually get your really bad cold, how you wake up and you feel, and you're like, man, I'm just not feeling it today. And I feel like I'm getting sick, right? I haven't got sick, but I feel it. So she was kind of just down a little bit. And I remember talking to her, and she says, I just don't feel like myself. So her knee was hot and swollen. So this is what her knee looked like on that particular day, her right knee, right? And so you'd say, okay, I mean, I see a lot of scopes. There's some swelling there, a little bit of discoloration, and she was having increased pain. And so the question is, what do you do with that, right? Is it just a little bit of swelling that she needs to elevate her leg and we're going to wrap it? Or are we potentially concerned about something more? Okay. So I'll give you a little more information. So I would recommend that if you're concerned about an infection, you go ahead and take a temperature, right? And that might be something that's a little foreign to PTs, but take a temperature. And her, what we had here, she was afebrile. Pain wasn't that bad, but she was taking 800 milligrams of Motrin and Vicodin every 6 to 8 hours. Now, what do you know about Vicodin and Motrin and a fever? Yeah, if you've had little kids, you know that Tylenol, Motrin every 2 hours for a fever. Don't forget, Vicodin always has Tylenol in it with the opioid. And so whatever she's taking there could potentially be lowering her fever. So she doesn't have that. So we don't know if she has a fever or not, right? And so bottom line was that the pain she was having in her knee, red, swollen, didn't have that on day one, wound up getting some basic labs. White blood cell count was elevated, and that's a SED rate. We'll talk about that. It's just a general inflammatory measure, and it was kind of off the charts, right? General inflammatory measure. Now, I will tell you this, you need more than this to diagnose an intra-articular infection, so you actually have to aspirate the joint. You're not going to do that, right? But you're going to send them back to the surgeon. Surgeon's going to, aspirate the joint. And it was a staph infection inside of her knee. We've talked about these intra-articular infections a little bit already. These are dangerous things. And so I'm going to show you her x-rays. So this is only 2 weeks. So these are plain film radiographs of her knee, AP views of her knee, and a lateral view. On your right, on the image on your right is going to be her good leg. That's her left leg. And then you can look at the lateral view right here. And what do you note about her cortical margins in her bone? Especially here. What do you note here? And here. This looks a little bit fuzzy, doesn't it? Cortical bone should be sharp and distinct. And what that tells you already at this point is that articular cartilage is being eaten away by the infection, right? And again, these could be life-threatening conditions. And so her articular cartilage was already gone at this point. And so this was a 28-year-old. Yeah, 28-year-old wound up undergoing a total knee. And so, a little bit of a concerning case, but I think you guys get the point that in this particular case, with the potential pending infection, you'd want to go ahead and get labs and get that worked up quick. If you can't do them on your own, you have to get them to someone to get, evaluated fast. All right. So that's blood cells. Let's talk about this basic metabolic panel. And for the sake of time, we'll probably focus on sodium, potassium. We can't call it BUN. Blood urination, we'll call it BUN. Don't call it BUN. And then creatinine. Those are your kidney labs right here. And then glucose out here. Chloride and carbon dioxide are also important, but probably not as important as these other ones we're going to talk about. And so sodium, potassium are going to be key. Okay. So sodium Sodium probably isn't necessarily what you'd think the lab would be, like how much, salt am I taking into my diet? What this probably relates back to more is probably how your water levels are being managed, right? Your fluid levels are being managed. Because high sodium, hypernatremia, means that there's water loss, right? There's water loss, which elevates the potential appearance of sodium in the blood. And so why would we see that? We would see it in folks who are sick, acutely ill. So diarrhea, vomiting, or even polyuria, like we see in diabetes. And the symptoms are going to be agitation, restlessness. It's going to affect the brain, right? So it's going to affect the brain, right? It's going to affect the kidneys. And so you're going to see symptoms associated with that. Hyponatremia is kind of interesting because this is low sodium due to overhydration, right? And this can be concerning as well, right? But we see fluid replacement following illness potentially. And again, it's going to affect the brain. Think about those sodium potassium pumps work in muscle, they work in the brain, but these are folks who are going to have fatigue, possibly even confusion and weakness. And those are folks that you want to make sure you get worked up. Potassium is a really, really important one because potassium deals with muscle, right? And we think about skeletal muscle, but cardiac muscle as well. So either too little or too much sodium outside that normal value can cause all kinds of troubles with the heart, right? All kinds of trouble with the heart. An increase in serum potassium, we typically see that with some malignancies and trauma, where we see potassium moving from the intra to extracellular compartment. And then a decrease in serum potassium is usually due again to sickness, vomiting, diarrhea, diuretic usage. Leg cramps certainly could be a manifestation of this. But again, we want to look at that normal value. If they're outside of that normal value, we don't want to do PT. The value is between about 3.2 and 5.1. If it's too low or too high, you're at risk for these dangerous arrhythmias and other concerns associated with it. And so be real cautious with potassium levels. But again, these are folks that are going to have probably constitutional symptoms associated with this as well. Let's talk about the kidneys real quick. Two labs here for the kidneys. Blood urea nitrogen. So what this really relates to is how, when you take in protein, how it's broken down and how well the kidneys can excrete it. It increases if the kidneys are failing or in terms of dehydration. And then creatinine is a measure of muscle metabolism, right? Muscles are always turning over. And so in this particular case, this is excreted by the kidneys, right? And if the kidneys are failing again, you're going to see an increase, right, in the creatinine in the kidneys. And so a doubling of that, right? So if you go up to say maybe like 2.5 to 3, right, you're talking about 50% reduction in kidney function with that. So that's a good lab to know about. So kidneys are important. And we'll probably bypass this for the time being. Question? Yes.
Potassium and sodium. So one of the patients population that we see quite a bit more nowadays is the POTS patients with post-COVID and before. And some of those patients getting, just a heads up, some of those patients getting IV therapy as part of the treatment for POTS.
Yes.
And the problem that I noticed in our population is that they don't always monitor
Yes.
electrolytes. So what end up happening, they supplement them but they don't supplement the potassium level because they just give them the sodium. So they start having palpitations, which is similar to POTS, but they end up having hypokalemia. So those are the patients that we really need to be on top of monitoring the labs, whether it's us doing it
Agree.
or whoever else is. So anyway.
Agree. Yeah. And you're going to have, again, that cardiovascular checklist. In that type of patient, you're probably going to have palpitations. You could potentially have chest pain. You could potentially have fatigue. And so any of those things being present, those would be labs that you'd probably want to get, right? And that's very interesting scenario because fluid replacement is really tricky, right? And you start playing around with these electrolytes, that gets tricky. And I would agree with you. It's not always monitored, even in the acute care setting, to look at that. Because if you give too much or too little, and it's not being monitored, right, you can actually affect these to a great extent. Let me mention one thing. Are you guys allowed, I don't know your practice act, are you allowed to make recommendations on medications? You can't prescribe, but you're allowed to make recommendations on meds? We're not allowed to in New York State, which makes no sense to me. I mean, we can have a patient who, whatever, I don't know how medically literate they are, but they can wander into a drugstore, Walgreens, Walmart, and they can buy off the shelf, what, Motrin, Tylenol, proton pump inhibitors, H2 antagonists that treat their stomach pain, but PTs that have, gone through the 20th grade or whatever we go through. Now, I mean, they can't educate somebody on Motrin or Tylenol. Bottom line, though, is that, the kidneys and the nonsteroidals don't work well together, right? Meaning if you're taking these nonsteroidals in excess, you can get renal deterioration. It can also cause GI bleeds. And so I'd be very, very careful with that. So any patients who do have, these labs related to the kidney, BUN and creatinine that are not within those normal limits, these are patients that should not be taking nonsteroidal anti-inflammatory drugs at all. Just want to mention a couple things real quick about glucose. Okay, so we've talked about this a little bit already. This is a chart that looks at the number of deaths due to these chronic diseases or any disease at all. And you can see diabetes kind of on there, heart disease is on there as well. Diabetes has been around for a long time. It's getting worse over time. And I would ask you, I talked about this earlier, these costs of these disorders. This was 2013 before musculoskeletal conditions overtook diabetes as the primary cost of care. So we spend an awful lot of money on this, and it continues to get worse. And if I asked you guys, why are diabetes getting worse? I'll just say the majority of you guys would say that patients aren't taking care of themselves the way that they should. And that might be the case. However, anytime I have a bad interaction with the patient where the patient doesn't do as well as I was hoping, I've stopped kind of blaming them, because this is the deal. I don't have any problems with patients anymore. If I ask them to do a home exercise program, I want them to be completely honest. I need you to do like 2 exercises a day. Can you do them? And if they tell me you need to be honest. If I'll try, but I don't know if I can. All right. Because if they're telling me up front that they don't know if they can do them when they come back and they're not better, they're not doing their exercise, I'm not blaming them. I'm blaming me because I gave them too much. And so if you ask up front, there should be no concern with that, right? Same thing with this. We blame patients, right? Your hemoglobin A1C is in low double digits, right? You're starting to go blind. Your hands and feet are tingling. It's your fault. I'm just going to show you something here. So hyperglycemia, why do we want to prevent it? Because it occludes the lumen, right? If you look at that picture there on the left, right, that's the vascular wall. In out of control diabetes on the right, that's what this looks like. So the vascular wall occludes, and sugar, very scientific here, is sticky. So all that fat that's cruising through the bloodstream binds to this and occludes the lumen, right? And that's what causes this microvascular disease, where kidneys, eyes, and nerves, right? Those are the 3 organs that get affected most. And so this paper was published in 2020 about the wonderful role that you guys can play in fighting the diabetic epidemic. A little before that, though, this paper kind of came out here. So this was interesting. This came out a few years back. And so these are physicians from Johns Hopkins. So if you're not familiar with that group, that's probably maybe, depending upon who you read, maybe one of the hospitals probably in the top 3 for care in this country. And this was a internal medicine conference that these physicians were at. And they gave them this little survey that asked them to tell us about diabetic risk factors, what lab tests you would do to evaluate for diabetes, what numbers on those lab tests would you be concerned about, et cetera, et cetera. Again, Johns Hopkins, only 6% could correctly identify all of the risk factors, and they were listed out. Only 17% correctly identified fasting glucose and hemoglobin A1C as the appropriate lab test for diagnosing diabetes. So think about that now. And then we're not even going to get into how much weight loss should they have, right? How much should they exercise? what type of medications. So this was not a good news story here. So all I'm saying, now, why are risk factors important? We could get into a discussion here, but the risk factors tell you who should be screened, right? If somebody has risk factors, those are the folks that should be screened. So we see those numbers out of control. I don't know if we're always doing what we should be doing. So you'd say, well, how did PTs do with this? And so we looked at that. We looked at PTs, and you guys didn't really do much better. Only 3% could identify all the risk factors. 73% knew what the lab test should be, but less than 10% knew the correct parameters. And then the bad part here is that only 2% knew what the weight loss recommendation should be, and only 22% knew what the physical activity recommendation should be. So we wanted to publish this paper in JOSPT, and so this was in there at the same time. And I just said, I don't even know if we know what the risk factors are. And you want us taking on the whole damn epidemic? We don't even know how much weight loss they should have, and we don't even know how much they should exercise. Yet you want us taking on the whole epidemic. Well, yours was probably a flawed study. And then I said, what about the Hopkins study? So all I'm saying is, when patients aren't doing well, I already told you this, I think there's a best way to manage patients. Is there anything that you may have done better? And I think this, to me, showed a huge knowledge gap in terms of basic stuff. And so we're going to tell you about this. We talk about glucose as part of that basic metabolic panel, but these are the risk factors. So why would you want to screen someone's glucose levels? Well, if they have these things, right? And you should know them, because you're going to see patients who don't have primary care physicians, right? And they're not being worked up, and they should be, right? So if they have risk factors, work them up for it, right? These are the numbers they should have. So a fasting plasma glucose is probably best versus non-fasting. So if they have a big giant meal that has a lot of sugar in it, their blood sugar is going to be elevated. So fasting is probably helpful. The 2-hour oral glucose tolerance test is good too, because it tells you how you process it. But the gold standard for diabetes is going to be hemoglobin A1C. Average life of a red blood cell, about 120 days. Sugar, I told you, binds to blood, right? Binds to blood. And so we know glycolated hemoglobin, we know those numbers. And so you could have someone who's probably pretty good for a week and their fasting glucose looks good, but their hemoglobin A1C is elevated. And I'm going to tell you, anything above an 8, that's danger zone for these folks. You're talking about vascular disease that's probably unrecoverable. And so well-controlled patients should be less than 7, probably between 6.5 and 7. You don't want to get them back into that normal range, okay? And so,
Mike?
What's that?
The highest level of diabetes in a geographical area in the United States of America is Arizona.
Really?
Yes.
I wouldn't
And-
think that.
Yes, it is. And it's been traced, they believe, with things happening to the Native Americans. And it was brought by using lard as a preservative and then cooking with it.
Huh.
And the highest level in Arizona is 40 miles from here, Gila River, Arizona.
Really?
Yes.
Amputee rate, Mike.
Microphones.
I worked on that reservation for 5 years, and we had the highest amputee rate. When I got down there in about 89, and they were losing limbs.
Oh, boy.
And the Pumas they were most studied forever.
Yeah.
They could look at a Snickers bar and
Yeah.
and their glucoses were running 600.
The Gila River Indian Reservation has 10 diabetes centers for what?
Treatment.
for the kidney disease for dialysis.
Yeah. Are they managed through the national or the public health system?
Yes. Indian Health.
Do your yeah. That's troublesome. So I think, I think that this is a lab that probably has some utility for you guys, especially in patients who are, out of control diabetics. The weight loss recommendations from the American Diabetic Association, you guys should know this, 5 to 7%. I wouldn't worry about trying to counsel. Can you guys counsel on diet in the state? In New York State actually added to the Practice Act, but this is one group that I wouldn't monkey around with. I mean, there's dietitians who know this stuff 100 times better than we do and what diets they should be on, right? So, get them to those folks. And then physical activity, 150 minutes a week, right, would be the goal for these folks. And they'll listen to you guys. And, they likely have other disorders in the musculoskeletal system that limits their ability to do this. And so I think that you guys can probably help them with that. But that's the bottom line with that, right? And so we don't need to go through all this stuff here, but these are some of the other cardinal signs of diabetes, that a patient could have with relation to symptoms. So polyuria is one, right? So we're losing, glucose, right? And you have to lose water, right? Glucose can't be reabsorbed into the cells. And so you have to have water to balance that out. So you get a lot of water that's lost through the kidneys. That's going to cause polydipsia or thirst, right? We could have blurred vision, weakness, and fatigue. Why? Because all of a sudden, we can't burn glucose as an energy source. So we start to burn fat, start to burn protein. You can possibly see ketones in the urine, right? Because we're breaking down fat. So this is not the good keto either, right? This is not like the carnivore keto where I want to see ketone bodies in my urine, I'm in the Atkins diet, whatever. This is the bad keto. That's not supposed to happen this way for these folks. And that's asymptomatic as well. It's a gradual adaptation, this insulin resistance over time. And the blood loss or the blood glucose, the rise in blood glucose is gradual. So you want to be concerned about that. And so again, that glucose out there on the side, that's just that routine measure that's included in this. Those other labs, you'd have to order special, but anything less than 60 or more than 300, especially in an acute care setting, you wouldn't want to do PT with those folks. Questions on that at all? All right, two other important electrolytes, uric acid. Uric acid's related to purine metabolism. We're joking about this before, but uric acid is going to come from the breakdown of purines, and you see purines is high in meats, fish like anchovies, sardines, things like that. And the problem with gout is that if you look at what these gout crystals look like, they're these little spears up here. And so it's those little spears, right, that are jamming into the joint, right? And that's what's causing that. And so what joints are affected the most? The big toe's affected a lot. Knee can be affected. And these are extremely painful conditions these patients are struggling with. Has anybody seen patients with gout? Go and use the mic. The microphone.
When you do them on ultrasound, gout, the first time I ever saw them was they're like little crystals. It's
Yeah.
like, and so it's the fluids in there, and they sparkle. Put the Doppler on there, and they sparkle. So and then you usually will take I'll go and get a lab
Yeah.
sample, and that'll show that spirit. That's what it looks
Yeah.
like under.
Yeah. Yeah. And you'll get, gouty arthritis associated with this because it's breaking down the articular cartilage. And so that's a concern. It can also cause renal failure as well. Yes, sir.
Beside the dietary intake, I think one of the questions we need to ask when somebody come in with joint pain that we suspect gout
Yeah.
is polypharmacy.
Yep.
So because you see patients on cholesterol medications, other things that could be associated. So you need to. I think that's another reason why to check uric acid levels is to assess whether some of the medications are interacting.
It's a good point.
because of this.
Yeah. And that's not even something we can even get into today, but the whole polypharmacy issue, how that can affect this and what's in the differential for gout, right? They're going to come in with swollen, hot joints, infection, right? So infection is going to be in the differential for these folks, but their white blood cell count won't be elevated, right? You won't see any change in their electrolytes. All you're likely going to see is an increase in their uric acid. And that little picture right here, I had to look it up today at lunch, but this is by a caricaturist from 1799 named James Gilroy. And that was his thought of the gout. So this was in England in the late 1700s, when I guess roast beef and stout beer was all these people were eating. And so gout was out of control back then. So that's what this looked like with the spiked tail shooting flames out his nose. Extremely painful condition, though. And then we'll talk about calcium. I think we'll go ahead and take a little bit of a break. But calcium is one of these labs that's very interesting because it's controlled by the parathyroid glands, and there's not many things that excite physicians outside of elevated calcium. Elevated calcium means bone is being broken down for some reason. It's either the parathyroids aren't functioning or there's something going on with the bone. And hypercalcemia, unless the parathyroids aren't functioning normal, could be related to cancer in the bone, right? So when you start seeing elevated calcium levels, you have to be concerned about either primary bone cancer or metastatic bone disease. Hyperparathyroidism as well, where bones are being demineralized and we're leaching calcium out into the bloodstream, right? And I was going to talk about this particular case here, but I think we're going to go ahead and bypass it and get back into the labs. And if I have time, I'll go through that. But let's go ahead and take our last break. Let's go ahead and come back. Let's go bottom of the hour, 3:30. We'll come back and we'll finish up. All right, let's go ahead and get started back up. Let's go ahead and get started back up. All right, so a couple points came up at the break, a couple people asking me some questions, good questions as well. And so again, for these, if you're concerned about, let me go through this here. So let's just talk about the gout thing. So someone comes in and they got a hot swollen knee. There's no trauma. You're not exactly sure what's going on, but they're in a great deal of pain. You'd still get your white blood cell, red blood cells, platelets, etc. You get your basic metabolic panel, but if the differential is concerning for you for gout, you add a uric acid lab onto it. You guys okay with that? And so many of you are going to have ordering, templates in your computer through EMR that you can do that with. And if you're not sure, just talk to the records folks on how to do that, and maybe get a little in-service in your department so you can see how to do that once you guys get the privilege. But the bottom line with these labs are that you want to get these in folks who have those constitutional symptoms. So fatigue, unexplained, weight loss, fatigue, fevers, chills, that type of thing, change in mentation for sure. You want to get these labs, complete blood count, and this basic metabolic panel. And you want to make sure that if necessary, you want to include these labs as well. And there's other ones that we'll talk about, but I am going to present this case. We didn't talk about thoracic spine at all. I'll show you a little thoracic spine imaging here. So this is a 55-year-old man who's a computer salesman. He came to see us after he's having problems with mid-back pain for the past month, and the onset occurred after jogging. He was going for a jog to try and relieve stress. He had a teenage daughter who was pregnant and trouble with his ex-wife, and so he's going for a jog, trying to relieve some stress, not something that he normally does, and he developed this really, really bad back pain. So he still has a CV, right? Constant varying ache, and it was intermittent, sharp, right? And the sharpness varied. He'd seen the physician twice over the course of his past 4 weeks, and he was taking Flexerol, Vicodin, and Motrin for the pain, and it really wasn't helping. And his physical examination findings, I knew he was in trouble just from the moment I saw him. This was actually at Travis Air Force Base, so he's out in the waiting room, and he's sitting in that little area, and he stands up, and he couldn't even stand. He just wandered his way back, right, to our little evaluation area. And, I couldn't even lay him down. So everything we did was really in sitting. Resting pain, he said, was 5 out of 10. It's there all the time. No movement at all, right, for his thoracic spine. Then he was tentative palpation through the T8, T9, T10 areas. Neuro exam was normal. And if nothing else, you can always palpate and you can always do a good neuro exam, right? But the palpation was concerning because he was very painful in that area. So the question comes up, well, what do you do with this, right? A guy his age goes for a jog, right? And he gets a severe onset of back pain, and it's not getting better over the course of a month, despite the fact he's seen a physician twice being treated with meds. He's resting. I think you got to look at it at some point. The other kicker to this was that I would recommend that for all of your patients, that you look at imaging that's done previously and see if there's anything there that can inform what you're doing now, right? Because when I look back, I saw him like right after lunch. And so when I remember looking at his past history over lunch, he had a pre-employment chest x-ray a few years earlier that was normal for the lungs because he was a smoker, but he had an age indeterminate stress fracture at what they thought might have been like T10. And so he already had one a few years back. So I asked him, I said, are the symptoms you're having right now anything that you felt like before? And he goes, I don't really think so. I said, well, what about a few years ago? Did you have pain then? And he goes, now that you mentioned it, I did. It was similar. It lasted a couple of months, but then it went away. And so these are his x-rays here. And so you'd say they're kind of hard to interpret, kind of look at, right? And so these would be lateral views of the thoracic spine here. And what I want you to appreciate is that a normal vertebral body on a lateral view, you guys already know this, should be square, right? Square. And I'm blowing up this area right here. So this vertebral body here is here. What do you notice about this vertebral body and this vertebral body? They're not square. They're wedged. Wedged. I don't think I need the H in there, but they are wedged. We have two in a row here that are wedged, right? And we go back to having a squared off vertebral body right here. So the bottom line is that we already know he had one compression fracture, right? Now he appears to have a second one, right, on this one. So at Travis Air Force Base with a wonderful radiology staff, they were doing a trial on a thing called vertebroplasty. Do folks know what that is, vertebroplasty? Yeah, so you stick a needle into the vertebral body and you inject medical grade cement into it and it stabilizes the fracture, okay? Stabilize the fracture. So I knew the trial was going on and they were recruiting patients for this. So when I ran it by one of the radiologists who was doing the study, he said, you got two fractures there right in a row. He goes, are they both current? Are they both recent fractures? And I'm like, I have no idea. So how would we determine if one of those is more current than the other? What do you think? What's that? We did, but all he had is just an AP of his chest. So we're not exactly sure which one it was. There you go. Something with contrast. We don't necessarily need to do contrast. We could do an MRI though, because an MRI is going to show what? Remember we talked about T2? If an area has an acute injury, remember that fellow with the Sagone fracture? It's going to light up, right? And so that is a T2 weighted MRI, right? And there's other reasons to probably do an MRI too, because those compression fractures are dangerous because those fractures can retropulse into the canal and possibly cause bony compression onto the cord. So I think that was like T10, right? T10, this fracture right here is this one right here, and that's the one that lights up. Okay, that's the one that lights up. So the treatment is you put the needle into the vertebral body and you inject fluid in, or you inject the medical grade cement into it. And I remember seeing him like on a Thursday. He had the procedure done on a Friday. I had to grind inpatients. They still doing inpatients there in 2018 at Travis? Yeah, I had to grind inpatients on the weekend. So I said, well, why don't you come in about 9 o'clock and I'll buy you breakfast. I just want to see how you're doing. And I couldn't believe it. It was like a completely new guy, right? He goes, I'm essentially like 90% better because whatever they did, I feel great. So I'm like, well, that's really good. But I'm going to tell you something. What do you notice about these x-rays on him? He's very kyphotic, isn't he? So he's very kyphotic. The other thing that didn't sit well with me is his bone density looks diminished, doesn't it? And so we did a bone mineral density test on him, and he was osteoporotic at, was he 55? Osteoporotic at 55. His mom and his grandmother both had severe osteoporosis, and he was a smoker. And that can have a little bit of a genetic line, but it never really sat well with me. And so I kind of kept in close contact with him, and he was doing okay. And then, you know, he wound up seeing, for whatever reason, his primary care physician didn't like this either because he was on a couple of these medications to treat his bone density and it wasn't working. So he ran labs on him. And these are the labs that they ran. Okay, so alk phosphatase was one of the labs. It's actually run is a kidney lab, or I'm sorry, a liver lab. I'll talk about that in a second, but it's also a byproduct of bone. And I mentioned calcium. That's where this relates. And the calcium really piqued their interest, and that SED rate is up, right? So the SED rate, I'll talk about that in a second too. It's a general inflammatory marker. It's elevated. And so what would cause bone to be breaking down in this fella? Begins with a C and ends with an R. Cancer. It was cancer. So he had multiple myeloma, which is a cancer of a specific type of cell, plasma cells. And those plasma cells, if they're immature, they hang out in the bone, right? That's where they're produced. And that's what created all of the problems associated with his back, right? So he had this low-grade multiple myeloma, and that's what was causing all the osteopenia in his back. So that was a case that we published a while back. But the bottom line was that it took almost 2 years to figure out what was going on with him. But like I said, the calcium level was what really piqued their interest. The one thing I will mention about this vertebroplasty, I don't think it's done as much anymore as it once was, but I just want to talk about this. And this is a complete aside, but this study just blew me away because literally this guy was like 90% better the day after he had that procedure, right? And it makes sense, right? You got a fracture. You're moving around, bones are moving around. If we stabilize the bones, it's like a cast, right? I feel better, right? So this study looked at patients who had compression fractures again, and one group got vertebroplasty, the other group got the sham. Now, this study was done, I want to say it was done in England. And there are different parts of the world that look at placebo different than we do, right? But placebo is absolutely real. So one group got vertebroplasty, the real vertebroplasty, the other group got the sham. So the sham would be you take the patient to the interventional radiology suite, right? You lay them sideline, you flex them a little bit, and you let them know that, okay, we're going to anesthetize you. So they give them a little topical anesthesia. They take the back end of a reflex hammer and say, okay, we're going to be poking this into you now. You should feel a little pressure, right? That's the pressure. And then they open up the medical grade cement, which smells like model airplane glue, if you know what that smell is. So here we go. We're injecting it into you now, and that's the pressure. So that was the sham procedure. I'm just going to tell you. So they found, now all the patients did better. And they found no difference in outcome at 1 week, 1 month, 3 months, or 6 months after treatment. Now I could see the 3 or 6 months, but no difference at 1 week. These were acute compression fractures. These are patients who got the sham who said, I'm feeling great. What? How are you feeling great? You didn't get anything done. You still got the fracture. Just think about the power of the mind. Now, and this would say, well, it's just a placebo, but that is a very elaborate placebo, isn't it? Like almost like BS in the patient, taking you in, here you go, you got it done. How are you feeling? I'm feeling great already, because you should feel better. The power of the mind. Unbelievable. So I don't know what to tell you about that. What's that? Australia? Was it Australia? Yeah. But they love the power of placebo in some of those countries, and they use it, right?
Mike, I can tell you he's 84 now. My 81-year-old dad went through that, and it was magic.
Oh, I thought this was the greatest thing since sliced bread. Because in that case, you had the 2 wedge fractures because, asked the radiologist, well, can't you just stick a needle in both of them? He said, not really, because now you have like 2 little concrete blocks that you got bone fulcruming over. And so we'd rather have the bone there. But yeah, I mean, it was a really interesting, like I said, the cafe, they had good food back when I was there, like really good food. And I said, come on, and they got good breakfast on a Saturday morning. I'll buy it. And it's doing great. I mean, I'm like, this is 24 hours after the procedure. And so I just thought that was really interesting. So the other thing is that with those labs that we talked about, let's talk about that glucose lab. And so if you were just going to measure glucose, you would probably get that as part of that comprehensive metabolic panel. But you could, let's say you wanted to monitor somebody who is diabetic, and that hemoglobin A1C and the fasting blood glucose, you could just get those separate of anything else, right? So you get those separate of anything else. And that would allow you to track diabetes. Liver function tests, there's 5 of them here. So these are transaminases here that, if the liver is affected, are going to spill out into the blood. I mentioned alkaline phosphatase as being a bone lab. It's also a lab that's indicative of liver function. And then bilirubin and albumin. Bilirubin would be when hemoglobin breaks down, right? That would be the yellowing that you potentially see in someone who's jaundiced. Bilirubin levels would be up. And then albumin's a component of blood, right? Component of blood that's made in the liver as well. So those are your liver function tests. Now think about why you might want to do this. This could be a patient, like I said, I just taught this course in Wyoming to the same group that Krista runs up there, that you guys are here. We talked about abdominal palpation, right upper quadrant type pain. Patient has right upper quadrant type pain. You go ahead and stick your fingers up in there. You reproduce the patient's primary pain complaint. What organ's there? Well, gallbladder and then liver, right? And gallbladder, you guys know, is important in the digestion of fats. And so you'd ask them about their dietary habits a bit. When does this come on? But it could also be the liver as well. So I'd probably say you do the CBC, the comprehensive basic metabolic panel, and throw a liver function test in there too, to determine what's kind of going on there, just to give the physician a little bit of a lead as to what's going on. So why would these things all be elevated, right? Certainly if the liver's inflamed or those cells are being destroyed, they're going to release those transaminases. There's lots of different reasons that can happen. The other big one there is Tylenol, right? Tylenol is metabolized by the liver. NSAIDs are too, but they're more primarily metabolized through the kidneys, but Tylenol can cause it as well. And then some of those other medications, I think some of the statins are metabolized through the liver. And then some of those medications like glucophage and metformin, which are still used for diabetes, are metabolized through the liver. And so bottom line here, patients with any kind of liver disease should probably not use Tylenol. And don't forget, Vicodin has Tylenol in it too. So that could be a concern. And this was an interesting study done looking at 4 grams of acetaminophen daily and what it does to these liver labs. So they looked at one specific transaminase. The graph up at the top shows placebo, and those are all individual patient lines. The acetaminophen is the second one down, and I'm not sure, that's 1,000 milligrams of Tylenol 4 times a day. I think that's probably the max dose you can probably do. And then the acetamin plus the opioid at the bottom was even worse, right? So you can look at how those transaminases go up. They come back down over time, right? But normal is between 30 and 50. And these patients on average were up around 100, right, with that. And some of them were really spiked up too. So you do these labs, they could definitely be elevated. It's not your job to figure out what the reason is, but that could be a concern. So we'll go through in our remainder time here, we'll go through a couple of these other labs here. Thyroid, CPK will give you that little more context. These 2 labs, erythrocyte, ESR, sedimentation rate, and C-reactive protein, that are measures of general inflammatory processes in the body. And then HLA-B27, you guys know what that one's for? Ankylosing spondylitis, right, which was one of our seronegative spondyloarthropathies. And then anti-nuclear antibody and RA factor. Those would be for these patients that, remember we talked about low back pain, where inflammatory disorders could potentially be a cause of their pain. Those are 2 good labs that you can look up for that. So these would be patients you're evaluating. They're not necessarily musculoskeletal in nature, and you're concerned about some type of an inflammatory process. Those would be labs that you'd want to get. So we'll go through these here. So the thyroid, all I can tell you is that I think Buffalo's the thyroid capital of the world. And I don't know why, and more women, but every middle-aged woman I see either has had hypo or hyperthyroid, and they're taking hormone replacement for it and things like that. But this is a really, really challenging condition to diagnose. And the bottom line is that the thyroid drives all metabolism in the body, right? It's like the engine in a car. And that thing can either be ramped up or it could be really, really sluggish, right? And either way, it's going to cause a cascade of symptoms that you'd probably be aware of. So the bottom line here is that there's two labs that you want to think about. The first one is TSH. So that's driven by the pituitary gland. TSH then stimulates the thyroid to release thyroxine or T4, right, which then circles back and tells the pituitary, we got enough. Let's tone things down a little bit. Okay. Sometimes, though, that kind of goes awry. So in hypothyroidism, think about this, there's elevated TSH and decreased T4. Why? The pituitary's spitting out thyroid stimulating hormone, but the thyroid's not responding. Okay. So to respond, the pituitary continues to spit out more TSH, and you just don't get those levels of T4. So in this particular case, everything is kind of slowed from a metabolic perspective. Things are slowed. So there's fatigue, maybe some forgetfulness, mild sensitivity to cold, mild weight gain, right? Mild weight gain. Remember when I was at Kaiser in V-Town, which is an interesting place, saw a patient that was about 350 pounds. And she said, it's because of my thyroid. I remember talking to internal medicine doctors. He said, look, he said, this weight gain is probably subtle, maybe 5%. But someone who's up to 350 pounds, that's probably due to something other than thyroid. Okay. So it's a subtle weight gain, probably 5, maybe 10% max. Okay. You can get muscle weakness, carpal tunnel syndrome, constipation, dry skin, because everything's shutting down. And treatment for this would be replacement, right? Hormone replacement. Hyperthyroid, a little bit different here. So it's decreased TSH because the pituitary secretes a little bit of TSH and the thyroid responds big time, right? So T4 is up, TSH is down, right? So what are we going to see here? Just the opposite. We're going to see people who have cold or heat intolerance, so they're sweating in a room that is comfortably cool like this. There could be weight loss again, maybe 5–10%, hyperreflexia, tachycardia, and even hypertension associated with this. And so that's thyroid, right? Very difficult to diagnose and treat. And again, you know, when we think about pain patterns, pain we ask about a lot with patients, and sometimes we get inconsistent pain patterns. What do I mean by that? Right? You're seeing a patient day one, they have shoulder and neck pain, right? They come back on day two, my shoulder and neck pain's still there, but now my knee hurts, right? And then the knee goes away and now my back hurts, right? And now my neck's better, but now my knee's hurting again, right? So there's inconsistent pain patterns that we're not sure why. In the elderly especially, that could be a concern for depression, right? That could be a pain manifestation that comes out of that. Endocrine can definitely cause that. Neurologic disorders can cause it, certainly rheumatic, and then we mentioned adverse drug reactions. But, you know, you get that kind of a pain pattern presentation, endocrine is one system you want to think about. CPK used to kind of be a lab that we would kind of look at for different things, but this is a measure of injury to muscle, can be striated muscle, cardiac muscle. It's been kind of replaced by troponin as the lab of choice for cardiac concerns. But the one I want to mention down there, and I had a case that I put in here. I don't know why, I don't know if I included it or not, but rhabdomyolysis. Do you guys know what that is? Yeah, so that's an important lab. And so that's an important condition. So this is a condition that can be caused by a couple of different things. And in young people, we see it. We'd see it at the Air Force Academy a lot, especially around times when the freshmen got hazed, because the hazing would happen like at 4 o'clock on a Friday and would go the entire weekend. Thousands of push-ups, thousands of squats, hours of wall sits, you know, and they would just beat the crap out of these kids. And so, you know, muscles being broken down, it really presents almost as like delayed onset muscle soreness, but on steroids. And the primary finding that you're going to hear from them in the history is going to be urine that is dark colored, Coca-Cola or iced tea colored, right? That's going to be the key. And so if you hear that, and it could be something as someone checks on the intake, you know, change in urinary function, and that's it, this would be one of the labs that you'd want to get. You'd probably also want to get a basic metabolic panel because that can monkey up the kidneys, right? If you have all that muscle that's not being secreted and managed appropriately, it can cause kidney failure as well. And so rhabdo is important. And then we'll talk about cardiac again, and statins again can cause muscle breakdown too. And so that would be another reason to possibly take a look at this particular lab. Sed rate I'll just mention quickly. So sed rate and C-reactive protein, these are general, non-specific measures of inflammation. I think the C-reactive protein is probably more commonly used today, but where these are probably best used is to track disease over time. You guys familiar with temporal arteritis? You guys familiar with that? So that's where the temporal artery actually becomes inflamed. There's different reasons for that to happen, but the temporal artery actually becomes inflamed. And so you can palpate your temporal artery, like literally right in front of your ear. So everyone do that. That's like a little lab action right here. Can you palpate your temporal pulse there? You guys got that? If you press on your temporal artery, it shouldn't be painful, right? And you can follow it up all the way up to where you lose the pulse. But the bottom line with temporal arteritis is that